mortality than any other category of human disease, mortality than any other category of human disease. Although the most clinically significant lesions involve arteries, venous disorders are not inconsequential. Two principal mechanisms underlie vascular disease: narrowing stenosis or complete obstruction of vessel lumens, either progressively, for example, by atherosclerosis, or precipitously, for example, by thrombosis or embolism. Weakening of vessel walls, leading to dilation or rupture. To better appreciate the pathogenesis of vascular disorders, it is important to first understand the normal vessel structure and function. Vascular structure and function. The general architecture and cellular composition of blood vessels are comparable throughout the cardiovascular system. However, structural specializations that reflect distinct functional roles characterize specific kinds of vessels. Fig. 11.1. For example, arterial walls are thicker than corresponding veins at the same level of branching to accommodate pulsatile flow and higher blood pressures. Arterial wall thickness gradually diminishes as the vessels become smaller, but the ratio of wall thickness to lumen diameter increases, allowing these muscular vessels to exert control over blood flow and pressure. Many disorders of the vasculature affect only particular types of vessels and thus have characteristic anatomic distributions. Thus, atherosclerosis affects mainly elastic and muscular arteries, hypertension affects small muscular arteries and arterioles, and different varieties of vasculitis characteristically involve only vessels of a certain caliber. The basic constituents of the walls of blood vessels are endothelial cells X and smooth muscle cells SMCS, and mixed with a variety of extracellular matrix ECM including elastin, collagen, and glycosaminoglycans. The relative amount and configuration of the basic constituents differ along the vasculature owing to local adaptations to mechanical or metabolic needs. In arteries and veins, these constituents are organized into three concentric layers: intima, media, and adventitia, which are anatomically more distinct in the arteries. The intima normally consists of a single layer of ECs attached to a basement membrane with a thin underlying. 486 chap ER vessel 11's blood, low pressure, high pressure. Elastic artery, muscular artery, lumen aorta, adventitia, intima media large vein internal elastic lamina, medium vein muscular artery, intima lumen, media adventitia. Adventitia ventral arteriole, media intima pericyst blood pressure, control, post-capillary avenue capillary, endothelial cell intima media adventitia, gas and nutrient exchange. Figure 11.1 Regional specializations of the vasculature. Although the basic organization of the vasculature is constant, the thickness and composition of the various layers differs according to hemodynamic forces and tissue requirements. Thus, the aorta and other elastic arteries have substantial elastic tissue to accommodate high pulsatile forces, with the capacity to recoil and transmit energy into forward blood flow. These vessels have lamellar units that are comprised of repetitions of a layer of elastic fibers, a smooth muscle cell, and intervening extracellular matrix. Purely muscular arteries have elastic fibers only at the intersection of the intima and media or media and adventitia. In comparison, the venous system has relatively poorly developed thinner medial layers that permit greater capacities, and the capillary wall permits ready diffusion of oxygen and nutrients because it is comprised only of an endothelial cell and sparse encircling pericytes. The different structure and functional attributes also influence the disorders that can affect the various parts of the vascular tree. Thus, loss of aortic elastic tissue will result in aneurysm, while stasis in a dilated venous bed can result in thrombosis. Layer of ECM. The intima is demarcated from the media by the internal elastic lamina. The media of elastic arteries, for example. The aorta are arranged in layers of lamellar units of elastin fibers and SMCs akin to tree rings. This high elastin content allows these vessels to expand during systole and recoil during diastole, functionally propelling blood toward the tissues. With aging and the loss of elasticity, the aorta and larger arteries become less compliant, besides transmitting higher pressures into distal tissues. The arteries of older individuals often become progressively tortuous and dilated ectatic. In muscular arteries, the media is composed predominantly of circumferentially oriented SMCs. Arteriolar SMC contraction vasoconstriction or relaxation vasodilation is regulated by inputs from the autonomic nervous system and local metabolic factors. Arterioles are the principal points of physiologic resistance to blood flow. Since the resistance to fluid flow is inversely proportional to the fourth power of the diameter, i.e., having the diameter increases resistance 16-fold, small decreases in the lumen size of arterioles. caused by structural changes or vasoconstriction can have profound effects on blood pressure. The adventitia lies external to the media and in many arteries is separated from the media by a well-defined external elastic lamina. The adventitia consists of loose connective tissue and can also contain nerve fibers. Diffusion of oxygen and nutrients from the lumen is adequate to sustain thin-walled vessels and the innermost SMCs of all vessels. In large and medium-sized vessels, however, small arterioles within the adventitia called vasa vasorum, literally, vessels of the vessels perfuse the outer half to 2/3 of the media. As already alluded to, arteries are divided into 3 types based on their size and structural features. 1 large or elastic arteries including the aorta, the major branches of the aorta innominate, subclavian, common carotid, and iliac, and pulmonary arteries, 2 medium-sized or muscular arteries comprising smaller branches of the aorta, for example, coronary and renal arteries, and 3 small arteries 2 mm in diameter and arterioles 20 to 100 mm in diameter within tissues and organs. Alexei Law S and V. Sir Odd Irigny 784. Capillaries are slightly smaller 5 mm than the diameter of a red blood cell 7 to 8 mm. They have an EC lining but no media, although variable numbers of pericytes. Cells that resemble SMCs typically lie just deep to the endothelium. Collectively, capillaries have a huge cross-sectional area and also have a relatively low flow rate. The combination of thin walls and slow flow makes capillaries ideally suited for the exchange of diffusible substances between blood and tissues. Because functionally useful oxygen diffusion is limited to a distance of only approximately 100 μ, the capillary network of most tissues is very rich. Tissues with high metabolic rates such as myocardium and brain have the highest density of capillaries. Blood from capillary beds flows into postcapillary venules and then sequentially through collecting venules and small, medium, and large veins. In most forms of inflammation, vascular leakage and leukocyte exudation occur preferentially from postcapillary venules. Chapter 3. Relative to arteries at the same level of branching, veins have larger diameters, larger lumens, and thinner and less well-organized walls. See Fig. 11.1. These structural features augment the capacitance of the venous side of the circulation, which on average contains about 2/3 of total blood volume. Reverse flow due to gravity is prevented in the extremities by venous valves. Lymphatics are thin-walled, endothelium-lined channels that drain lymph water, electrolytes, glucose, fat, proteins, and inflammatory cells from the interstitium of tissues, eventually reconnecting with the bloodstream via the thoracic duct. Lymphatics transport interstitial fluid and inflammatory cells from the periphery to lymph nodes, thereby facilitating antigen presentation and cell activation in the nodal tissues, and enabling continuous monitoring of peripheral tissues for infection. This can be a double-edged sword, however, as these channels can also disseminate disease by transporting microbes or tumor cells to distant sites. Key concepts: vascular structure and function. All vessels except capillaries share a general 3-layer architecture consisting of an endothelial-lined intima, surrounding smooth muscle media, and supportive adventitia. The SMCs and ECM of arteries, veins, and capillaries vary, according to hemodynamic demands, for example, pressure, pulsatility, and functional requirements. The specific composition of the vessel wall at any given site within the vascular tree influences the nature and consequences of pathologic injuries. Vascular anomalies. Although rarely symptomatic, anatomic variants of the usual vascular supply are important to recognize, as the failure to do so may lead to surgical complications and impede attempted therapeutic interventions, for example, placement of coronary artery stents. Among the other congenital vascular anomalies, 4 are particularly significant, although not necessarily common. Developmental or berry aneurysms occur in cerebral vessels. 1 ruptured. These can cause fatal intracerebral hemorrhage. Chapter 28. Arteriovenous fistulas are direct connections, usually small, between arteries and veins that bypass capillaries. They occur most commonly as developmental defects, but can also result from rupture of an arterial aneurysm into the adjacent vein, from penetrating injuries that pierce arteries and veins, or from inflammatory necrosis of adjacent vessels. Surgically generated arteriovenous fistulas provide vascular access for chronic hemodialysis. Like berry aneurysms, arteriovenous fistulas can rupture. Large or multiple arteriovenous fistulas become clinically significant by shedding blood from the arterial to the venous circulations, forcing the heart to pump additional volume and leading to high output cardiac failure. Fibromuscular dysplasia is a focal irregular thickening in medium and large muscular arteries including renal, carotid, splanchnic, and vertebral vessels. The cause is unknown. Segments of the vessel wall are focally thickened by a combination of medial and intimal hyperplasia and fibrosis, resulting in luminal stenosis. In the renal arteries, it can be a cause of renovascular hypertension. Chapter 20. Immediately adjacent vessel segments can have markedly attenuated medial angiography. The vessels are said to have a string of beads appearance leading to vascular outpouchings, aneurysms that can rupture. Anomalous coronary artery origin occurs from a developmental anomaly in which both coronary arteries arise over the same coronary cusp of the aortic valve. Although many of these anomalies are benign, when a coronary vessel passes between the aorta and pulmonary artery, it can be squeezed, for example, during exercise, limiting blood flow and resulting in sudden death. Vascular wall response to injury. The integrated functioning of ECs and SMCs impacts physiologic and pathophysiologic responses to hemodynamic and biochemical stimuli. Their function and dysfunction are described briefly, followed by discussion of specific vascular disorders. ECs form a specialized simple squamous epithelium lining for blood vessels. Although ECs throughout the vascular tree share many attributes, populations that line different portions of the vascular tree, large vessels versus capillaries, arteries versus veins, have distinct gene expression profiles, behaviors, and morphologic appearances. Thus, ECs in liver sinusoids or in renal glomeruli are fenestrated. They have holes, presumably to facilitate filtration, while central nervous system ECs along with the associated perivascular cells create an impermeable blood-brain barrier. ECs are versatile multifunctional cells with a wealth of synthetic and metabolic properties. In the normal state, they have several constitutive activities that are critical for vessel homeostasis and circulatory function. Table 11.1. Unless injured or otherwise activated, ECs have a non-thrombogenic surface that maintains blood in a fluid state. Chapter 4. They also modulate medial SMC tone, thereby influencing 488. Chapter 11. Blood vessels. Endothelial cell properties and functionality. Mediators/products. L's property/function. Maintenance of permeability barrier. Elaboration of anticoagulant, antithrombotic, and fibrinolytic regulators. 1. Tone. Prostacyclin, thrombomodulin, heparin-like molecules, plasminogen activator. Von Willebrand factor, tissue factor, plasminogen activator inhibitor. Collagen, proteoglycans. Elaboration of prothrombotic molecules. Production of extracellular matrix. Modulation of blood flow, vasoconstrictors. Endothelin, AC and vascular reactivity, vasodilators. No, prostacyclin. Regulation of inflammation, IL-1, IL-6, chemokines and immunity adhesion molecules, VCAM1. ICAM, E-selectin, P-selectin, histocompatibility antigens. Growth stimulators, PDGF, CSF, FGF growth inhibitors, heparin, TGF-beta, ACE, angiotensin converting enzyme, CSF, colony stimulating factor, FGF, fibroblast growth factor, ICAM, intercellular adhesion molecule, IL, interleukin, LDL, low-density lipoprotein, No, nitric oxide, PDGF, platelet-derived growth factor, TGF-beta, transforming growth factor beta, VCAM, vascular cell adhesion molecule, regulation of cell growth, vascular resistance, metabolize hormones such as angiotensin, regulate inflammation, and affect the growth of other cell types, particularly SMCs. Although interendothelial junctions are largely impermeable in normal vessels, vasoactive agents, for example, histamine, cause contraction of ECs and allow the rapid egress of fluids, electrolytes, and protein. In inflammation, even leukocytes can slip between adjacent ECs. Chapter 3. ECs can respond to various stimuli by adjusting their steady-state constitutive functions and by expressing newly acquired inducible properties, a process termed endothelial activation. Fig. 11.2. There are numerous inducers of endothelial activation, including cytokines and bacterial products, which elicit inflammation and, in severe cases, can promote septic shock. Chapter 4. Additional activators include hemodynamic stresses and lipid products that are critical to the pathogenesis of atherosclerosis. See later, and advanced glycation end products that are important in the pathogenic sequelae of diabetes. Chapter 24. Viruses, complement components, and hypoxia also activate ECs. Activated ECs, in turn, express adhesion molecules. Chapter 3, and produce cytokines, chemokines, growth factors, vasoactive molecules that result either in vasoconstriction or in vasodilation, induction of major histocompatibility complex molecules, procoagulant and anticoagulant factors, and a variety of other biologically active products. ECs influence the vasoreactivity of the underlying SMCs through the production of both vasodilating relaxing factors, for example, nitric oxide NO, and vasoconstrictive factors, for example, endothelin. Normal EC function is characterized by a balance of these responses. Endothelial dysfunction refers to an alteration in endothelial phenotype, seen in many different conditions, that is often both pro-inflammatory and prothrombogenic. It is responsible, at least in part, for the initiation of thrombus formation, atherosclerosis, and the vascular lesions of hypertension and other disorders. Certain forms of endothelial dysfunction are rapid in onset within minutes, reversible, and independent of new protein synthesis, for example, EC contraction induced by histamine and other vasoactive mediators that cause gaps in venular endothelium. Chapter 3. Other changes, such as the upregulation of adhesion molecules, involve alterations in gene expression and protein synthesis and may require hours or even days to develop. Vascular SMCs are the predominant cellular element of the vascular media, playing important roles in normal vascular repair and pathologic processes such as atherosclerosis. SMCs have the capacity to proliferate when appropriately stimulated. They can also synthesize collagen, elastin, and protoglycans and elaborate growth factors and cytokines. SMCs are also responsible for the vasoconstriction or dilation that occurs in response to physiologic or pharmacologic stimuli. Intimal thickening, a stereotyped response to vascular injury. Vascular injury associated with EC dysfunction or loss stimulates SMC recruitment and proliferation and associated ECM synthesis. The result is intimal thickening that can compromise vascular flow. Healing of injured vessels is analogous to the healing process that occurs in any other damaged tissue. Chapter 3, but has a somewhat unique outcome because the process impacts downstream blood flow. ECs involved in repair can migrate from adjacent uninjured areas into denuded areas or can derive from basal state. Normal tension laminar flow growth factors, for example, VAV, non-adhesive, non-thrombogenic surface, endothelium, turbulent flow hypertension, cytokines complement bacterial products, lipid products, advanced glycation, end products, hypoxia, acidosis, viruses, cigarette smoke, increased expression of procoagulants, adhesion molecules, and pro-inflammatory factors, altered expression of chemokines, cytokines, and growth factors, activated state. Figure 11.2 pressure, laminar flow, and stable growth factor levels promote a basal endothelial cell state that maintains a non-thrombotic, non-adhesive surface with appropriate vascular wall, smooth muscle tone. Injury or exposure to certain mediators results in endothelial activation, a state where endothelial cells develop a procoagulant surface that can be adhesive for inflammatory cells and express factors that cause smooth muscle contraction and / or proliferation and matrix synthesis. VAV, vascular endothelial growth factor, basal and activated endothelial cell states, normal blood, vascular disease. 489, endothelium. 1. Recruitment of smooth muscle cells or smooth muscle precursor cells to the intima. 2. Smooth muscle cell mitosis. 3. Elaboration of extracellular matrix, intima, internal elastic lamina, smooth muscle cells, median. Figure 11.3 stereotypical response to vascular injury. Schematic diagram of intimal thickening, emphasizing intimal smooth muscle cell migration and proliferation associated with extracellular matrix synthesis. Intimal smooth muscle cells can derive from the underlying media or can be recruited from circulating precursors. The intimal cells are shown in a darker shade to emphasize that they have a proliferative, synthetic, and non-contractile phenotype distinct from medial smooth muscle cells. Circulating precursors. Medial SMCs or circulating smooth muscle precursor cells also migrate into the intima, proliferate, and synthesize ECM in much the same way that fibroblasts fill in a wound. Fig. 11.3. The resulting neointima is typically completely covered by ECs. This neointimal response occurs with any form of vascular damage or dysfunction, regardless of cause. Thus, intimal thickening is the stereotypical response of the vessel wall to any insult. Neointimal SMCs have a phenotype that is distinct from that of medial SMCs. Specifically, neointimal SMCs are more proliferative, with increased biosynthetic capabilities and reduced contractile function. This neointimal SMC behavior is regulated by cytokines and growth factors derived from platelets, and macrophages, as well as thrombin and activated complement factors. With time and restoration and or normalization of the EC layer, the neointimal SMCs can return to a non-proliferative state. Key concepts: response of vascular wall cells to injury. All vessels are lined by endothelium. Although all ECs share certain homeostatic properties, ECs in specific vascular beds have special features that allow for tissue-specific functions. For example, fenestrated ECs in renal glomeruli. EC function is tightly regulated in both the basal and activated states. Various physiologic and pathophysiologic stimuli induce endothelial activation and dysfunction that alter the EC phenotype. For example, procoagulative versus anticoagulative, pro-inflammatory versus anti-inflammatory, and non-adhesive versus adhesive. Injury of almost any type to the vessel wall results in a STI-type healing response involving SMC proliferation, deposition, and intimal expansion. The recruitment and activation of the SMCs involves signals from cells, for example, platelets, and macrophages, as well as mediators derived from coagulation and complement cascades. Excessive thickening of the intima can result in luminal stenosis and vascular obstruction. Hypertensive vascular disease. Systemic and local tissue blood pressures must be maintained within a narrow range to prevent untoward consequences. Low pressures hypotension result in inadequate organ perfusion and can lead to dysfunction or tissue death. Conversely, high pressure hypertension can cause end organ damage and is one of the major risk factors for atherosclerosis. See later. Like height and weight, blood pressure is a continuously distributed variable. Detrimental effects of blood pressure increase continuously as the pressure rises. No rigidly defined threshold level of blood pressure identifies those who have an increased risk for cardiovascular disease. Both the systolic and the diastolic blood pressure are important in determining risk. Specifically, according to the newest guidelines, individuals with diastolic pressures above 80 mmHg or systolic pressures above 120 mmHg are considered to have clinically significant hypertension. Approximately 46% of individuals in the general population are therefore hypertensive based on these newer criteria. However, such cutoffs do not reliably assess risk in all patients. For example, when other risk factors such as diabetes are present, lower thresholds are applicable. Table 11.2 lists the major causes of hypertension. Although the molecular pathways that regulate normal blood pressure are reasonably well understood, the causes of hypertension in most individuals remain largely unknown. A small number of patients, approximately 10%, are said to have secondary hypertension resulting from an underlying renal or adrenal disease, for example, primary aldosteronism, Cushing's syndrome, or phacocytoma, renal artery stenosis, or other identifiable cause. However, approximately 90% of hypertension is idiopathic, so-called essential hypertension. It seems likely that hypertension is a multifactorial disorder resulting from the cumulative effects of multiple genetic polymorphisms and interacting environmental factors. The prevalence and vulnerability to complications of hypertension increase with age and are higher among African. 490 Chapter 11 Blood vessels. 2 types: Diston table down as systolic causes of hyper-NCO and 1. Essential hypertension accounts for 90%, 95% of all cases. Secondary hypertension. Renal, acute glomerulonephritis, chronic renal disease, polycystic disease, renal artery stenosis, renal vasculitis, renin-producing tumors. Endocrine, adrenocortical hyperfunction, Cushing's syndrome, primary, aldosteronism, congenital adrenal hyperplasia, licorice ingestion, exogenous hormones, glucocorticoids, estrogen including pregnancy, induced in oral contraceptives, sympathomimetics and tyramine-containing foods, monoamine oxidase inhibitors, phacocytoma, acromegaly, hypothyroidism, thyrotoxicosis, pregnancy-induced preeclampsia. Cardiovascular, coarctation of the aorta, polyarteritis nodosa, increased intravascular volume, increased cardiac output, rigidity of the aorta. Neurologic, psychogenic, increased intracranial pressure, sleep apnea, acute stress, including surgery. Monthly, Americas. Besides increasing risk of atherosclerosis, hypertension can cause cardiac hypertrophy and heart failure. Hypertensive heart disease, Chapter 12. Multi-infarct dementia, Chapter 28. Aortic dissection, discussed later in this chapter. And renal failure, Chapter 20. Unfortunately, hypertension typically remains asymptomatic until late in its course, and even severely elevated pressures can be clinically silent for years. Left untreated, roughly half of hypertensive patients die of ischemic heart disease or congestive heart failure, and another third die of stroke. Treatment with blood pressure lowering drugs dramatically reduces the incidence and death rates attributable to all forms of hypertension-related pathology. A small percentage of hypertensive persons, as much as 5%, show a rapidly rising blood pressure that, if untreated, leads to death within 1 to 2 years. This form of hypertension, called malignant hypertension, is characterized by severe pressure elevations, i.e., systolic pressure more than 200 mmHg, diastolic pressure more than 120 mmHg, renal failure, and retinal hemorrhages and exudates, with or without papilledema, swelling of the optic nerve that reflects increased intracranial pressures. It can develop in previously normotensive persons, but more often is superimposed on pre-existing benign hypertension. In this section, we will first briefly outline normal blood pressure homeostasis, followed by a discussion of pathogenic mechanisms that underlie hypertension and a description of hypertension-associated pathologic changes in vessels. Blood pressure regulation. Blood pressure is a function of cardiac output and peripheral vascular resistance, both of which are influenced by multiple genetic and environmental factors. Fig. 11.4. The integration of the various inputs ensures adequate systemic perfusion, despite regional demand differences. Cardiac output is a function of stroke volume and heart rate. The most important determinant of stroke volume is the filling pressure, which is regulated through sodium homeostasis and its effect on blood volume. Heart rate and myocardial contractility, a second factor affecting stroke volume, are both regulated by the alpha and beta-adrenergic systems, which also have important effects on vascular tone. Peripheral resistance is regulated predominantly at the level of the arterioles by neural and hormonal inputs. Blood volume, sodium mineralocorticoids, atrial natriuretic peptide. Humoral factors, constrictors, dilators, angiotensin, Roman II, prostaglandins, catecholamines, kinase, thromboxane, leukotrienes, endothelin. Blood pressure, cardiac output, peripheral resistance. Local factors are regulation, pH, hypoxia. Cardiac factors, heart rate, contractility. Constrictors, dilators, alpha-adrenergic, beta-adrenergic. Neural factors. Figure 11.4. Neural, humoral, and local effectors impact the output blood pressure. Blood pressure regulation. Diverse influences on cardiac output, for example, blood volume and myocardial contractility and peripheral resistance. Hypertensive vascular disease. 491. Vascular tone reflects a balance between vasoconstrictors including angiotensin, Roman II, catecholamines, and endothelin, and vasodilators including kinase, prostaglandins, and no. Resistance vessels also exhibit autoregulation, whereby increased blood flow induces vasoconstriction to protect tissues against hyperperfusion. Finally, blood pressure is fine-tuned by tissue pH and hypoxia to accommodate local metabolic demands. Factors released from the kidneys, adrenals, and myocardium interact to influence vascular tone and to regulate blood volume by adjusting sodium balance. Fig. 11.5. The kidneys filter 170 liters of plasma containing 23 moles of salt daily. Thus, with a typical diet containing 100 mg of sodium, 99.5% of the filtered salt must be reabsorbed to maintain total body sodium levels. About 98% of the filtered sodium is reabsorbed by several constitutively active transporters. The small amount of remaining sodium is subject to resorption by the epithelial sodium channel ENS-C, which is tightly regulated by the renin-angiotensin-aldosterone system. It is this pathway that determines net sodium balance. The kidneys and heart contain cells that sense changes in blood pressure or volume. In response, these cells release circulating effectors that act in concert to maintain normal blood pressure. Kidneys influence peripheral resistance and sodium excretion/retention primarily through the renin-angiotensin-aldosterone system. Renin is a proteolytic enzyme produced by renal juxtaglomerular cells, which are myoepithelial cells adjacent to the glomerular afferent arterioles. Renin is released in response to low blood pressure in afferent arterioles, elevated levels of circulating catecholamines, or low sodium levels in the distal convoluted renal tubules. The latter occurs when the glomerular filtration rate falls, for example, when the cardiac output is low, leading to increased sodium resorption by the proximal tubules. Renin cleaves plasma angiotensinogen to angiotensin I, which in turn is converted to angiotensin Roman II by angiotensin converting enzyme ACE, mainly a product of vascular endothelium. Angiotensin Roman 2 raises blood pressure by 1, inducing vascular contraction, 2, stimulating aldosterone secretion by the adrenal gland, and 3, increasing tubular sodium resorption. Adrenal aldosterone increases blood pressure by its effect on blood volume. Aldosterone increases sodium resorption and thus water in the distal convoluted tubules, which increases blood volume. The kidney also produces a variety of vascular relaxing substances including prostaglandins and that can counterbalance the vasopressor effects of angiotensin. Atrial natriuretic peptide, volume overload, excretes NA+ in water, vasodilation blood volume, blood pressure normotension blood pressure, liver, low volume or low resistance, renal artery stenosis, kidney, renin, angiotensinogen angiotensin I, resorbs NA+, and water, adrenal, blood volume, aldosterone, angiotensin Roman 2, angiotensin converting, enzyme, endothelium in many tissues, vasoconstriction increased volume excess dietary sodium, inadequate excretion, renal failure, hyperaldosteronism, increased sodium resorption, Deichmann, Barter, and Little syndromes, increased resistance, increased sympathetic tone, for example, phacocytoma, increased renin-angiotensin, aldosterone axis. Figure 11.5 Interplay of renin-angiotensin aldosterone and atrial natriuretic peptide in maintaining blood pressure homeostasis. 492 Chapter 11 Blood vessels. Myocardial natriuretic peptides are released from atrial dominant contributor and ventricular minor contributor myocardium in response to volume expansion. These inhibit sodium resorption in the distal renal tubules, thus leading to sodium excretion and diuresis. They also induce systemic vasodilation. Key concepts: blood pressure regulation. Blood pressure is determined by vascular resistance and cardiac output. Vascular resistance is regulated at the level of the arterioles, influenced by neural and hormonal inputs. Cardiac output is determined by heart rate and stroke volume, which is strongly influenced by blood volume. Blood volume in turn is regulated mainly by renal sodium excretion or resorption. Renin, a major regulator of blood pressure, is secreted by the kidneys in response to decreased blood pressure in afferent arterioles. In turn, renin cleaves angiotensinogen to angiotensin I. Subsequent endothelial catabolism produces angiotensin Roman 2, which regulates blood pressure by increasing vascular SMC tone and by increasing adrenal aldosterone secretion, thereby increasing renal sodium resorption. Pathogenesis of hypertension. The vast majority, 90% to 95% of hypertension, is idiopathic, the result of interacting genetic and environmental factors. Even without knowing the specific lesions, it is reasonable to suppose that small changes in renal sodium homeostasis and or vessel wall tone or structure act in combination to cause essential hypertension. See Fig. 11.5. Most other causes fall under the general rubric of renal disease, including renovascular hypertension due to renal artery occlusion. Infrequently, hypertension has an underlying endocrine basis. Mechanisms of secondary hypertension. For many of the secondary forms of hypertension, the underlying pathways are reasonably well understood. In renovascular hypertension, renal artery stenosis causes decreased glomerular flow and pressure in the afferent arteriole of the glomerulus. As already discussed, this induces renin secretion leading to increased blood volume and vascular tone via angiotensin and aldosterone pathways. See Fig. 11.5. Primary hyperaldosteronism is one of the most common causes of secondary hypertension. Chapter 24. It may be idiopathic or less commonly caused by aldosterone-secreting adrenal adenomas. Single gene disorders cause severe but rare forms of hypertension. Gene defects affecting enzymes involved in aldosterone metabolism, for example, aldosterone synthase, 11-beta-hydroxylase, 17-alpha-hydroxylase, can lead to increased aldosterone secretion with downstream increases in salt and water resorption, plasma volume expansion, and, ultimately, hypertension. Mutations affecting proteins that influence sodium reabsorption, for example, the moderately severe form of salt-sensitive hypertension, called Little syndrome, is caused by mutations in an epithelial NA+ channel protein that increase distal tubular reabsorption of sodium in response to aldosterone. Mechanisms of essential hypertension. As mentioned earlier, in the vast majority of cases, hypertension results from complex interactions between multiple genetic and environmental influences. Genetic factors definitely contribute to blood pressure regulation, as shown by comparisons of monozygotic and dizygotic twins and genetically related versus adopted children. Moreover, as noted earlier, several single-gene disorders cause relatively rare forms of hypertension and hypotension by altering net sodium reabsorption in the kidney. Large genome-wide association studies point to more than 60 genetic loci in which variants individually contribute minimally to blood pressure levels, but in some have larger effects. Insufficient renal sodium excretion in the presence of normal arterial pressure may be a key initiating event in essential hypertension and, indeed, a final common pathway for the pathogenesis of hypertension. Insufficient sodium excretion may lead sequentially to an increase in fluid volume, increased cardiac output, and peripheral vasoconstriction, thereby elevating blood pressure. At the high blood pressure, enough additional sodium is excreted by the kidneys to equal intake and prevent further fluid retention. Thus, a new steady state of sodium balance is achieved resetting of pressure natriuresis, but at the expense of an increase in blood pressure. Vasoconstrictive influences, such as factors that induce vasoconstriction or stimuli that cause structural changes in the vessel wall, can lead to an increase in peripheral resistance and may also play a role in essential hypertension. Environmental factors such as stress, obesity, smoking, physical inactivity, and heavy salt consumption all are implicated in hypertension. Indeed, the evidence linking dietary sodium intake with the prevalence of hypertension in different populations is particularly impressive. Vascular pathology and hypertension. Hypertension not only accelerates atherogenesis, see later, but also causes degenerative changes in the walls of large and medium arteries that can lead to both aortic dissection and cerebrovascular hemorrhage. 3 forms of small vessel disease are hypertension-related: Fig. 11.6. Morphology: hyaline arteriolosclerosis. Arterioles show homogeneous, pink hyaline thickening with associated luminal narrowing. Fig. 11.6a. These changes reflect both plasma protein leakage across injured ECs and increased SMC matrix synthesis in response to the chronic hemodynamic pressures of hypertension. Although the vessels of older patients, either normotensive or hypertensive, also frequently exhibit hyaline arteriosclerosis, it is more generalized and severe in patients with hypertension and diabetes. Chapter 24. Nephrosclerosis due to chronic hypertension, the arteriolar. 493. B. Figure 11.6. Vascular pathology and hypertension. Hyaline arteriolosclerosis. The arteriolar wall is thickened with increased protein deposition, hyalinized, and the lumen is markedly narrowed. The hyperplastic arteriolosclerosis, onion skinning causing luminal obliteration, arrow periodic acid skiff stain. B. Courtesy Helmut Rank, M.D., Brigham and Women's Hospital, Boston, Mass. Narrowing causes diffuse impairment of renal blood supply and glomerular scarring. Chapter 20. Hyperplastic arteriolosclerosis. This lesion occurs in severe hypertension. Vessels exhibit concentric, laminated onion skin thickening of the walls with luminal narrowing. Fig. 11.6b. The laminations consist of SMCs with thickened, reduplicated basement membrane. In malignant hypertension, they are accompanied by fibrinoid deposits and vessel wall necrosis, necrotizing arteriolitis, particularly in the kidney. Chapter 20. Pulmonary hypertension can be caused by several entities including left heart failure, congenital heart disease, valve disorders, obstructive or interstitial lung disease, and recurrent thromboemboli. Arterioles in such affected lungs typically show histologic changes ranging from fibrotic intimal thickening to medial hyperplasia. These are described in greater detail in Chapter 15. Atherosclerosis. Key concepts: hypertension. Hypertension is a common disorder affecting roughly half of adults in the United States. It is a major risk factor for atherosclerosis, congestive heart failure, and renal failure. Essential hypertension represents 90% to 95% of cases and is a complex, multifactorial disorder involving both environmental influences and genetic polymorphisms that influence sodium resorption, aldosterone pathways, and the renin-angiotensin-aldosterone system. Hypertension is occasionally caused by single gene disorders or is secondary to diseases of the kidney, adrenal, or other endocrine organs. Sustained hypertension requires participation of the kidney, which normally responds to hypertension by eliminating salt and water. In established hypertension, both increased blood volume and increased peripheral resistance contribute to the increased pressure. Histologically, hypertension is associated with thickening of arterial walls caused by hyaline deposits and, in severe cases, by proliferation of ECs or SMCs and replication of the basement membrane. Arteriosclerosis. Arteriosclerosis literally means hardening of the arteries. It is a generic term for arterial wall thickening and loss of elasticity. There are 4 general patterns, with different clinical and pathologic consequences. Arteriosclerosis affects small arteries and arterioles and may cause downstream ischemic injury. The 2 anatomic variants, hyaline and hyperplastic, were discussed earlier in relation to hypertension. Merkeberg medial sclerosis is characterized by calcifications of the medial walls of muscular arteries, typically starting along the internal elastic membrane. Adults older than age 50 are most commonly affected. The calcifications do not encroach on the vessel lumen and are usually not clinically significant. Fibromuscular intimal hyperplasia occurs in muscular arteries larger than arterioles. It is driven by inflammation as in a healed arteritis or transplant-associated arteriopathy. See Chapter 12, or by mechanical injury, for example, associated with stents or balloon angioplasty. See later and can be considered as a healing response. The affected vessels can become quite stenotic, indeed. Such intimal hyperplasia underlies in stent restenosis and is the major long-term limitation of solid organ transplants. Atherosclerosis, from Greek root words for gruel and hardening, is the most frequent and clinically important pattern and is discussed here. Atherosclerosis. Atherosclerosis underlies the pathogenesis of coronary, cerebral, and peripheral vascular disease and causes more morbidity and mortality, roughly half of all deaths in the Western world, than any other disorder. Because coronary artery disease is an important manifestation of the disease, epidemiologic data related to atherosclerosis mortality typically reflect deaths caused by ischemic heart disease. Chapter 12. Indeed, myocardial infarction is responsible for almost a quarter of all deaths in the United 494. Chapter 11. Blood vessels. Fibrous smooth muscle cells, macrophages, foam cells, lymphocytes, collagen, elastin, protoglycans, neovascularization, necrotic center cell debris, cholesterol crystals, foam cells, calcium, media. Figure 11.7. Basic structure of an atherosclerotic plaque. Note that atherosclerosis is an intimal-based process with a complex interplay of cells and extracellular materials. Plaques can have secondary effects on the underlying media, including a reduction in smooth muscle cells. States. Significant morbidity and mortality are also caused by aortic and carotid atherosclerotic disease and stroke. The likelihood of atherosclerosis is determined by the combination of acquired, for example, cholesterol levels, smoking, hypertension, inherited, for example, low-density lipoprotein LDL receptor gene mutations, and gender and age-associated risk factors. Acting in concert, they cause intimal lesions called atheromas, also called atheromatous or atherosclerotic plaques that protrude into vessel lumens. An atheromatous plaque typically consists of a raised lesion with a soft grumous core of lipid, mainly cholesterol and cholesterol esters, covered by a fibrous cap. Fig. 11.7. Besides mechanically obstructing blood flow, atherosclerotic plaques can rupture, leading to catastrophic obstructive vascular thrombosis. Atherosclerotic plaques can also increase the diffusion distance from the lumen to the media, leading to ischemic injury and weakening of the vessel wall, changes that can result in aneurysm formation. Epidemiology. Although atherosclerosis-associated ischemic heart disease is ubiquitous among most developed nations, risk reduction and improved therapies have combined to moderate the associated mortality. At the same time, reduced mortality from infectious diseases and the adoption of Western lifestyles has led to the increased prevalence of ischemic heart disease in low-income nations. As a result, the death rate for coronary artery disease in Africa, India, and Southeast Asia now exceeds that in the United States. Eastern European countries have rates 3 to 5 times higher than the United States and 7 to 12 times higher than Japan. Risk factors. The prevalence and severity of atherosclerosis and ischemic heart disease among individuals and groups are related to a number of risk factors identified through several prospective analyses. For example, the Framingham Heart Study. Some of these are constitutional and therefore less controllable, but others are acquired or related to specific behaviors and potentially amenable to intervention. Table 11.3. These risk factors typically have greater than additive effects, but treatment even less than optimal can mitigate some of the risk. Fig. 11.8. Constitutional risk factors. Genetics. Family history is the most important independent risk factor for atherosclerosis. Certain Mendelian disorders are strongly associated with atherosclerosis. For example, Familial hypercholesterolemia. See Chapter 5. But they account for only a small percentage of cases. A well-established familial predisposition to atherosclerosis and ischemic heart disease is usually polygenic, relating to small effects of many shared alleles common to a family or population. Age is a dominant influence. The development of atherosclerotic plaque is a progressive process that usually becomes clinically manifest in middle age or later. See later. Thus, between ages 40 and 60, the incidence of myocardial infarction increases fivefold. Death rates from ischemic heart disease rise with each decade, even into advanced age. Increasingly, however, this age association is being recognized as perhaps more than just the accumulated slings and arrows of vascular injury over the years. Indeed, with aging, there is a tendency for the outgrowth of hematopoietic clones, so-called clonal hematopoiesis of indeterminate potential chip-carrying mutations that confer a proliferative advantage. Many of these affect DNA modifications and transcriptional regulation. For example, TTHO encoding an enzyme that converts methylcitosine to 5-hydroxymethylcitosine. As expected, these can ultimately influence the risk of developing hematologic malignancies. Perhaps more remarkable, however, is that such clonal hematopoiesis is even more. Risk factors for atherosclerosis 11. 3 is major, non-modifiable constitutional. Genetic abnormalities, family history, increasing age, male gender, modifiable. Hyperlipidemia, hypertension, cigarette smoking, diabetes, inflammation. Table 495. Grade year 10, estimated 60, 50, 40, 30, 20, 10, 5.5. Men, women 8, 7, 9, 2, 1, 3, 7, 1, 1, 3, 1, 6, 5, 1, 7, 2, 3, 4, 2, 8, 8, 2, 7, 7, 3, 6, 8, 3, 8, 5, 6, 4, 5, 7, 5, a 0. BP, systolic cholesterol, HDL-C, diabetes, cigarettes, LVH by ECG. 120, 220, 50. 160, 220, 50. 160, 260, 50. 160, 260, 35. 160, 260, 35 plus. 160, 260, 35 plus plus. 160, 260, 35 plus plus plus. 40, 30. Risk, lifetime 20. 10. 2 major risk factors, 1 major risk factor, all risk factors optimal. 40, 30. Risk, lifetime 20. 10. 2 major risk factors, 1 major risk factor, all risk factors optimal. E. 0, 0, 55, 60, 65, 70, 75, 80, 85, 90. Attain age years. 0, 0, 55, 60, 65, 70, 75, 80, 85, 90. See attain age years. Figure 11.8 lifetime risk of death from cardiovascular disease. The estimated 10-year risk of coronary artery disease in hypothetical 55-year-old men and women is a function of traditional risk factors: hyperlipidemia, hypertension, smoking, and diabetes. BP, blood pressure. 8. Electrocardiogram, HDL-C, high-density lipoprotein cholesterol, LVH, left ventricular hypertrophy. In women B and men C, 1 or more risk factors of blood pressure, cholesterol, diabetes, and cigarettes significantly increases the lifetime risk of a cardiovascular event. 8. From O'Donnell C.J., Cano W.B., cardiovascular risks of hypertension. Lessons from observational studies. J. Hyperton Supple 16.6, S3, S7, 1998, with permission from Lippincott, Williams, and Wilkins, B and C, modified from Berry J.D., Dyer A., Chi X, et al. Lifetime risks of cardiovascular disease. NAJ Med 36X32-1, 329, 2012. Atherosclerosis. Significantly associated with increased all-cause cardiovascular mortality. An explanation is beginning to emerge that the same chip mutations that affect cellular proliferation, for example, TT12, can also impact the inflammatory response of mononuclear cells and thereby influence atherogenesis. See also later. Gender. Premenopausal women are relatively protected against atherosclerosis and its consequences compared with age-matched men. Thus, myocardial infarction and other complications of atherosclerosis are uncommon in premenopausal women unless they are otherwise predisposed by diabetes, hyperlipidemia, or severe hypertension. After menopause, however, the incidence of atherosclerosis-related diseases increases and at older ages exceeds that of men. Although a favorable influence of estrogen has been proposed to explain this effect, clinical trials of estrogen replacement did not show any benefit. Indeed, postmenopausal estrogen therapy actually increased cardiovascular risk in some older women. Modifiable major risk factors, hyperlipidemia, and more specifically hypercholesterolemia, is a major risk factor for atherosclerosis. Even in the absence of other risk factors, hypercholesterolemia is sufficient to initiate lesion development. The major component of serum cholesterol associated with increased risk is LDL cholesterol. Chapter 11, Blood Vessels. Bad cholesterol. LDL is the lipid cholesterol protein complex that delivers cholesterol to peripheral tissues. In contrast, high-density lipoprotein HDL is the complex that mobilizes cholesterol from the periphery, including atheromas, and transports it to the liver for catabolism and biliary excretion. High levels of HDL good cholesterol correlate with reduced risk. Understandably, dietary and pharmacologic interventions that lower LDL or total serum cholesterol are of considerable interest. Interestingly, approaches that exclusively raise HDL are not effective. Although previously considered important, the contribution of most dietary fasts to atherosclerosis is now viewed as minimal. Nevertheless, omega-3 fatty acids abundant in fish oils are considered beneficial, whereas trans-unsaturated fats produced by artificial hydrogenation of polyunsaturated oils used in baked goods and margarine can adversely affect cholesterol profiles. Statins are a class of drugs that lower circulating cholesterol levels by inhibiting hydroxymethylglutaryl coenzyme HMG-CoA reductase, the rate-limiting enzyme in hepatic cholesterol biosynthesis. Chapter 5. Statins are widely used to lower serum cholesterol levels, lowering rates of myocardial infarctions, arguably one of the most significant success stories of translational research. Interestingly, some of the benefit of the statins may be due to off-target effects on reducing inflammation. See also later. Hypertension can increase the risk of ischemic heart disease by approximately 60% versus normal-intensive populations. Chronic hypertension is the most common cause of left ventricular hypertrophy, and hence the latter is also a surrogate marker for cardiovascular risk. Cigarette smoking, and in particular prolonged years use, doubles the death rate from ischemic heart disease. Smoking cessation reduces that risk substantially. Diabetes mellitus induces hypercholesterolemia. Chapter 24, and markedly increases the risk of atherosclerosis. Other factors being equal, the incidence of myocardial infarction is twice as high in diabetics relative to normal glycemic individuals. There is also an increased risk of strokes and a 100-fold increased risk of atherosclerosis-induced gangrene of the lower extremities. Additional risk factors: as many as 20% of all cardiovascular events occur in the absence of major risk factors, for example, hypertension, hyperlipidemia, smoking, or diabetes. Indeed, more than 75% of cardiovascular events in previously healthy women occur with LDL cholesterol levels below 160 mg/dl, levels generally considered to connote low risk. Clearly, other factors are contributory. Among those that are proven or suspected are the following. Inflammation. Inflammation is present during all stages of atherogenesis and is intimately linked with atherosclerotic plaque formation and ruptures. See later. With the increasing recognition that inflammation plays a significant causal role in ischemic heart disease, assessment of systemic inflammation has become important in overall risk stratification. A number of circulating markers of inflammation correlate with ischemic heart disease, and C-reactive protein CRP has emerged as one of the most stable and simplest to measure. 25, 20, risk 15, relative 10, 5, 0, 0, 1, 2, 4, 5, 9, 10, 20. Framingham estimate of 10-year risk percent. Figure 11.9 of traditional risk identified from the Framingham Heart Study. Relative risk y-axis refers to the risk of a cardiovascular event, for example, myocardial infarction. The x-axis is the 10-year risk of a cardiovascular event derived from the traditional risk factors identified in the Framingham study. In each risk group, C-reactive protein values further stratify the patients. Data from Ritker PM, et al. Comparison of C-reactive protein and low-density lipoprotein cholesterol levels in the prediction of first cardiovascular events. In Engel J. Med 34-7-1557, 2002, 496. C-reactive protein adds prognostic information at all levels. CRP is an acute phase reactant synthesized primarily by the liver. Although CRP does not appear to be causally related to the development of atherosclerosis or its sequelae, it is well established that plasma CRP is a strong, independent marker of risk for myocardial infarction, stroke, peripheral arterial disease, and sudden cardiac death, even among apparently healthy individuals. Fig. 11.9. Accordingly, CRP levels are now incorporated into risk stratification algorithms. Interestingly, CRP levels are also typically lowered in concert with other risk reduction measures including smoking cessation, weight loss, exercise, and statin administration. Hyperhomocystinemia. Serum homocysteine levels correlate with coronary atherosclerosis, peripheral vascular disease, stroke, and venous thrombosis. Homocystinuria, due to rare inborn errors of metabolism, results in elevated circulating homocysteine 100 mmol/L and is associated with premature vascular disease. Metabolic syndrome, associated with central obesity. Chapter 9. This entity is characterized by insulin resistance, hypertension, dyslipidemia, elevated LDL and depressed HDL, hypercoagulability, and a pro-inflammatory state. Dyslipidemia, hyperglycemia, and hypertension all are cardiac risk factors, while the systemic hypercoagulable and pro-inflammatory state may contribute to endothelial dysfunction and/or thrombosis. Lipoprotein LP is an altered form of LDL that contains the apolipoprotein B100 portion of LDL linked to apolipoprotein ApoA. LPA levels are associated with coronary and cerebrovascular disease risk, independent of total cholesterol or LDL levels. Factors affecting hemostasis. Several markers of hemostatic and/or fibrinolytic function, for example, elevated plasminogen activator inhibitor 1 are potent predictors of risk for C-reactive protein Mg/L1, 01, 03, 03, 0. Atherosclerosis 497. Figure 11.10 hypothesis. 1. Normal. 2. Endothelial injury with monocyte and platelet adhesion. 3. Monocyte and smooth muscle cell migration into the intima with macrophage activation. 4. Macrophage and smooth muscle cell uptake of modified lipids with further activation. 5. Intimal smooth muscle cell proliferation with extracellular matrix production, forming a well-developed plaque. Evolution of arterial wall changes in the response to injury. Major atherosclerotic events including myocardial infarction and stroke. Platelet-derived factors as well as thrombin, through both procoagulant and pro-inflammatory effects, are increasingly recognized as major contributors to local vascular pathology. Other factors. Factors associated with a less pronounced and/or difficult to quantitate risk include lack of exercise, competitive, stressful lifestyle type of personality, and obesity, the last mentioned also being complicated by hypertension, diabetes, hypertriglyceridemia, and decreased HDL. Pathogenesis of atherosclerosis. The clinical importance of atherosclerosis has stimulated enormous interest in understanding the mechanisms that underlie its evolution and complications. The contemporary view of atherogenesis integrates the risk factors previously discussed and is called the response to injury hypothesis. This model views atherosclerosis as a chronic inflammatory and healing response of the arterial wall to endothelial injury. Lesion progression occurs through interaction of modified lipoproteins, macrophages, and T lymphocytes with ECs and SMCs of the arterial wall. Fig. 11.10. According to this schema, atherosclerosis progresses in the following sequence: endothelial injury and dysfunction, causing among other things increased vascular permeability, leukocyte adhesion, and thrombosis. Accumulation of lipoproteins, mainly LDL and its oxidized forms in the vessel wall. Monocyte adhesion to the endothelium, followed by migration into the intima and transformation into macrophages and foam cells. Platelet adhesion. Factor release from activated platelets, macrophages, and vascular wall cells, inducing SMC recruitment either from the media or from circulating precursors. SMC proliferation, ECM production, and recruitment of T cells. Lipid accumulation both extracellularly and within cells, macrophages, and SMCs. Calcification of ECM and necrotic debris late in the pathogenesis. We will now discuss the role of these factors in the pathogenesis of atherosclerosis in some detail, starting with endothelial injury. Endothelial injury. EC injury is the cornerstone of the response to injury hypothesis. Early lesions begin at sites of morphologically intact endothelium that exhibit endothelium intima media adventitia. chronic endothelial injury, hyperlipidemia, hypertension, smoking, homocysteine, hemodynamic factors, toxins, viruses, immune reactions. 2. Endothelial dysfunction, for example, increased permeability, leukocyte adhesion, monocyte adhesion, and emigration. 3. Macrophage activation, smooth muscle recruitment. 4. Macrophages and smooth muscle cells engulf lipid. 5. Smooth muscle proliferation, collagen and other extracellular matrix deposition, extracellular lipid. T lymphocyte, response to injury, T lymphocyte collagen, platelet monocyte, smooth muscle cell, fatty streak, fibrofatty atheroma, lipid debris. 498 Chapter 11 Blood vessels. Features of endothelial dysfunction: increased permeability, enhanced leukocyte adhesion, and altered gene expression. Causes of EC dysfunction include toxins from cigarette smoke, homocysteine, and the local production of inflammatory cytokines. However, the three most important causes of endothelial dysfunction are hemodynamic disturbances, hypercholesterolemia, and inflammation. Hemodynamic disturbances. The importance of hemodynamic turbulence in atherogenesis is illustrated by the observation that plaques do not occur randomly, but rather tend to locate at the ostia of exiting vessels, branch points, and along the posterior abdominal aorta where flow patterns are disturbed and non-laminar. This is explained by the fact that laminar non-turbulent flow increases the production of transcription factors and, in particular, crupill-like factor 2KLF12 that turn on atheroprotective genes and turn off inflammatory gene transcription. Conversely, turbulent, non-laminar flow drives a repertoire of genetic transcription that makes those sites atheroprone. It is noteworthy that some of the atheroprotective effects of statins also occur through KLF12 upregulation. Hypercholesterolemia. Lipids are transported in the bloodstream bound to specific apoproteins, forming lipoprotein complexes. Dyslipidemias are lipoprotein abnormalities that may be present in the general population and, indeed, are found in many myocardial infarction survivors. These include 1. Increased LDL cholesterol levels, 2. Decreased HDL cholesterol levels, and 3. Increased levels of the abnormal LP. These may result from mutations in apoproteins or lipoprotein receptors or arise from other underlying disorders that affect circulating lipid levels such as nephrotic syndrome, alcoholism, hypothyroidism, or diabetes mellitus. All of these abnormalities are associated with an increased risk of atherosclerosis. The evidence implicating hypercholesterolemia in atherogenesis includes the following. The dominant lipids in atheromatous plaques are cholesterol and cholesterol esters. Genetic defects in lipoprotein uptake and metabolism that cause hyperlipoproteinemia are associated with accelerated atherosclerosis. Thus, familial hypercholesterolemia, caused by mutations affecting the LDL receptors and consequent inadequate hepatic LDL uptake and catabolism, Chapter 5, can precipitate myocardial infarctions before age 20 in those homozygous for the mutation. Similarly, accelerated atherosclerosis occurs in animal models with engineered deficiencies in apolipoproteins or LDL receptors. Epidemiologic analyses demonstrate a significant correlation between the severity of atherosclerosis and the levels of total plasma cholesterol or LDL. Lowering serum cholesterol by diet or drug slows the rate of progression of atherosclerosis, causes regression of some plaques, and reduces the risk of cardiovascular events. The mechanisms by which hyperlipidemia contributes to atherogenesis include the following. Impaired EC function. Chronic hyperlipidemia, particularly hypercholesterolemia, can directly impair EC function by increasing local reactive oxygen species production. Besides causing membrane and mitochondrial damage, oxygen-free radicals accelerate node decay, dampening its vasodilator activity. Modified LDL. With chronic hyperlipidemia, lipoproteins accumulate within the intima, where they may aggregate or become oxidized by free radicals produced by inflammatory cells. Such modified LDL is then accumulated by macrophages through a variety of scavenger receptors distinct from the LDL receptor. Because the modified lipoproteins cannot be completely degraded, chronic ingestion leads to the formation of lipid-filled macrophages called foam cells. SMCs can similarly transform into lipid-laden foam cells by ingesting modified lipids through LDL receptor-related proteins. Not only are the modified lipoproteins toxic to ECs, SMC, and macrophages, but their binding and uptake also stimulate the release of growth factors, cytokines, and chemokines that create a vicious inflammatory cycle of monocyte recruitment and activation. The early lesions containing lipid-filled macrophages are called fatty streaks. Inflammation. Chronic inflammation contributes to the initiation and progression of atherosclerotic lesions. It is believed that inflammation is triggered by the accumulation of cholesterol crystals and free fatty acids in macrophages and other cells. Fig. 11.11. These cells sense the presence of abnormal materials via cytosolic innate immune receptors that are components of the inflammasome. Chapter 6. The resulting inflammasome activation leads to the production of the pro-inflammatory cytokine interleukin IL-1, which recruits and activates mononuclear cells including macrophages and T lymphocytes. Such mononuclear cell activation, in turn, leads to local production of cytokines and chemokines that recruit and activate more inflammatory cells. Activated macrophages produce reactive oxygen species that enhance LDL oxidation and elaborate growth factors that drive SMC proliferation. Activated T lymphocytes in the growing intimal lesions elaborate inflammatory cytokines, for example, interferon gamma, which, in turn, can activate macrophages as well as ECs and SMCs. Thus, many of the lesions of atherosclerosis are attributable to the chronic inflammatory reaction in the vessel wall. Infection. Although circumstantial evidence has been presented linking atherosclerosis to herpes virus, cytomegalovirus, and chlamydophila pneumoniae, there is not an established causal role for infection. Smooth muscle proliferation and matrix synthesis. Intimal SMC proliferation and ECM deposition convert a fatty streak into a mature atheroma and contribute to the progressive growth of atherosclerotic lesions. See Fig. 11.10. Several growth factors are implicated in SMC proliferation and ECM synthesis, including platelet-derived growth factor PDGF, released by locally adherent platelets, as well as macrophages, ECs and SMCs, fibroblast growth factor, and transforming growth factor alpha. Chapter 1. These factors also stimulate SMCs to synthesize ECM, notably collagen, which stabilizes atherosclerotic plaques. In contrast, activated inflammatory cells and atheromas may increase the breakdown of ECM components, resulting in unstable plaques. See later. Monocyte LDL, macrophage CD35, inflammatory cell, infiltration, cell death. 2222. Oxidized LDL, TLR, cholesterol, crystals and KB signaling, lysosomal, damage NLRP3 inflammasome. Active, IL-1B, IL-18 maturation IL-1 sharp S, IL-18 Pro, IL-1 sharp S Pro, IL-18. Atherosclerosis 499. Artery lumen. Intimate. Figure 11.11. The role of cholesterol crystals in inflammasome activation and interleukin-1 production in atherosclerotic plaque. Oxidized low density lipoprotein LDL leads to the activation of subendothelial macrophages through toll-like receptor TLR-mediated initiation of downstream NF-KB transcription factor activation. The NF-kappa complex then induces the production of a variety of pro-inflammatory mediators, including interleukin precursors and the components of the NLRP3 inflammasome. Uptake of oxidized LDL and subsequent cholesterol crystallization results in assembly of the precursor components into an active inflammasome complex that proteolytically activates the pro-interleukin 1 beta IL-1B and interleukin 18 IL-18 molecules. Modified from LIX, steroid N, malate C. The role of the inflammasome in cardiovascular disease. J. Malmed Burrow 9237, 319, 2014. Overview. Fig. 11.12 summarizes the major pathogenic pathways in atherogenesis, emphasizing the multifactorial nature of the disease. This schematic highlights the concept of atherosclerosis as a chronic inflammatory response, ultimately an attempt at vascular healing, driven by a variety of insults including EC injury, lipid oxidation, lipid accumulation, and inflammation. Atheromas are dynamic lesions consisting of dysfunctional ECs, proliferating SMCs, and admixed T lymphocytes and macrophages. All four cell types are capable of liberating mediators that can influence atherogenesis. Thus, at early stages, intimal plaques are little more than aggregates of SMCs, macrophages, and foam cells. Death of these cells releases lipids and necrotic debris. With progression, the atheroma is modified by ECM synthesized by SMC. Connective tissue is particularly prominent on the intimal aspect, forming a fibrous cap. Lesions typically retain a central core of lipid, laden cells and fatty debris that can become calcified. Although the intimal plaque can initially cause medial remodeling and outward expansion, the growing atherosclerotic plaque, with varying degrees of calcification depending on the nature of the surrounding matrix, eventually encroaches on the vessel lumen and compromises blood flow. The plaque can also compress the underlying media, leading to its degeneration, or can erode or rupture to expose thrombogenic factors resulting in thrombus formation and acute vascular occlusion. Morphology: fatty streaks. Fatty streaks are composed primarily of lipid-filled foamy macrophages, beginning as small flat yellow macules. These can eventually coalesce into elongated streaks ICM long or longer. The lesions are not particularly raised and do not cause any significant flow disturbance. Fig. 11.13. Although fatty streaks can evolve into plaques, not all are destined to become advanced lesions. Aortas of infants can exhibit fatty streaks, and such lesions are present in virtually all adolescents, even those without known risk factors. That coronary fatty streaks begin to form in adolescence at the same anatomic sites that later tend to develop plaque suggests a temporal evolution of these lesions. Atherosclerotic plaque. The key processes in atherosclerosis are intimal thickening and lipid accumulation. See Figs 11.7, 11.10, and 11.12. Athermatous plaques are yellow, tan, and are raised above the surrounding vessel wall. Any superimposed thrombus over ulcerated plaques will be red, brown. Plaques vary in size but can coalesce to form larger masses. Fig. 11.14. Atherosclerotic lesions are patchy and rarely circumferential, usually involving only a portion of any given arterial wall. On cross section, the lesions therefore appear eccentric. Fig. 11.15a. The focality of atherosclerotic lesions, despite the uniform exposure of vessel walls to such factors as cigarette smoke, toxins, elevated LDL, hyperglycemia, etc., is attributable to the vagaries. 500 chapter Roman II blood vessels, hyperlipidemia, hypertension, smoking, toxins, hemodynamic factors, immune reactions, viruses, endothelial injury/dysfunction, lumen, endothelium, intima internal, elastic membrane, media, LDL, LDL cytokines, monocyte adhesion, and immigration into intimate cholesterol efflux via HDL. For example, IL-1, MCP-1, oxidized LDL, macrophage, T-cell cytokines, for example, interferon, Y, lipid uptake, smooth muscle cells, growth factors, extracellular matrix synthesis, foam, cells proliferation of smooth muscle cells, extracellular lipids and necrotic cells, recruitment and migration of smooth muscle cells, normal vessel progressive development of atherosclerotic plaque. Figure 11.12 sequence of cellular interactions in atherosclerosis, hyperlipidemia, hyperglycemia, hypertension, and other influences cause endothelial dysfunction. This results in platelet and monocyte adhesion, with subsequent cytokine and growth factor release leading to smooth muscle cell migration and proliferation. Foam cells and athermatous plaques derive from macrophages and smooth muscle cells that have accumulated modified lipids, for example, oxidized and aggregated low density lipoprotein LDL via scavenger and LDL receptor related proteins. Extracellular lipid is derived from exudation from the vessel lumen, particularly in the presence of hypercholesterolemia, as well as from degenerating foam cells. Cholesterol accumulation in the plaque reflects an imbalance between influx and efflux. High density lipoprotein HDL likely helps clear cholesterol from these accumulations. In response to the elaborated cytokines and chemokines, smooth muscle cells migrate to the intima, proliferate, and produce extracellular matrix including collagen and proteoglycans. IL-1, interleukin, 1, MCP-1, monocyte chemoattractant protein, I. Figure 11.13 fatty streak, a collection of foamy macrophages in the intima, aorta with fatty streaks arrows, associated largely with the ostia branch vessels. A photomicrograph of fatty streak in an experimental hypercholesterolemic rabbit, demonstrating intimal, macrophage, derived foam cells arrows. B. Courtesy Myron I. Saboski, MD, University of Toronto, Toronto, Ontario, Canada. Atherosclerosis 501. A B. Figure 11.14 gross views of atherosclerosis in the aorta. Mild atherosclerosis composed of fibrous plaques, one of which is denoted by the arrow. B. Severe disease with diffuse, complicated lesions including an ulcerated plaque open arrow and a lesion with overlying thrombus closed arrow. Vascular hemodynamics. Local flow disturbances, such as nonlaminar flow turbulence at branch points, make certain portions of a vessel wall more susceptible to plaque formation. Although initially focal and sparsely distributed, atherosclerotic lesions tend to enlarge over time and become more numerous and broadly distributed. Moreover, in any given vessel, lesions at various stages often coexist. In descending order, the most extensively involved vessels are the lower abdominal aorta and iliac arteries, the coronary arteries, the popliteal arteries, the internal carotid arteries, and the vessels of the circle of Willis. Vessels of the upper extremities are usually relatively spared, as are the mesenteric and renal arteries except at their osteo. Although most individuals tend to have a consistent degree of atherosclerotic burden in the affected vasculature, the severity of disease in one arterial distribution does not necessarily predict severity in another. Atherosclerotic plaques have four principal components: 1 cells including variable numbers of SMCs, macrophages, and T lymphocytes, 2 ECM including collagen, elastic fibers, and proteoglycans, 3 intracellular and extracellular lipids, and 4 calcifications and later stage plaques Fig. 11, 15, B, and C. These components occur in varying proportions and configurations in different lesions. Typically, there is a superficial fibrous cap composed of SMCs and relatively dense collagen. Beneath and to the side of the cap, the shoulder is a more cellular area containing macrophages, T lymphocytes, and SMCs. Deep to the fibrous cap is a necrotic core containing lipid, primarily cholesterol and cholesterol esters, debris from dead cells, foam cells, lipid-laden macrophages, and lipid-laden SMCs, fibrin, thrombus, and varying degrees of organization, and other plasma proteins. The cholesterol content is frequently present as crystalline aggregates that are washed out during routine tissue processing. LFC, a BC figure 11.15 necrotic core C containing cholesterol and other lipids. The lumen arrow. The lesion is therefore eccentric. In this section, collagen has been stained blue mass and trichome stain. The higher power photograph of a section of the plaque shown in a stain for elastin black, demonstrating that the internal and external elastic membranes are attenuated and the media of the artery is thin under the most advanced plaque arrow. See high magnification photomicrograph at the junction of the fibrous cap and core showing scattered inflammatory cells, calcification arrowhead, and neovascularization small arrows. Histologic features of atheromatous plaque in the coronary artery. Overall architecture demonstrating fibrous cap F and a central L has been moderately compromised. Note that a segment of the wall is plaque-free. Chapter 11, Blood Vessels. Figure 11.16, a plaque rupture without superimposed thrombus in a patient who died suddenly. The acute coronary thrombosis superimposed on an atherosclerotic plaque with focal disruption of the fibrous cap, triggering fatal myocardial infarction. In both A and B, an arrow points to the site of plaque rupture. B. Reproduced from Scone FJ. Interventional and surgical cardiovascular pathology. Clinical correlations and basic principles. Philadelphia. 1989, W.B. Saunders, P61. Atherosclerotic plaque rupture, a B, and leave behind only empty clefts. The periphery of the lesions demonstrate neovascularization proliferating small blood vessels Fig. 11, 15C. Most atheromas contain abundant lipid, but some plaques, fibrous plaques, are composed almost exclusively of SMCs in fibrous tissue, which can be heavily calcified. Plaques generally continue to change and progressively enlarge as a consequence of cell death and degeneration, synthesis and degradation, remodeling of ECM, organization of any superimposed thrombus, and secondary calcification of phospholipid or necrotic debris. See Fig. 11, 15C. Atherosclerotic plaques are susceptible to clinically important pathologic changes. As discussed further later, the thickness and ECM content of the overlying fibrous cap will impact the stability or fragility of the plaque and its tendency to undergo secondary changes. Rupture, ulceration, or erosion of the surface of atheromatous plaques exposes the bloodstream to highly thrombogenic substances and leads to thrombosis, which can partially or completely occlude the vessel lumen. Fig. 11, 16. If the patient survives, the thrombus may organize and become incorporated into the growing plaque. Hemorrhage into a plaque. Rupture of the overlying fibrous cap or of the thin-walled vessels in the areas of neovascularization can cause intraplaque hemorrhage. A contained hematoma may Expand the plaque or induce plaque rupture. Atherombolism. Plaque rupture can discharge atherosclerotic debris into the bloodstream, producing microemboli. Aneurysm formation. Atherosclerosis induced pressure or ischemic atrophy of the underlying media with loss of elastic tissue causes weakness and potential rupture. Consequences of atherosclerotic disease: myocardial infarction, heart attack, cerebral infarction, stroke, aortic aneurysms, and peripheral vascular disease. Gangrene of the legs are the major consequences of atherosclerosis. Large elastic arteries, for example, aorta, carotid, and iliac arteries, and large and medium-sized muscular arteries, for example, coronary and popliteal arteries, are the major targets of atherosclerosis. Symptomatic atherosclerotic disease most often involves the arteries supplying the heart, brain, kidneys, and lower extremities. The natural history, principal morphologic features, and main pathogenic events are schematized in Fig. 1117502. We next describe the features of atherosclerotic lesions that are typically responsible for the clinical pathologic manifestations. Atherosclerotic stenosis. In small arteries, atherosclerotic plaques can gradually occlude vessel lumens, compromising blood flow and causing ischemic injury. At early stages of stenosis, outward remodeling of the vessel media tends to preserve the size of the lumen. However, there are limits on the extent of remodeling, and eventually the expanding atheroma impinges on the lumen to such a degree that blood flow is compromised. See Fig. 11.17. Critical stenosis is the stage at which the occlusion is sufficiently severe to cause tissue ischemia. In the coronary and other circulations, this typically occurs when the occlusion produces a 70% to 75% decrease in luminal cross-sectional area. With this degree of stenosis, chest pain may develop with exertion, so-called stable angina. See Chapter 12. Although acute plaque rupture, see later, is the most dangerous consequence, atherosclerosis also takes a toll through chronically diminished arterial perfusion, mesenteric occlusion and bowel ischemia, sudden cardiac death, chronic ischemic heart disease, ischemic encephalopathy, and intermittent claudication. Diminished perfusion of the extremities all are consequences of flow-limiting stenosis. The effects of vascular occlusion ultimately depend on arterial supply and the metabolic demand of the affected tissue. If stenosis occurs slowly, smaller adjacent vessels can partially compensate by enlarging and creating collateral circulation to perfuse the organ. Acute plaque change. Plaque erosion or rupture is typically promptly followed by partial or complete vascular thrombosis. See Fig. 11.16, resulting in acute tissue infarction, for example, myocardial or cerebral infarction. See Fig. 11.17. Plaque changes fall into three general categories: rupture/fissuring, exposing highly thrombogenic plaque constituents that activate coagulation and induce thrombosis that is often completely occlusive; erosion/ulceration, exposing the thrombogenic subendothelial basement membrane to blood, less frequently inducing fully occlusive thrombosis; hemorrhage into the atheroma, expanding its volume. It is now recognized that the plaques that are responsible for myocardial infarction and other acute coronary 503 plaque progression, sudden events, outcomes: thin cap plaque rupture, sudden cardiac death, normal fatty streak, pathologic intimal thickening, plaque expansion, thick cap erosion, and thrombosis. Lumen, risk factors: endothelial dysfunction, monocyte adhesion/immigration, smooth muscle migration to intimate extracellular matrix, elaboration, lipid accumulation, expansion of outer wall to maintain internal diameter. Until the 40% stenosis, inner diameter begins to narrow. Fibrotic plaque, fibrocalcific plaque. Critical stenosis. Figure 11.17 form, which can progress to atherosclerosis. Compensatory enlargement become a thin cap plaque unstable, vulnerable, a thick cap plaque stable, or a fibrotic plaque stable. Thin cap plaques are the most prone to plaque rupture, generally leading to sudden cardiac death. Stable plaques can undergo surface erosion and thrombosis, rapidly expanding the plaque size and leading to more prominent calcifications. This event can lead to sudden cardiac death. Extensive narrowing of the luminal diameter from large plaques generally results in critical stenosis, reducing blood supply to the heart and resulting in angina. Atherosclerotic plaque formation, activities, and outcomes. In a lesion-prone area, along with other risk factors, or reversible fatty streakers, initially prevents a reduction of blood flow through the vessel. Plaque syndromes are often asymptomatic before undergoing a sudden, typically unpredictable change. Thus, pathologic and clinical studies show that the majority of plaques that undergo abrupt disruption and coronary occlusion previously showed only mild to moderate non-critical luminal stenosis. Thus, a large number of asymptomatic adults may be at risk for a catastrophic coronary event. Although imaging modalities are being developed that could preemptively identify such lesions, it is clear that standard angiographic studies are woefully inadequate to visualize them until after the fact. Plaques rupture when they are unable to withstand mechanical stresses generated by vascular shear forces. The events that trigger abrupt changes in plaques and subsequent thrombosis are complex and include both intrinsic factors, for example, plaque structure and composition, and extrinsic elements, for example, blood pressure, platelet reactivity, and vessel spasm. The fibrous cap undergoes continuous remodeling that can stabilize the plaque or, conversely, render it more susceptible to rupture. Collagen is the major structural component of the fibrous cap and accounts for its mechanical strength and stability. The balance of collagen synthesis versus degradation affects cap integrity. Thus, plaques with thin fibrous caps and active inflammatory cells over a necrotic core are more likely to rupture. These are referred to as vulnerable plaques. Fig. 11.18. Collagen in atherosclerotic plaque is produced primarily by SMCs, so that loss of these cells results in a less sturdy cap. Moreover, collagen turnover is controlled by metalloproteinases (MMPs), enzymes elaborated largely by macrophages and SMCs within the athermatous plaque. Conversely, tissue inhibitors of metalloproteinases TIMPs produced by ECs, SMC, and macrophages modulate MMP activity. In general, plaque inflammation results in a net increase in collagen degradation and reduced collagen synthesis, thereby destabilizing the mechanical integrity of Figure 11.18 have thickened and densely collagenous fibrous caps with minimal inflammation and underlying athermatous core. Vulnerable plaques have thin fibrous caps, large lipid cores, and increased inflammation. Modified from LibP, molecular basis of the acute coronary syndromes, circulation 91-2844, 1995. Atherosclerosis. Vulnerable and stable atherosclerotic plaque. Stable plaques. 504 Chapter 11 Blood vessels. The fibrous cap. See later. The inflammation induced by cholesterol deposits themselves may contribute to plaque destabilization. Conversely, statins may have a beneficial therapeutic effect not only by reducing circulating cholesterol levels but also by stabilizing plaques through a reduction in plaque inflammation. Influences extrinsic to plaques also contribute to acute plaque changes. Adrenergic stimulation can increase systemic blood pressure or induce local vasoconstriction, thereby increasing the physical stresses on a given plaque. Indeed, the adrenergic stimulation associated with awakening and rising can cause blood pressure spikes followed by heightened platelet reactivity that have been causally linked to the pronounced circadian periodicity for onset of acute myocardial infarction peaking between 6 a.m. and 12 noon. Intense emotional stress can also contribute to plaque disruption. This is most dramatically illustrated by the uptick in the incidence of sudden death associated with natural or other disasters, such as earthquakes and the September 11, 2001, attack on the World Trade Center. It is also important to note that not all plaque ruptures result in occlusive thrombosis with catastrophic consequences. Indeed, plaque disruption and an ensuing superficial platelet aggregation and thrombosis are probably common, repetitive, and often clinically silent complications of atheroma. Healing of these subclinical plaque disruptions and organization of their overlying thrombi is an important mechanism in the growth of atherosclerotic lesions. Thrombosis, partial or total, associated with the disrupted plaque is a central factor in acute coronary syndromes. In its most serious form, thrombus leads to total occlusion of the affected vessel. In contrast, in other coronary syndromes, Chapter 12, luminal obstruction by the thrombus is incomplete and may even wax and wane with time. Mural thrombi in a coronary artery can also embolize. Small embolic fragments of thrombus can often be found in the distal intramyocardial circulation or in association with microinfarcts in patients with atherosclerosis who die suddenly. Thrombin and other factors associated with thrombosis are potent activators of SMCs and can thereby contribute to the growth of atherosclerotic lesions. Vasoconstriction compromises lumen size and, by increasing the local mechanical forces, can potentiate plaque disruption. Vasoconstriction at sites of atheroma may be stimulated by 1 circulating adrenergic agonist, 2 locally released platelet contents, 3. EC dysfunction with impaired secretion of endothelial-derived relaxing factors no relative to contracting factors endothelin, and 4. Mediators released from perivascular inflammatory cells. Key concepts: atherosclerosis. Atherosclerosis is an intimal-based lesion composed of a fibrous cap and an atheromatous core. The constituents of the plaque include SMCs, ACM, inflammatory cells, calcifications, lipids, and necrotic debris. Atherogenesis is driven by an interplay of vessel wall injury and inflammation. The multiple risk factors for atherosclerosis all cause EC dysfunction and influence inflammatory cell and SMC recruitment and stimulation. Atherosclerotic plaques develop and generally grow slowly over decades. Stable plaques can produce symptoms related to chronic ischemia by narrowing vessel lumens, whereas unstable plaques can cause dramatic and potentially fatal ischemic complications related to acute plaque rupture, thrombosis, or embolization. Stable plaques tend to have a dense fibrous cap, minimal lipid accumulation, and little inflammation, whereas vulnerable, unstable plaques have thin caps, large lipid cores, and relatively dense inflammatory infiltrates. Aneurysms and dissection. An aneurysm is a localized abnormal dilation of a blood vessel or the heart that may be congenital or acquired. Fig. 11.19. When an aneurysm involves all the layers of an intact but attenuated arterial wall or the thin ventricular wall of the heart, it is called a true aneurysm. Atherosclerotic and congenital vascular aneurysms and ventricular aneurysms that follow transmural myocardial infarctions. Extravascular connective tissue extravasation. Blood tear-in. Intima extravasation of blood. Dissection. Hematoma. A. Normal vessel. B. True aneurysm saccular. C. True aneurysm fusiform. D. False aneurysm. E. Dissection. Figure 11.19. Aneurysms. The normal vessel. B. True aneurysm. Saccular type. The wall focally bulges outward and may be attenuated but is otherwise intact. C. True aneurysm. Fusiform type. There is circumferential dilation of the vessel without rupture. D. False aneurysm. The wall is ruptured, and there is a collection of blood hematoma that is bounded externally by adherent extravascular tissues. E. Dissection. Blood has interdissected the wall of the vessel and separated the layers. Although this is shown as occurring through a tear in the lumen, dissections can also occur by rupture of the vessels of the vasa vasorum within the media. Aneurysms in dissection 505 are of this type. In contrast, a false aneurysm, also called a pseudoaneurysm, is a defect in the vascular wall leading to an extravascular hematoma that freely communicates with the intravascular space pulsating hematoma. Examples include a ventricular rupture after myocardial infarction that is contained by a pericardial adhesion or a leak at the suture junction of a vascular graft with a natural artery. An arterial dissection arises when blood enters a defect in the arterial wall and tunnels through medial or medial adventitial planes. Dissections are often, but not always, aneurysmal. See later. Both true and false aneurysms as well as dissections can rupture, often with catastrophic consequences. Descriptively, aneurysms are classified by macroscopic shape and size. See Fig. 11.19. Saccular aneurysms are essentially spherical outpouchings involving only a portion of the vessel wall. In intracranial vessels they generally measure 2 to 20 mm. However, in the aorta they range from 5 to 10 cm in diameter and often contain thrombus. Fusiform aneurysms involve diffuse, circumferential dilation of a lone vascular segment. They vary in diameter in the aorta, generally from 5 to 10 cm, and can involve extensive portions of the aortic arch, abdominal aorta, or even the iliacs. These types are not specific for any disease or clinical manifestations. Pathogenesis: to maintain their structural and functional integrity, arterial walls constantly remodeled by synthesizing, degrading, and repairing damage to their ECM constituents. Aneurysms can occur when the structure or function of the connective tissue within the vascular wall is compromised. Defects in synthesis or breakdown of connective tissue contribute to the pathobiology of both heritable aneurysmal diseases, as well as the common, sporadic forms of aneurysms. These defects include the following. The intrinsic quality of the vascular wall connective tissue is poor. Weak vessel walls due to defective type Roman III collagen synthesis are a hallmark of the vascular form of Ehlers-Danlos syndrome. Chapter 5. Abnormal transforming growth factor beta TGF-beta signaling. Excessive TGF-beta activity alters vascular wall remodeling, primarily of the ascending aorta, leading ultimately to diminished ECM content and integrity with aneurysmal dilation. And Marfan syndrome. Chapter 5. Defective synthesis of the scaffolding protein fibrillin leads to the inability to appropriately sequester endogenously produced TGF-beta. In Loeys Diet syndrome, increased activity in the TGF-beta signaling pathway can result from mutations in TGF-beta receptors, an intracellular downstream signaling molecule in the TGF-beta pathway isomer D3, and even TGF-beta 3 itself. Aneurysms in patients with Loeys Diet syndrome can rupture at small sizes and are thus considered to follow an aggressive course. The balance of collagen degradation and synthesis is altered by inflammation and associated proteases. Inflammatory cells in the setting of an aortitis or associated with atherosclerosis can be found throughout the aortic wall. Increased MMP production, especially by macrophages, can contribute to aneurysm development by degrading ECM elastin, collagens, proteoglycans, laminin, fibronectin in all layers of the wall. Decreased expression of TIMP can also impact ECM degradation. Both processes result in a loss of elastic fibers necessary for recoil and diastole. Genetic predisposition to aneurysm formation in the setting of inflammatory lesions, for example. Atherosclerosis may be related to MMP and or TIMP polymorphisms or to the nature of the local inflammatory response. Indeed, abdominal aortic aneurysms, as seen later, are associated with shifts in the local cytokine environments toward the production of T helper 2 cytokines, for example, IL-4 and IL-10, that can drive macrophages to produce increased amounts of elastolytic MMP. The vascular wall is weakened through loss of SMCs or the inappropriate synthesis of non-collagenous or non-elastic ECM. Ischemia of the inner media occurs when there is atherosclerotic thickening of the intima, increasing the distance that oxygen and nutrients must diffuse. Systemic hypertension can also cause significant narrowing of arterioles of the vasa vasorum, for example, in the aorta, which causes outer medial ischemia. Tertiary syphilis is another rare cause of aortic aneurysms in which obliterative endarteritis occurs in the vasa vasorum of the thoracic aorta. This engenders medial ischemia that leads to SMC loss, elastic fiber loss, and inadequate or inappropriate ECM synthesis. All of the above described processes lead to histopathologic changes in the arterial wall referred to as medial degeneration, Fig. 11.20. Although adventitial lymphoplasmacytic 8b figure 11.20 media from a patient with Morphin syndrome showing marked elastin fragmentation and formation of areas devoid of elastin that resemble cystic spaces but are actually filled with increased amounts of proteoglycans asterisks. Normal media for comparison showing the regular layered pattern of elastic tissue. In both A and B, elastin is stained black. Cystic medial degeneration. Cross-section of aortic. Chapter 11, blood vessels. Inflammation can suggest syphilis. And clinical features, for example, skeletal changes in Morphin syndrome can suggest a potential genetic underpinning. Medial degeneration is a nonspecific finding common to all forms of aortic disease. The two most important causes of aortic aneurysms are atherosclerosis and hypertension. Atherosclerosis is a greater factor in AAAs, while hypertension is the most common etiology associated with ascending aortic aneurysms. Other pathologies and risk factors that weaken vessel walls and lead to aneurysms include advanced age, smoking, trauma, vasculitis, see later, congenital defects, for example, fibromuscular dysplasia, and berry aneurysms typically in the circle of Willis. See Chapter 28, and infections. Mycotic aneurysms. Mycotic aneurysms can originate from 1, embolization of a septic embolus, usually as a complication of infective endocarditis, 2, extension of an adjacent suppurative process, or 3, circulating organisms directly infecting the arterial wall. Abdominal aortic aneurysm. Aneurysms occurring as a consequence of atherosclerosis form most commonly in the abdominal aorta and common iliac arteries. A variety of factors discussed earlier collaborate to weaken the media and predispose to aneurysm formation. AAs occur more frequently in men and in smokers, rarely developing before age 50. Atherosclerosis is a major cause of AAs, but other factors clearly contribute, since the incidence is 5% in men older than age 60, despite almost universal abdominal aortic atherosclerosis in that population. 506. Morphology usually located between the renal arteries and the bifurcation of the aorta. AAs can be saccular or fusiform, greater than 3 cm, but often 5 cm in diameter, and up to 25 cm in length. Fig. 11.21. There is severe complicated atherosclerosis with destruction and thinning of the underlying aortic media. Aneurysm frequently contains a bland, poorly organized mural, thrombus, AAs can occasionally affect the renal and superior or inferior mesenteric arteries, either by direct extension or by occluding vessel ostia with mural thrombi. Not infrequently, AAs will be accompanied by smaller aneurysms of the iliac arteries. 3 AA variants merit special mention. Inflammatory AAs account for 5% to 10% of all AAs. These typically occur in younger patients who often present with back pain and elevated inflammatory markers, for example, erythrocyte sedimentation rate. Inflammatory aneurysms are characterized by abundant lymphoplasmacytic inflammation with many macrophages and even giant cells associated with dense aortic scarring that can extend into the anterior retroperitoneum. The cause is a presumed localized immune response to the abdominal aortic wall. Remarkably, most cases are not associated with inflammation of other arteries. A subset of inflammatory AAs may be a vascular manifestation of immunoglobulin G4 related disease G4RD. This is a disorder marked by, in most cases, high circulating levels of G4 with storiform fibrosis and G4 positive infiltrating plasma cells in affected tissues. It may affect a host of organs, including the pancreas and thyroid, as well as other vascular sites such as the ascending aorta and heart vessels. There may be retroperitoneal fibrosis with bilateral hydronephrosis. Recognition of this entity is important since it responds well to steroid and anti-B-cell therapies. Mycotic AAs are lesions that have become infected by the lodging of circulating microorganisms in the wall. In such cases, suppuration further destroys the media, potentiating rapid dilation and rupture. Clinical features: most cases of AAs are completely asymptomatic and are discovered incidentally on physical examination as an abdominal mass, often palpably pulsating, that simulates a tumor. The other clinical manifestations of AAs include rupture into the peritoneal cavity or retroperitoneal tissues with massive, potentially fatal hemorrhage, obstruction of a branch vessel resulting in downstream tissue ischemic injury, for example, iliac leg, renal kidney, mesenteric gastrointestinal tract, or vertebral artery spinal cord, embolism from atheroma or mural thrombus, impingement on an adjacent structure, for example, compression of the ureter or erosion of vertebrae. The risk of rupture is directly related to the size of the aneurysm, varying from nil for AAs 4 cm in diameter to 1% per year for AAs between 4 and 5 cm, 11% per year for AAs between 5 and 6 cm, and 25% per year for aneurysms 6 cm. Most aneurysms expand at a rate of 0.2 to 0.3 cm/year, but 20% expand more rapidly. In general, aneurysms 5 cm are managed aggressively, either through B figure 11.21 photograph of a large aortic aneurysm that rupture site is indicated by the arrow. The open view, with the location of the rupture tract indicated by a probe. The wall of the aneurysm is exceedingly thin, and the lumen is filled by a large quantity of layered but largely unorganized thrombus. Abdominal aortic aneurysm. External view, gross, and dissection 507. Open surgeries involving prosthetic grafts or endovascular approaches through the femoral artery deploying a stent graft expandable wire frame covered by a cloth sleeve. Timely surgery is critical. Operative mortality for unruptured aneurysms is approximately 5%, whereas emergency surgery after rupture carries a mortality rate of more than 50%. It is worth reiterating that because atherosclerosis is a systemic disease, a patient with an AA is also very likely to have atherosclerosis in other vascular beds and is at a significantly increased risk of ischemic heart disease and stroke. Thoracic aortic aneurysm. Thoracic aortic aneurysms are most commonly associated with hypertension, although other causes such as Marfan syndrome, Loeys Dietz syndrome, and inflammatory conditions, aortitis, are increasingly recognized. Before dissection or rupture, symptoms can include 1. Chest pain from encroachment or erosion into bone, 2. Myocardial ischemia from compression of a coronary artery, 3. Difficulty swallowing due to compression of the esophagus, 4. Hoarseness from irritation of or pressure on the recurrent laryngeal nerves, or 5. Respiratory complications from compression of the bronchi. The vast majority cause no symptoms at all until a catastrophic event occurs. See later. Aortic dissection. Aortic dissection occurs when blood separates the laminar planes of the media to form a blood-filled channel within the aortic wall. Fig. 11.22. Aortic dissection is generally associated with aortic dilation, It can be disastrous if the dissection then ruptures through the adventitia and hemorrhages into adjacent spaces. Aortic dissection occurs principally in two groups of patients, one men aged 40 to 60 years, with antecedent hypertension more than 90% of cases, and two younger patients with syndromic diseases affecting the aorta, for example, Morphin syndrome. Dissections can be iatrogenic, for example, following arterial cannulations during diagnostic catheterization or cardiopulmonary bypass. Pregnancy is also rarely associated with aortic or other vessel dissection, roughly 10 to 20 cases per 1 million births, typically occurring during or after the third trimester. It may be related to hormonally induced vascular remodeling and the hemodynamic stresses of the perinatal period. Dissection is unusual in the presence of substantial atherosclerosis or other cause of medial scarring, such as syphilis, presumably because the medial fibrosis inhibits propagation of the dissecting hematoma. Pathogenesis. Hypertension is the major risk factor for aortic dissection. Aortas of hypertensive patients have medial degenerative changes with SMC loss and altered ECM content. Other dissections occur in the setting of inherited or acquired connective tissue disorders with defective TGF-beta signaling or defective ECM synthesis or degradation. However, specific patterns of medial damage are neither a prerequisite for dissection nor a reliable predictor of its occurrence. Regardless of the underlying etiology, the ultimate trigger for the intimal tear and initial intramural aortic hemorrhage is not known in most cases. Nevertheless, once the tear has occurred, blood flow under systemic pressure dissects through the media, leading to progression of the hematoma. Accordingly, aggressive pressure-reducing therapy may be effective in limiting and evolving dissection. In some cases, disruption of penetrating vessels of the vasa vasorum can give rise to an intramural hematoma without an intimal tear. Morphology. In most cases of dissection, medial degeneration is present at the site of tear but may not be seen in the area of propagation. These typically feature elastic fiber fragmentation and loss, mucoid ECM accumulation, and SMC attrition. See Fig. 11:20. Inflammation is characteristically absent. Dissections can occur in the setting of rather trivial medial degeneration. Conversely, marked degenerative changes are frequently seen at autopsies of patients who are completely free from dissection. Thus, the relationship of the structural changes to the pathogenesis of dissection is uncertain. Aneurysms. A B Figure 11.22 aortic dissection. A gross photograph of an open aorta with proximal dissection originating from a small, oblique intimal tear probe, allowing blood to enter the media and creating a retrograde intramural hematoma. Thin arrows. Note that the intimal tear has occurred in a region largely free of atherosclerotic plaque, and that propagation of the intramural hematoma distally is arrested where atherosclerosis begins. Thick arrow. The histologic view of dissection demonstrating an aortic intramural hematoma asterisk. Aortic elastic layers are black and blood is red movage stain. Chapter 11. Blood vessels. An aortic dissection usually initiates with an intimal tear. In the vast majority of spontaneous dissections, the tear occurs in the ascending aorta, usually within 10 cm of the aortic valve. See Fig. 11:22a. Such tears are typically transverse with sharp, jagged edges up to 1 to 5 cm in length. The dissection can extend retrograde toward the heart as well as distally, sometimes as far as the iliac and femoral arteries. The dissecting hematoma spreads characteristically between lamellar units of the outer third of the media or between media and adventitial layers. See Fig. 11:22b. It can rupture through the adventitia, causing massive hemorrhage, for example, into the thoracic or abdominal cavities, or cardiac tamponade hemorrhage into the pericardial sac. In some fortuitous instances, the dissecting hematoma re-enters the lumen of the aorta through a second distal intimal tear, creating a new false vascular channel, double-barreled aorta. This averts a fatal extra-aortic hemorrhage, and over time, such false channels can be endothelialized to become recognizable chronic dissections. Traumatic chest injury, for example, motor vehicle accident, or even extremely vigorous cardiopulmonary resuscitation can cause intimal tears that originate after the origin of arch vessels at the ligamentum arteriosum. In such cases, the connective tissue that tethers the aorta and pulmonary vessels in that location can lead to aortic tearing when there is sudden extreme movement of the heart toward the anterior chest wall. DeBakey Figure 11.23 ascending aorta, either as part of a more extensive dissection DeBakey or in isolation DeBakey Roman II. Type B distal or DeBakey Roman III dissections arise after the takeoff of the great vessels. Type of dissections typically have the most serious complications and greatest mortality. Classification of dissections. Type of proximal involves the clinical features. The morbidity and mortality associated with dissections depends on which part of the aorta is involved. The most serious complications occur with dissections between on whether a patient is a surgical candidate and other aortic valve and the distal arch. Accordingly, aortic dissect. Prognostic factors. Most type B dissections can be managed times are generally classified into two types: Fig. 11, 23, conservatively. Such patients have a short-term 75% survival. Type of dissections. These are the more common and rate whether they are treated with surgery or anti-hyperdangerous proximal lesions involving either both the tensive medication only, ascending and the descending aorta, or the ascending aorta only. Types I am Roman 2 of the DeBakey classification. Key concepts. Type B dissections. Distal lesions not involving the ascending aorta and usually beginning distal to the subclavian aneurysms and dissections artery called DeBakey type Roman 3. Vascular aneurysms are congenital or acquired dilations of the blood vessels that involve the entire thickness of the wall. The classic clinical symptoms of aortic dissection are the plications are related to rupture, thrombosis, and embolization. Sudden onset of excruciating pain, usually beginning in the dissections, occur when blood enters the wall of a vessel and anterior chest, radiating to the back between the scapulae, dissects through the layers generally between lamellar units, and moving downward as the dissection progresses. The complications arise due to rupture or obstruction of vessels. Pain can be confused with that of myocardial infarction. Branching off the aorta. The most common cause of death is rupture of the disc. Aneurysms and dissections result from structural weakness of section and bleeding into the pericardial, pleural, or peritoneal, the vessel wall, caused by aberrant TGF-beta signaling, loss of SMCs, cavities. Retrograde dissection into the aortic root can also, and changes in the ECM, which can result from ischemia, genetic disrupt the aortic valve annulus. Common clinical manifested defects or defective matrix remodeling. Signs include cardiac tamponade and aortic insufficiency. Dissections can also extend into the great arteries of the neck or into the coronary, renal, mesenteric, or iliac arteries, causing vascular obstruction and ischemic consequences. Vasculitis, such as myocardial infarction, involvement of spinal arteries, can cause transverse myelitis. Vasculitis is a general term for vessel wall inflammation. In type of dissections, rapid diagnosis and institution of with protein manifestations depending on the vascular bed. Intensive antihypertensive therapy coupled with surgical effective. For example, central nervous system versus heart versus small bowel. Application of the aortic tear can save 65% to 85% of patients. Besides the findings referable to the specific tissues involved, however, mortality approaches 70% in those who present the clinical manifestations. Typically include constitutional with hemorrhage or symptoms related to distal ischemia, signs and symptoms associated with systemic inflammation, and the overall 10-year survival is 40% to 88% depending, such as fever, myalgias, arthralgias, and malaise. 508. Type A, DeBakey Roman 2 DeBakey. Type B, Roman 3. Vasculitis. 509. Primary forms of vasculitis: granulomatosis, churn, giant cell with Strauss polyarteritis, leukocytoclastic buogebasic arteritis, polyangiitis syndrome, nodosa vasculitis, disease. Sites of involvement: aorta plus, medium size plus arteries, small size plus arteries, capillaries plus veins plus inflammatory cells present. Lymphocytes plus or minus macrophages plus or minus neutrophils rare plus or minus required. Eosinophils very rare plus or minus required plus or minus. Other features: granulomas plus or required or plus or minus. Giant cells often not plus or minus required. Thrombosis plus or minus required plus or minus. Serum anchor plus or minus. Positivity. Clinical 40 years old, any asthma, atopy, any young male, oral general history plus or minus polymyalgia, smoker, ulcers, rheumatic. of the granulomas of giant cell arteritis are found within the vessel wall as part of the inflammation comprising the vasculitis but need not be present to render the diagnosis. The granulomas of granulomatosis with polyangiitis are larger, spanning between vessels, and associated with areas of tissue necrosis. ANCA, antineutrophil cytoplasmic antibody, from Saban M.A., Mitchell R.N., Surgical Pathology of Small and Medium-Sized Vessels, Circ Pathol Clin 543 2012. Table 11.4. Vessels of any type and virtually any organ can be affected. Most vasculitides affect small vessels ranging from arterioles to capillaries to venules. Nevertheless, several vasculitides tend to affect only vessels of a particular size or location. Thus, there are entities that primarily affect the aorta and medium-sized arteries, while others principally affect only smaller arterioles. Some 20 primary forms of vasculitis are recognized, and classification schemes attempt with variable success to group them according to vessel diameter, wall of immune complexes, presence of specific autoantibodies, granuloma formation, organ specificity, and even population demographics. Table 11.4 and Fig. 11.24. As we will see, there is considerable clinical and pathologic overlap among many of them. The two pathogenic mechanisms of vasculitis are immune-mediated inflammation and direct invasion of vascular walls by infectious pathogens. Infections can also indirectly induce a non-infectious vasculitis, for example, by generating immune complexes or triggering vascular cross-reactivity. In any given patient, it is critical to distinguish between infectious and immunologic mechanisms because immunosuppressive therapy is appropriate for immune-mediated vasculitis but could very well be counterproductive for infectious vasculitis. Physical and chemical injury, for example, from irradiation, mechanical trauma, and toxins can also cause vasculitis. Non-infectious vasculitis. The main immunologic mechanisms underlying non-infectious vasculitis are immune complex deposition, antineutrophil cytoplasmic antibodies ANCAs, anti-EC antibodies, autoreactive T cells, immune complex associated vasculitis. This form of vasculitis can be seen in immunologic disorders such as systemic lupus erythematosus SLE Chapter 6 that are associated with autoantibody production. Vascular lesions resemble those found in experimental immune complex mediated disorders such as the Arthus phenomenon and serum sickness, and in many cases contain readily identifiable antibody and complement. Often, however, this type of vasculitis presents a number of diagnostic challenges. Only rarely is the specific antigen responsible for immune complex formation identified. While immune complexes can occasionally be detected in the blood, in most cases it is not clear whether the pathogenic antigen-antibody complexes are deposited from the circulation or form in situ. Indeed, the sensitivity and specificity of circulating immune complex assays in such diseases are extremely low. In many suspected cases, even the antigen antibody. 510 Chapter 11 Blood vessels, capillaries, arterioles, venules, arteries, veins, aorta, medium vessel vasculitis, immune complex, mediated, for example, polyarteritis, nodosa, anti-endothelial cell antibodies, for example, Kawasaki disease. Vasculitis without granulomas, asthma or granulomas, no asthma. Microscopic granulomatosis, polyangiitis with polyangiitis. Paucity of immune complexes, often with ANCA, eosinophilia, asthma, and granulomas. Churg-Strauss syndrome, large vessel vasculitis. Granulomatous disease, for example, giant cell arteritis, Takayasu arteritis. Figure 11.24. Vascular sites typically involved with the more common forms of vasculitis as well as their presumptive etiologies. Note that there is a substantial overlap in distributions. ANCA, antineutrophil cytoplasmic antibody. SLE, systemic lupus erythematosus. SLE, for example, SLE vasculitis. Small vessel vasculitis, immune complex mediated cryoglobulin, for example. HEMAT, for example. Cryoglobulin Schernlein purpura vasculitis. Other, for example, Goodpasture disease. Deposits are scarce. In such instances, the immune complexes have putatively been degraded by the time of biopsy. Alternatively, other underlying mechanisms need to be considered for such pauci-immune vasculitis. Immune complex deposition is implicated in the following vasculitis: drug hypersensitivity vasculitis. In some cases, for example, penicillin, drugs act as happens by binding to serum proteins. Other agents are themselves foreign proteins, for example, streptokinase. Regardless, Antibodies directed against the drug-modified proteins or foreign molecules result in immune complex formation. The clinical manifestations can be mild and self-limiting or severe and even fatal. Skin lesions are most common. It is always important to consider drug hypersensitivity as a cause of vasculitis, since discontinuation of the offending agent usually leads to resolution. Vasculitis secondary to infections. Antibodies to microbial constituents can form immune complexes that circulate and deposit in vascular lesions. In up to 30% of patients with polyarteritis nodosa, see later, the vasculitis is attributable to immune complexes composed of hepatitis B surface antigen HBs-Ag and anti-HBs-Ag antibody. Antineutrophil cytoplasmic antibodies. Many patients with vasculitis have circulating antibodies that react with neutrophil cytoplasmic antigens, ANC. ANC are a heterogeneous group of autoantibodies directed against constituents, mainly enzymes of neutrophil primary granules, monocyte lysosomes, and ECs. ANC are very useful diagnostic markers. Their titers generally mirror clinical severity, and a rise in titers after periods of quiescence is predictive of disease recurrence. Although a number of ANC have been described, two are most important. These were previously grouped according to the intracellular distribution of the target antigens, cytoplasmic C ANC, or paranuclear P ANC, but are now classified according to their antigen specificity. Antiproteinase 3PR3 ANC, previously C ANC. Proteinase 3PR3 is a neutrophil azurophilic granule constituent that shares homology with numerous microbial peptides, possibly explaining the generation of PR3 ANC. PR3 ANC are associated with granulomatosis with polyangiitis, see later. Anti-myeloperoxidase MPO ANC, previously P ANC. Myeloperoxidase MPO is a lysosomal granule constituent involved in oxygen-free radical generation. Chapter 3. MPO ANC are induced by several therapeutic agents, particularly propylthiouracil used to treat hypothyroidism. MPO ANC are associated with microscopic polyangiitis and Churg-Strauss syndrome, see later. The close association between ANC titers and disease activity also suggests a pathogenic role for these antibodies. Of note, ANC can directly activate neutrophils, stimulating the release of reactive oxygen species and proteolytic enzymes in vascular beds. Such activation also leads to destructive interactions between inflammatory cells and ECs. While the antigenic targets of ANC are primarily intracellular and therefore not usually accessible to circulating antibodies, it is now clear that ANC antigens, especially PR3, are either constitutively expressed at low levels on the plasma membrane or are translocated to the cell surface and activated in apoptotic leukocytes. A plausible mechanism for ANC vasculitis is the following. Drugs or cross-reactive microbial antigens induce ANC formation. Alternatively, leukocyte surface expression or release of PR3 and MPO in the setting of infections incites ANC development in a susceptible host. Subsequent infection, endotoxin exposure, or inflammatory stimulus elicits cytokines such as tumor necrosis. Vasculitis 511. Factor TNF that upregulate the surface expression of PR3 and MPO on neutrophils and other cell types. ANC react with these cytokine-activated cells, causing either direct injury, for example, to X, or further activation, for example, of neutrophils. ANC-activated neutrophils cause tissue injury by releasing granule contents and reactive oxygen species. Since the ANC autoantibodies are directed against cellular constituents and do not form circulating immune complexes, the vascular lesions do not typically contain demonstrable antibody and complement. Thus, ANC-associated vasculitis are often described as pulsi-immune. Anti-endothelial cell antibodies to ECs, perhaps induced by defects in immune regulation, may predispose to certain vasculitis, for example, Kawasaki disease, see later. We will now briefly present several of the mischaracterized and generally recognized vasculitis, re-emphasizing that there is substantial overlap among the different entities. Moreover, it should be kept in mind that some patients with vasculitis do not have a classic constellation of findings that allows them to be neatly pigeonholed into one specific diagnosis. Giant cell temporal arteritis. Giant cell temporal arteritis is a chronic, classically granulomatous inflammation of large to small-sized arteries that principally affects arteries in the head. It is the most common form of vasculitis among elderly adults in the United States and Europe. The temporal arteries are not particularly vulnerable if their name is attached to the disorder, since they are the most readily biopsied in making the diagnosis. Vertebral and ophthalmic arteries. as well as the aorta. Giant cell aortitis also can be involved. Because ophthalmic artery involvement can lead to sudden and permanent blindness, affected persons must be diagnosed and treated promptly. Pathogenesis. Giant cell arteritis likely occurs as a result of a T-cell mediated immune response to an as yet uncharacterized vessel wall antigen. Pro-inflammatory cytokines, especially TNF and anti-EC antibodies, also contribute. The characteristic granulomatous inflammation, in association with certain major histocompatibility complex MHC class Roman II haplotypes, and the excellent therapeutic response to steroids all strongly support an immune etiology. The predilection for vessels of the head remains unexplained, although one hypothesis is that vessels in various parts of the body develop from distinct antigen and may therefore express unique antigens. Morphology. Involved arterial segments develop intimal thickening with occasional thrombosis that reduces the luminal diameter. Classic lesions exhibit medial granulomatous inflammation centered on the internal elastic membrane with elastic lamina fragmentation. There is an infiltrative T-cell CD4 plus CD8 plus in macrophages. Although multinucleated giant cells are seen in approximately 75% of adequately biopsied specimens, Fig. 11.25. Granulomas in giant cells can be rare or absent. Inflammatory. AT. A BC Figure 11.25. Giant cell temporal arteritis. A hematoxylin and eosin stain of section of temporal artery showing giant cells at the degenerated internal elastic membrane in active arteritis arrow. The elastic tissue stain demonstrating focal destruction of internal elastic membrane arrow and intimal thickening IT characteristic of long-standing or healed arteritis. See the temporal artery of a patient with classic giant cell arteritis shows a thickened, nodular, and tender segment of a vessel on the surface of head arrow. C. From Salvrani C. et al. Polymyalgia rheumatica and giant cell arteritis. And Engel J. Med 34726 on 2002. Chapter 11. Blood vessels. Lesions are only focally distributed along the vessel, and segments of relatively normal artery may be interposed. The healed stage is marked by medial attenuation and scarring with intimal thickening, fragmentation of greater than 30% of the circumference of the internal elastic lamina, and adventitial fibrosis. 512. Clinical features. Temporal arteritis is rare before age 50. Symptoms may be only vague and constitutional, fever, fatigue, weight loss, or may involve facial pain or headache, most intense along the course of the superficial temporal artery, which can be painful to palpation. Ocular symptoms associated with involvement of the ophthalmic artery abruptly appear in about 50% of patients. These range from diplopia to complete vision loss. Diagnosis depends on biopsy and histologic confirmation. However, because giant cell arteritis can be extremely focal within an artery, adequate biopsy requires at least a 1 cm segment. Even then, a negative biopsy result does not exclude the diagnosis. Corticosteroids or anti-TNF therapies are typically effective. Takayasu arteritis. Takayasu arteritis is a granulomatous vasculitis of medium and larger arteries characterized principally by ocular disturbances and marked weakening of the pulses in the upper extremities, hence the name pulseless disease. Takayasu arteritis manifests with transmural fibrous thickening of the aorta, particularly the aortic arch and great vessels, with severe luminal narrowing of the major branch vessels. Fig. 11.26. Takayasu aortitis shares many attributes with giant cell aortitis, including clinical features and histology. Indeed, the distinction is typically made based on the age of the patient. Those over 50 years of age are designated as giant cell aortitis, while those under 50 are designated as Takayasu aortitis. Although traditionally associated with the Japanese population and a subset of human leukocyte antigen haplotypes, Takayasu aortitis has a global distribution. An autoimmune etiology is likely. Morphology. Takayasu arteritis classically involves the aortic arch. In a third of patients, it also affects the remainder of the aorta and its branches, with pulmonary artery involvement in half of cases. Coronary and renal arteries may be similarly affected. There is irregular thickening of the vessel wall with intimal hyperplasia. When the aortic arch is involved, the great vessel lumens can be markedly narrowed or even obliterated. Fig. 11.26 and B. Such narrowing explains the weakness of the peripheral pulses. Histologically, the changes range from adventitial mononuclear infiltrates with perivascular cuffing of the vasa vasorum to intense mononuclear inflammation in the media. Granulomatous inflammation, replete with giant cells and patchy medial necrosis, is also seen. The histology Fig. 11.26c is essentially indistinguishable from giant cell temporal arteritis. As the disease progresses, collagenous scarring with mixed chronic inflammatory infiltrates occurs in all three layers of the vessel wall. Occasionally, aortic root involvement causes dilation and aortic valve insufficiency. Figure 11.26 narrowing of brachiocephalic, carotid, and subclavian arteries arrows. B. Gross photograph of two cross-sections of the right carotid artery taken at autopsy of the patient shown in a demonstrating marked intimal thickening and adventitial fibrosis with minimal residual lumen. C. Histologic appearance in active Takaysu aortitis illustrating destruction and fibrosis of the arterial media associated with mononuclear infiltrates and inflammatory giant cells arrows. Takaysu arteritis. Aortic arch angiogram showing. Clinical features. Initial symptoms are usually nonspecific, including fatigue, weight loss, and fever. With progression, vascular symptoms appear and dominate the clinical picture, including reduced blood pressure and weaker pulses in the upper extremities, ocular disturbances, including visual defects, retinal hemorrhages, and total blindness, and neurologic deficits. Involvement of the more distal aorta may lead to claudication of the legs. Pulmonary artery involvement can cause pulmonary hypertension. Narrowing of the coronary ostia may lead to myocardial infarction, and involvement of the renal arteries leads to systemic hypertension in roughly half of patients. The course of the disease is variable. In some patients there is rapid progression, while others enter a quiescent stage at 1 to 2 years, permitting long-term survival, albeit with visual or neurologic deficits. Vasculitis 513. Polyarteritis nodosa PAN. PAN is a systemic vasculitis of small or medium-sized muscular arteries that typically affects renal and visceral vessels but spares the pulmonary circulation. There is no association with ANCA, but a third of patients with PAN have chronic hepatitis B, which leads to the formation of HBsAg/HBsAg complexes that deposit in affected vessels. The cause remains unknown in the majority of cases. Clinical manifestations result from ischemia and infarction of affected tissues and organs. Morphology. PAN is associated with segmental transmural necrotizing inflammation of small to medium-sized arteries, often with superimposed aneurysms and / or thrombosis. Kidney, heart, liver, and gastrointestinal tract vessels are involved in descending order of frequency. Lesions usually involve only part of the vessel circumference with a predilection for branch points. Impaired perfusion of parenchyma distal to the lesions results in ulcerations, infarcts, ischemic atrophy, or hemorrhage. During the acute phase, there is transmural inflammation of the arterial wall with a mixed infiltrate of neutrophils, eosinophils, and mononuclear cells, frequently accompanied by fibrinoid necrosis and luminal thrombosis. Fig. 11.27. Older lesions show fibrous thickening of the vessel wall extending into the adventitia. Characteristically, all stages of activity from early to late coexist in different vessels or even within the same vessel, suggesting ongoing injury. Clinical features. PAN is primarily a disease of young adults but can occur in all age groups. The course is frequently remitting and episodic, with long symptom-free intervals. Because the vascular involvement is widely scattered, the clinical signs and symptoms of PAN can be quite variable. Typical presentation involves some combination of rapidly accelerating hypertension due to renal artery involvement, abdominal. Figure 11.27 and thrombotic occlusion of the lumen of this small artery. Note that part of the vessel wall at the upper right arrow is uninvolved. Courtesy Sidney Murphy, MD, Department of Pathology, University of Texas Southwestern Medical School, Dallas, Texas. Polyarteritis nodosa. There is segmental fibrinoid necrosis. Pain and bloody stools caused by vascular gastrointestinal lesions, diffuse myalgias, and peripheral neuritis, predominantly affecting motor nerves. Renal involvement is often a major cause of mortality. Untreated, PAN is typically fatal. However, immunosuppression can yield remissions or cure in 90% of cases. Kawasaki disease. Kawasaki disease is an acute, febrile, usually self-limited illness of infancy and childhood associated with large to medium-sized vessel arteritis. 80% of the patients are younger than 4 years of age. Its clinical significance stems from the involvement of coronary arteries. Coronary arteritis can result in aneurysms that rupture or thrombose, causing myocardial infarction. Originally described in Japan, the disease is now recognized in the United States and elsewhere in genetically susceptible persons, A variety of infectious agents, mostly viral, have been posited to trigger the disease. The vasculitis may result from a delayed type hypersensitivity response directed against cross-reactive or newly uncovered vascular antigens. Subsequent cytokine production and polyclonal B-cell activation result in autoantibodies to ECs and SMCs that precipitate the vasculitis. Morphology. Kawasaki disease vasculitis resembles that seen in PAN. There is a dense transmural inflammatory infiltrate, although the fibrinoid necrosis is usually less prominent than in PAN. Acute vasculitis typically subsides spontaneously or in response to treatment, but aneurysm formation due to wall damage can appear. As with other arteriitis, healed lesions can also exhibit obstructive intimal thickening. Pathologic changes outside the cardiovascular system are rarely significant. Clinical features: Kawasaki disease typically presents with conjunctival and oral erythema and blistering, edema of the hands and feet, erythema of the palms and soles, a desquamative rash, and cervical lymph node enlargement, hence its other name, mucocutaneous lymph node syndrome. Approximately 20% of untreated patients develop cardiovascular sequelae, ranging from asymptomatic coronary arteritis to coronary artery ectasia to giant coronary artery aneurysms 7 to 8 mm. The last mentioned are associated with rupture, thrombosis, myocardial infarction, or sudden death. With intravenous immunoglobulin therapy and aspirin, the rate of symptomatic coronary artery disease is less than 4%. Microscopic polyangiitis. Microscopic polyangiitis is a necrotizing vasculitis that generally affects capillaries as well as small arterioles and venules. Unlike PAN, all lesions of microscopic polyangiitis tend to be of the same age in any given patient, suggesting a single episode of antibody or immune complex deposition. It is also called hypersensitivity vasculitis or leukocytoclastic vasculitis. The skin, mucous membranes, lungs, brain, heart, gastrointestinal tract, kidneys, and muscle all can be. Chapter 11. Blood vessels. Involved. Necrotizing glomerulonephritis. 90% of patients in pulmonary capillaritis are particularly common. Microscopic angiitis can be a feature of a number of immune disorders, for example, Henoch-Schönlein purpura, essential mixed cryoglobulinemia, and vasculitis associated with connective tissue disorders. Pathogenesis. In some cases, antibody responses to antigens, such as drugs, for example, penicillin, microorganisms, for example, streptococci, heterologous proteins, or tumor proteins have been implicated. These can either lead to immune complex deposition or trigger secondary immune responses, for example, development of ANCAs that are pathogenic. Indeed, most cases are associated with MPO ANCA. Recruitment and activation of neutrophils within affected vascular beds is likely responsible for the disease manifestations. Morphology. Microscopic polyangiitis is characterized by segmental fibrinoid necrosis of the media with focal transmural necrotizing lesions. Granulomatous inflammation is absent. These lesions morphologically resemble PAN but typically spare medium-sized and larger arteries. Consequently, macroscopic infarcts are uncommon. In some areas, typically postcapillary venules, only infiltrating and fragmenting neutrophils are seen, giving rise to the term leukocytoclastic vasculitis Fig. 11. 28a. Although immunoglobulins and complement components can be demonstrated in early skin lesions, little or no immunoglobulin can be seen in most lesions, so-called pauci-immune injury. Granulomatosis with polyangiitis. GPA, previously called Wegener granulomatosis. GPA is a necrotizing vasculitis characterized by a triad of acute necrotizing granulomas of the upper respiratory tract, ear, nose, sinuses, throat, or the lower respiratory tract, lung, or both. Necrotizing or granulomatous vasculitis affecting small to medium-sized vessels, for example, capillaries, venules, arterioles, and arteries, most prominent in the lungs and upper airways but affecting other sites as well. Focal necrotizing, often crescentic, glomerulonephritis. Limited forms of GPA may be restricted to the respiratory tract. Conversely, a widespread form of the disease can affect eyes, skin, and other organs, notably the heart. Clinically, widespread GPA resembles PAN except that there is also respiratory involvement. Pathogenesis. GPA likely represents a form of T-cell mediated hypersensitivity response to normally innocuous inhaled microbial or other environmental agents. Such a pathogenesis is supported by the presence of granulomas and a dramatic response to immunosuppressive therapy. PR3 ANCA are also present in up to 95% of cases. They are a useful marker of disease activity and may participate in disease pathogenesis. Following immunosuppression treatment, PR3 ANCA titers fall dramatically. Subsequent rising titers are predictive of relapse. Clinical features morphology depending on the vascular bed involved. Major clinical features include hemoptysis, hematuria and proteinuria, bowel pain or bleeding, muscle pain or weakness, and palpable cutaneous purpura. With the exception of those who develop widespread renal or brain involvement, immunosuppression induces remission and markedly in fibroblasts with giant cells and leukocyte infiltrate. Reminiscent improves long-term survival. 514. Upper respiratory tract lesions range from inflammatory sinusitis with mucosal granulomas to ulcerative lesions of the nose, palate, or pharynx, rimmed by granulomas with geographic patterns of central necrosis and accompanying vasculitis. Fig. 11.28b. The necrotizing granulomas are surrounded by a zona proliferans, a BC figure 11.28 and a neutrophil cytoplasmic antibody, associated small vessel vasculitis. A leukocytoclastic vasculitis, microscopic polyangiitis with fragmentation of neutrophils in and around blood vessel walls. B and C granulomatosis with polyangiitis. E vasculitis of a small artery with adjacent granulomatous inflammation including epithelioid cells and giant cells arrows. C gross photo from the lung of a patient with fatal granulomatosis with polyangiitis demonstrating large, nodular, centrally cavitating lesions. A. Courtesy Michael A. Seidman, MD, PhD. Laboratory Medicine Program, University Health Network, Toronto, Canada. C. Courtesy Sidney Murphy, MD, Department of Pathology, University of Texas Southwestern Medical School, Dallas, Texas. Vasculitis 515 of mycobacterial or fungal infections. Multiple granulomata can coalesce to produce radiographically visible nodules that can also cavitate. Late-stage disease may be marked by extensive necrotizing granulomatous involvement of the parenchyma. Fig. 11.28c. And alveolar hemorrhage may be prominent. Lesions may ultimately undergo progressive fibrosis and organization. Renal lesions range from mild, focal glomerular necrosis with isolated capillary loop thrombosis, focal and segmental. Necrotizing glomerulonephritis to more advanced glomerular. Lesions with diffuse necrosis with parietal cell proliferation resulting in crescent formation, crescentic glomerulonephritis. Clinical features: males are affected more often than females, at an average thromboangiitis obliterans Buerger disease. The luminous age of about 40 years. Classic features include bilateral pneumonitis with nodules and cavitary lesions 95%, chronic sinusitis 90%, mucosal ulcerations of the nasopharynx 75%, and renal disease 80%. Rashes, myalgias, articular involvement, neuritis, and fever can also occur. Left injected tobacco extracts, and their vessels exhibit impaired untreated. The disease is usually rapidly fatal with 80% endothelium-dependent vasodilation when challenged with mortality within 1 year. Treatment with steroids, cyclophos, acetylcholine. There is an increased prevalence in certain famide, TNF antagonists, and anti-B-cell antibodies, have ethnic groups Israeli, Indian subcontinent, Japanese, and turn GPA into a chronic relapsing and remitting disease. In association with certain MHC haplotypes. Figure 11.29 occluded by a thrombus containing abscesses arrow, and the vessel wall is infiltrated with leukocytes. Churg-Strauss syndrome. Churg-Strauss syndrome, also called allergic granulomatosis and angiitis, is a small vessel necrotizing vasculitis classically associated with asthma, allergic rhinitis, lung infiltrates, peripheral eosinophilia, extravascular necrotizing granulomas, and a striking eosinophilic infiltration of vessels and tissues. Cutaneous involvement with palpable purpura, gastrointestinal bleeding, and renal disease primarily as focal and segmental glomerulosclerosis are the major associations. Cytotoxicity produced by the myocardial eosinophilic infiltrates often leads to cardiomyopathy. Cardiac involvement is seen in 60% of patients and is a major cause of morbidity and death. Churg-Strauss syndrome is likely a consequence of hyperresponsiveness to some normally innocuous allergic stimulus. MPO ANCA are present in a minority of cases, suggesting that the disorder is pathogenically heterogeneous. Vascular lesions differ from those of PAN or microscopic polyangiitis by virtue of the presence of both granulomas and eosinophils. Morphology: affected vessels of thromboangiitis obliterans show acute and chronic inflammation, accompanied by luminal thrombosis. The thrombus can contain small microabscesses composed of neutrophils, surrounded by granulomatous inflammation. Fig. 11:29. The thrombus may eventually organize and recanalize. The inflammatory process extends into contiguous veins and nerves railway, other forms of vasculitis, and with time all three structures can be encased in fibrous tissue. Clinical features. Early manifestations include Raynaud phenomenon, see later, and step foot pain induced by exercise and step claudication, and a superficial nodular phlebitis venous inflammation. The vascular insufficiency of Buerger disease tends to be accompanied by severe pain, even at rest, undoubtedly due to the neural involvement. Chronic extremity ulcerations can develop, progressing over time occasionally precipitously to frank gangrene. Smoking abstinence in the early stages of the disease can often ameliorate further attacks. However, once established, the vascular lesions do not respond to smoking abstinence. Thromboangiitis obliterans. Buerger disease. Thromboangiitis obliterans is characterized by segmental thrombosing, acute and chronic inflammation of medium and small-sized arteries, especially the tibial and radial arteries, that often leads to vascular insufficiency, typically of the extremities. It occurs almost exclusively in heavy cigarette smokers, usually before the age of 35. Vasculitis associated with other non-infectious disorders. Vasculitis resembling hypersensitivity angiitis or classic PAN can sometimes be associated with other disorders, such as rheumatoid arthritis, systemic lupus erythematosus, malignancy, or systemic illnesses, such as mixed cryoglobulinemia, antiphospholipid antibody syndrome, and Henoch-Schönlein purpura. Rheumatoid vasculitis occurs predominantly in the setting of long-standing, severe rheumatoid arthritis and usually affects small and medium-sized arteries. Pathogenesis. The strong relationship with cigarette use involves either direct idiosyncratic EC toxicity caused by some tobacco component or an immune response to the same agents that have modified host vascular wall proteins. Most patients with Buerger disease have hypersensitivity to intradermally. Chapter 11. Blood vessels, leading to visceral infarction. It may also cause a clinically significant aortitis. Identifying the underlying pathology has therapeutic significance. For example, although classic immune complex lupus vasculitis and antiphospholipid antibody syndrome can be morphologically and clinically similar, anti-inflammatory therapy is required in the former, and aggressive anticoagulant therapy is indicated in the latter. Infectious vasculitis. Arteritis can be caused by the direct invasion of infectious agents, usually bacteria or fungi, and in particular Aspergillus and Mucor species. Vascular invasion can be part of a localized tissue infection, for example, bacterial pneumonia, or adjacent to abscesses, or, less commonly, can arise from hematogenous spread of microorganisms during septicemia or embolization from infective endocarditis. Vascular infections can weaken arterial walls and culminate in mycotic aneurysms, see earlier, or can induce thrombosis and downstream infarction. Thus, inflammation-induced thrombosis of meningeal vessels and bacterial meningitis can eventually give rise to infarction of the underlying brain. Key concepts. Vasculitis. Vasculitis is defined as inflammation of vessel walls. It is frequently associated with systemic manifestations including fever, malaise, myalgias, and arthralgias, and organ dysfunction that depends on the pattern of vascular involvement. Vasculitis most commonly has an immunologic basis resulting from immune complex deposition, or anti-EC antibodies. Less commonly, it is caused by infections. Different forms of vasculitis tend to specifically affect vessels of a particular caliber and location. See Fig. 11.24 and Table 11.4. Disorders of blood vessel hyperactivity. Several disorders are characterized by inappropriate or excessive blood vessel vasoconstriction. Raynaud phenomenon. Raynaud phenomenon results from exaggerated vasoconstriction of arteries and arterioles in responses to cold or emotion. It most commonly affects the extremities, particularly the fingers and toes, but also occasionally the nose, earlobes, or lips. The restricted blood flow induces paroxysmal pallor and even cyanosis in severe cases. Involved digits classically show red, white, and blue color changes from most proximal to most distal, correlating with proximal vasodilation, central vasoconstriction, and more distal cyanosis. Fig. 11.30. Raynaud phenomenon can be a primary entity or secondary to other disorders. Primary Raynaud phenomenon affects 3% to 5% of the general population and occurs most often in young women. It tends to symmetrically affect the extremities, and the severity and extent of involvement typically does not progress. It results from intrinsic hyperactivity of medial SMCs. Structural changes in the arterial walls are absent except in long-standing disease, when intimal thickening can develop. The course is usually benign, but chronicity can lead to atrophy of the skin, subcutaneous tissues, and muscles. Ulceration and ischemic gangrene are rare. Secondary Raynaud phenomenon refers to vascular insufficiency due to arterial disease caused by other entities, including SLE, scleroderma, Buerger disease, or even atherosclerosis. Clinically, secondary Raynaud phenomenon tends to have asymmetric involvement of the extremities and progressively worsens extent and severity over time. Since Raynaud phenomenon may be the first manifestation of immune-mediated vasculitis, any patient would know. A B figure 11.30 fingertips, reproduced from Salvrani C. et al. Polymyalgia rheumatica and giant cell arteritis, in Engel J. Med 34726 on 2002, 516. Raynaud phenomenon, a sharply demarcated pallor of the distal fingers resulting from the closure of digital arteries. B. Cyanosis of the veins and lymphatics 517. Symptoms should be evaluated. Of these, some 10% will eventually manifest an underlying disorder. Myocardial vessel vasospasm. Excessive constriction of arteries or arterioles may cause ischemia, and persistent vasospasm can even cause myocardial infarction. In addition to intrinsic hyperactivity of medial SMCs, as described for primary Raynaud disease see earlier, high levels of vasoactive mediators can precipitate prolonged vascular contraction. Such agents can be endogenous, for example, epinephrine released by pheochromocytomas or exogenous cocaine or phenylephrine. Elevated thyroid hormone causes a similar effect by increasing the sensitivity of vessels to circulating catecholamines, while autoantibodies and T cells in scleroderma chapter 6 can cause vascular instability and vasospasm. Extreme psychological stress and the attendant release of catecholamines can lead to pathologic vasospasm. When vasospasm of cardiac arteriole or arteriolar beds, so-called cardiac Raynaud, is of sufficient duration 20 to 30 minutes, myocardial infarction or sudden cardiac death may occur. Veins and lymphatics. Varicose veins and phlebothrombosis/thrombophlebitis together account for at least 90% of clinical venous disease. Varicose veins. Varicose veins are abnormally dilated, tortuous veins produced by prolonged, increased intraluminal pressure with vessel dilation and incompetence of the venous valves. The superficial veins of the upper and lower leg are commonly involved because venous pressures in these sites can be markedly elevated up to 10 times normal by prolonged dependent posture. Up to 20% of men and a third of women develop lower extremity varicose veins. Obesity increases the risk, and the higher incidence in women probably reflects the prolonged elevation in venous pressure caused by compression of the inferior vena cava by the gravid uterus during pregnancy. Familial predilection to varicose veins reflects defective venous wall development. Clinical features: incompetence of the venous valves leads to stasis, congestion, edema, pain, and thrombosis. Secondary tissue ischemia results from chronic venous congestion and poor vessel drainage leading to stasis. Dermatitis, also called brawny induration. The brawny color comes from the hemolysis of extravasated red cells and ulcerations. Poor wound healing and superimposed infections are common additional complications. Notably, embolism from these superficial veins is very rare, as opposed to the relatively frequent thromboembolism that arises from thrombosed deep veins. See later in Chapter 4. Varicosities in two other sites also deserve mention: esophageal varices, liver cirrhosis less frequently. Portal vein obstruction or hepatic vein thrombosis causes portal vein hypertension. Chapter 18. Portal hypertension leads to the opening of portosystemic shunts that increase blood flow into veins at the gastroesophageal junction, forming esophageal varices, rectum forming hemorrhoids, and periumbilical veins of the abdominal wall forming a cap of Medusa. Esophageal varices are the most important since their rupture can lead to massive, even fatal upper gastrointestinal hemorrhage. Hemorrhoids can also result from primary varicose dilation of the venous plexus at the anortal junction, for example, through prolonged pelvic vascular congestion due to pregnancy or straining to defecate. Hemorrhoids are uncomfortable and may be a source of bleeding. They can also thrombose and are prone to painful ulceration, thrombophlebitis, and phlebothrombosis. Thrombophlebitis and phlebothrombosis are largely interchangeable designations for venous thrombosis and inflammation. Deep leg veins account for more than 90% of cases. The periprostatic venous plexus in males and the pelvic venous plexus in females are additional sites, as are the large veins in the skull and the dural sinuses, especially in the setting of infection or inflammation. Portal vein thrombosis can occur in association with peritoneal infections, peritonitis, appendicitis, esophagitis, and pelvic abscesses, as well as certain thrombophilic conditions associated with platelet hyperactivity, for example, polycythemia vera, chapter 14. Decreased blood flow in the setting of prolonged immobilization is the most common cause of lower extremity deep venous thrombosis, DVT. This can occur with extended bed rest or sitting during long airplane or automobile excursions. The postoperative state can also precipitate DVT, and congestive heart failure, pregnancy, oral contraceptive use, malignancy, and obesity all constitute additional risk factors. Systemic Thrombophlebitis and phlebothrombosis are largely interchangeable designations for venous thrombosis and inflammation. Deep leg veins account for more than 90% of cases. The periprostatic venous plexus in males and the pelvic venous plexus in females are additional sites, as are the large veins in the skull and the dural sinuses, especially in the setting of infection or inflammation. Portal vein thrombosis can occur in association with peritoneal infections, peritonitis, appendicitis, esophagitis, and pelvic abscesses, as well as certain thrombophilic conditions associated with platelet hyperactivity, for example, polycythemia vera, chapter 14. Decreased blood flow in the setting of prolonged immobilization is the most common cause of lower extremity deep venous thrombosis, DVT. This can occur with extended bed rest or sitting during long airplane or automobile excursions. The postoperative state can also precipitate DVT, and congestive heart failure, pregnancy, oral contraceptive use, malignancy, and obesity all constitute additional risk factors. Systemic hypercoagulability, including genetic hypercoagulability syndromes, chapter 4, can also contribute to thrombophlebitis. In patients with cancer, particularly adenocarcinomas, hypercoagulability occurs as a paraneoplastic syndrome related to tumor elaboration of procoagulant factors, chapter 7. In this setting, venous thrombosis classically appear in one location, disappear, and then occur in another site, so-called migratory thrombophlebitis Trousseau syndrome. Thrombi in the legs tend to produce few, if any, reliable signs or symptoms. Indeed, local manifestations including vein dilation, edema, cyanosis, heat, erythema, or pain may be entirely absent, especially in bedridden patients. In some cases, pain can be elicited by pressure over affected veins, squeezing the calf muscles, or forced dorsiflexion of the foot Hamann sign. Absence of these findings does not exclude a diagnosis of DVT. Pulmonary embolism is a serious clinical complication of DVT, chapter 4, resulting from fragmentation or detachment of the venous thrombus. In many cases, the first manifestation of thrombophlebitis is a pulmonary embolus. Depending on the size and number of emboli, the outcome can range from no symptoms to death. Superior and inferior vena cava syndromes. The superior vena cava syndrome is usually caused by neoplasms that compress or invade the superior vena cava, for example, bronchogenic carcinoma or mediastinal lymphoma. 518, chapter 11, blood vessels. The resulting obstruction produces a characteristic clinical complex including marked dilation of the veins of the head, neck, and arms with cyanosis. Pulmonary vessels can also be compressed, inducing respiratory distress. The inferior vena cava syndrome can be caused by neoplasms that compress or invade the inferior vena cava IVC or by thrombosis of the hepatic, renal, or lower extremity veins that propagate cephalad. Certain neoplasms, particularly hepatocellular carcinoma and renal cell carcinoma, show a striking tendency to grow within veins, and these can ultimately occlude the IVC. IVC obstruction induces marked lower extremity edema, distension of the superficial collateral veins of the lower abdomen, and, with renal vein involvement, massive proteinuria. Lymphangitis and lymphedema. Although primary disorders of lymphatic vessels are extremely uncommon, secondary processes frequently develop in association with inflammation or malignancies. Lymphangitis represents acute inflammation caused by the spread of bacterial infections into lymphatics. Group of beta hemolytic streptococcus is the most common agent. Affected lymphatics are dilated and filled with an exudate of neutrophils and monocytes. The infiltrates can extend through the vessel wall and, in severe cases, can produce cellulitis or focal abscesses. Lymphangitis is manifested by red, painful subcutaneous streaks to inflamed lymphatics, with painful enlargement of the draining lymph nodes, lymphadenitis. If bacteria are not successfully contained within the lymph nodes, subsequent escape into the venous circulation can result in bacteremia or sepsis. Primary lymphedema can occur as an isolated congenital defect, simple congenital lymphedema, or as the familial Milroy disease, familial congenital lymphedema, which results in lymphatic agenesis or hypoplasia. Secondary or obstructive lymphedema stems from blockage of previously normal lymphatics, including tumors obstructing lymphatic channels or the regional lymph nodes. Surgical procedures that sever lymphatic connections, for example, axillary lymph node resection and a radical mastectomy. Post-radiation fibrosis, filariasis, post-inflammatory thrombosis and scarring. Regardless of the cause, lymphedema increases the hydrostatic pressure in the lymphatics distal to the obstruction and causes edema. Chronic edema, in turn, can lead to ECM deposition and fibrosis, producing brawny induration or orange peel appearance of the overlying skin. Eventually, inadequate tissue perfusion can lead to skin ulceration, rupture of dilated lymphatics, for example. Secondary to obstruction from a tumor or following surgical injury leads to milky accumulations of lymph designated as chylous abdomen, chylothorax, and chylopericardium. Vascular tumors. Tumors of blood vessels and lymphatics constitute a spectrum from benign hemangiomas extremely common to Balek 10, N5 TRS, classificate 2 of Visorion and conditions. Benign neoplasms, developmental and acquired conditions. Hemangioma capillary, hemangioma cavernous, hemangioma pyogenic granuloma. Lymphangioma simple capillary, lymphangioma cavernous, lymphangioma cystic hygroma. Glomus tumor, vascular ectasias, nevus flammeus. Spider telangiectasia, arterial spider. Hereditary hemorrhagic telangiectasis, Osler-Weber-Rendu disease. Reactive vascular proliferations, bacillary angiomatosis. Intermediate grade neoplasms. Kaposi sarcoma, hemangioendothelioma. Malignant neoplasms. Angiosarcoma, hemangiopercytoma, tumor-like. Locally aggressive neoplasms that rarely metastasize. Rare. Highly malignant angiosarcomas, table 11.5. Vascular neoplasms arise either from endothelium, for example, hemangioma, lymphangioma, angiosarcoma, or from cells that support or surround blood vessels, for example, glomus tumor. Primary tumors of large vessels, aorta, pulmonary artery, and vena cava are mostly sarcomas. Although a benign, well-differentiated hemangioma is not usually confused with an aplastic angiosarcoma, the distinction between benign and malignant can occasionally be difficult. Congenital or developmental malformations and non-neoplastic reactive vascular proliferations, for example, bacillary angiomatosis, can also present as tumor-like lesions that can be diagnostically challenging. In general, benign and malignant vascular neoplasms can be distinguished by the following features. Benign tumors usually contain obvious vascular channels filled with blood cells. Lymphatics will be filled with lymph, lined by a monolayer of normal-appearing ECs. Malignant tumors are more solidly cellular and more proliferative and exhibit cytologic atypia. They usually do not form well-organized vessels. The endothelial derivation of such neoplastic proliferations may require immunohistochemical detection of EC-specific markers such as CD31 or von Willebrand factor. Benign tumors and tumor-like conditions. Vascular ectasias. Ectasia is a generic term for any local dilation of a structure, while telangiectasia is used to describe a permanent dilation of pre-existing small vessels, capillaries, venules, and arterioles, usually in the skin or mucous membranes, that forms a discrete red lesion. These can be congenital or acquired and are not true neoplasms. Vascular tumors 519. Nevus flammeus, a birthmark. The most common form of vascular ectasia is a light pink to deep purple flat lesion on the head or neck composed of dilated vessels. Most ultimately regress spontaneously. The sole, called port wine stain is a type of nevus flammeus that tends to grow during childhood, thickening the associated skin surface and persisting over time. Perhaps the most well-known example is that on the forehead of the former Soviet President Mikhail Gorbachev. Such lesions in the distribution of the trigeminal nerve can be associated with Sturge-Weber syndrome, also called encephalotrigeminal angiomatosis. This uncommon congenital disorder is associated with facial port wine nevi, ipsilateral venous angiomas in the cortical leptomeninges, intellectual disability, seizures, hemiplegia, and skull radiopacities. A large facial telangiectasia in a child with intellectual deficiency may indicate the presence of additional vascular malformations. The majority of cases of port wine stains, including those associated with Sturge-Weber syndrome, are caused by a somatic single nucleotide missense mutation in NAC, the alpha subunit of heterotrimeric transmembrane signaling molecule. Spider telangiectasias are non-neoplastic vascular malformations grossly resembling a spider. These manifest as radial, often pulsatile lesions composed of dilated subcutaneous arteries or arterioles resembling spider legs about a central core resembling a spider's body that blanch with pressure. These commonly occur on the face, neck, or upper chest and are most frequently associated with hyperestrogenic states, for example, in pregnant women or patients with cirrhosis. Hereditary hemorrhagic telangiectasia Osler-Weber Rendu disease is an autosomal dominant disorder caused by mutations in genes that encode components of the TGF-beta signaling pathway in ECs. The telangiectasias are malformations composed of dilated capillaries and veins that are present at birth. They are widely distributed over the skin and oral mucous membranes, as well as in the respiratory, gastrointestinal, and urinary tracts. The lesions can spontaneously rupture, causing serious epistaxis, nosebleed, gastrointestinal bleeding, or hematuria. Hemangiomas. Hemangiomas are very common tumors composed of blood-filled vessels. Fig. 11.31. They constitute 7% of all benign tumors of infancy and childhood. Most are present from birth and initially increase in size, but many eventually regress spontaneously. While hemangiomas are typically confined to the head, neck, and thoracic skin, they can also arise internally and can occasionally be more extensive angiomatosis. Nearly 1/3 of internal lesions occur in the liver. Malignant transformation is rare. Several histologic and clinical variants have been described. Capillary hemangiomas are the most common type. These occur in the skin, subcutaneous tissues, and mucus. A B. Figure 11.31. Hemangiomas. The hemangioma of the tongue. B. Histology of juvenile capillary hemangioma. C. Histology of cavernous hemangioma. D. Pyogenic granuloma of the lip. And D. Courtesy John Sexton, M.D. Beth Israel Hospital, Boston, Mass. E. Courtesy Christopher D. M. Fletcher, M.D. Brigham and Women's Hospital, Boston, Mass. And C. Courtesy Thomas Rogers, M.D. University of Texas Southwestern Medical School, Dallas, Texas. 520. Chapter 11. Blood vessels. Membranes of the oral cavities and lips, as well as in the liver, spleen, and kidneys. Fig. 11.31. Histologically, they are composed of thin-walled capillaries with scant stroma. Fig. 11.31b. Juvenile hemangiomas, so-called strawberry-type hemangiomas of the newborn skin, are extremely common, 1 in 200 births, and can be multiple. These grow rapidly for a few months, but then fade by 1 to 3 years of age and completely regress by age 7 in most cases. Cavernous hemangiomas are composed of large, dilated vascular channels. In contradistinction to capillary hemangiomas, cavernous hemangiomas are more infiltrative, frequently involve deep structures, and do not spontaneously regress. Moreover, cavernous hemangiomas detected by imaging studies may be difficult to distinguish from their malignant counterparts. On histologic examination, the mass is sharply delineated but unencapsulated and composed of large, cavernous blood-filled vascular spaces, separated by connective tissue stroma. Fig. 11.31c. Intravascular thrombosis with associated dystrophic calcification is common. They can be locally destructive, but more often are of little clinical significance outside of a cosmetic disfigurement or their vulnerability to traumatic ulceration and bleeding. Brain hemangiomas are problematic, as they can cause symptoms related to compression of adjacent tissue or rupture. Cavernous hemangiomas are one component of von Hippel-Lindau disease, chapter 28, in which vascular lesions are commonly found in the cerebellum, brainstem, retina, pancreas, and liver. Pyogenic granulomas are capillary hemangiomas that present as rapidly growing red pedunculated lesions on the skin, gingiva, or oral mucosa. They bleed easily and are often ulcerated. Fig. 11.31d. Roughly a quarter of lesions develop after trauma, reaching the size of 1 to 2 cm within a few weeks. Curettage and cautery is usually curative. Pregnancy tumor granuloma gravidarum is a pyogenic granuloma that occurs in frequently 1% of patients in the gingiva of pregnant women. These lesions may spontaneously regress, especially after pregnancy, or undergo fibrosis, but occasionally require surgical excision. Lymphangiomas. Lymphangiomas are the benign lymphatic counterparts of hemangiomas. Simple capillary lymphangiomas are slightly elevated or sometimes pedunculated lesions up to 1 to 2 cm in diameter that occur predominantly in the head, neck, and axillary subcutaneous tissues. Histologically, lymphangiomas exhibit networks of endothelium-lined spaces that can be distinguished from capillary channels by lymphatic endothelial markers, for example, VEGFR3, LIVE1, and others, or by the absence of erythrocytes. Cavernous lymphangiomas, cystic fibromas, are typically found in the neck or axilla of children and more rarely in the retroperitoneum. Cavernous lymphangiomas can occasionally be enormous, up to 15 cm, filling the axilla or producing gross deformities about the neck. Cavernous lymphangiomas of the neck are common in Turner syndrome. The lesions are composed of massively dilated lymphatic spaces lined by ECs and separated by intervening connective tissue stroma containing lymphoid aggregates. The tumor margins are indistinct and unencapsulated, making resection difficult. Glomus tumor glomangioma. Glomus tumors are benign but exquisitely painful tumors arising from modified SMCs of the glomus bodies, arteriovenous structures involved in thermoregulation. Although they may superficially resemble hemangiomas, glomangiomas arise from SMCs rather than ECs. They are most commonly found in the distal portion of the digits, especially under the fingernails. Excision is curative. Bacillary angiomatosis. Bacillary angiomatosis is a vascular proliferation in immunocompromised hosts, for example, patients with acquired immunodeficiency syndrome AIDS caused by opportunistic bacilli of the Bartonella family. Lesions can involve the skin, bone, brain, and other organs. 2 species are implicated. Bartonella henselae, whose principal reservoir is the domestic cat, causes cat scratch disease, a necrotizing granulomatous disorder of lymph nodes in immunocompetent hosts. Bartonella quintana is transmitted by human body lice. This microbe was the cause of trench fever in World War I. Morphology. Skin lesions are red papules and nodules or rounded subcutaneous masses. Histologically, there is capillary proliferation with prominent epithelioid ECs exhibiting nuclear atypia and mitosis, with scattered stromal neutrophils and causal bacteria. Fig. 11.32. Bacteria induce host tissues to produce hypoxia-inducible factor 1 alpha (HIF1 alpha), which, in turn, drives vascular endothelial growth factor VEGF production and ultimately vascular proliferation. The infections and lesions are cleared by antibiotics. Intermediate grade borderline tumors. Kaposi sarcoma. Kaposi sarcoma KS is a vascular neoplasm caused by human herpes virus HHV, also known as Kaposi sarcoma herpes virus. Although it occurs in a number of contexts, it is by far most common in patients with AIDS. Indeed, its presence is used as a criterion for diagnosis of AIDS. Based on population demographics and risk factors, KS is categorized into 4 forms. Classic KS is a disorder of older men of Mediterranean, Middle Eastern, or Eastern European descent, especially Ashkenazic Jews. It is uncommon in the United States. It can be associated with malignancy or altered immunity, but it is not associated with human immunodeficiency virus HIV infection. Classic KS manifests as multiple red-purple skin plaques or nodules, usually in the distal lower extremities. These progressively increase in size and number and spread proximally. Although persistent, the tumors are typically asymptomatic and remain localized to the skin and subcutaneous tissue. Endemic African KS typically occurs in HIV seronegative individuals younger than age 40 years and can follow an indolent or aggressive course. It involves lymph nodes much more frequently than the classic variant. In combination with AIDS-associated KS, see later. KS is one of the vascular tumors 521. A B figure 11.32 bacillary angiomatosis, a characteristic cutaneous lesion. E histologic appearance with acute neutrophilic inflammation and vascular capillary proliferation. INSIT, modified silverworth and starry stain, demonstrates clusters of tangled bacilli. Black. 8. Courtesy Richard Johnson, MD. Beth Israel Deaconess Medical Center, Boston, Mass. B. and Ensign. Courtesy Scott Grander, MD. Brigham and Women's Hospital, Boston, Mass. More common tumors in Central Africa. A particularly severe form, with prominent lymph node and visceral involvement, occurs in prepubertal children. The prognosis is poor, with almost 100% mortality within 3 years. Transplant-associated KS occurs in solid organ transplant recipients receiving T-cell immunosuppression. The risk can be 100-fold greater than for immunocompetent patients. Transplant-associated KS typically follows an aggressive course involving lymph nodes, mucosa, and viscera. Cutaneous lesions may be absent. Lesions can regress as immunosuppression is reduced, but at the risk of organ rejection. AIDS-associated epidemic KS is an AIDS-defining illness. Worldwide, it represents the most common HIV-related malignancy. Although the incidence of KS has fallen more than 80% with the advent of aggressive antiretroviral therapies, it still occurs in HIV-infected individuals 300-fold more commonly than in transplant recipients and 1,000-fold greater than in the general population. AIDS-associated KS often involves lymph nodes and disseminates widely to viscera early in its course. Most patients eventually die of opportunistic infections rather than KS. Pathogenesis: virtually all KS lesions are infected by HHV. Like Epstein-Barr virus, HHV is a gamma herpes virus. It is transmitted sexually and potentially via oral secretions and cutaneous exposures of note. The prevalence of endemic African KS is inversely related to the wearing of shoes. HHV and altered T-cell immunity are likely required for KS development. In elderly adults, diminished T-cell immunity may be related to aging. Acquired somatic mutations in the cells of origin also contribute to tumor development and progression. HHV causes lytic and latent infections in these seeds, both of which contribute to KS pathogenesis. A virally encoded G protein induces VEGF production, stimulating endothelial growth. In addition, cytokines produced by inflammatory cells recruited to sites of lytic infection create a local proliferative milieu. In latently infected cells, HHV-encoded proteins disrupt normal cellular proliferation controls, for example, through synthesis of a viral homologue of cyclin D and prevent apoptosis by inhibiting 53. Thus, the local inflammatory environment favors cellular proliferation, and latently infected cells have a growth advantage. In its early stages, only a few cells are HHV infected, but with time, virtually all of the proliferating cells carry the virus. Molecular pathogenesis is discussed in more detail in Chapter 6 along with HIV infections. Morphology. In classic KS and sometimes in other variants, the cutaneous lesions progress through 3 stages. Patches are red-purple macules. Fig. 11:33. Histology shows dilated irregular EC-line vascular spaces with interspersed lymphocytes, plasma cells, and macrophages sometimes contain hemosiderin. The lesions can be difficult to distinguish from granulation tissue. With time, lesions become larger, violaceous, raised plaques. See Fig. 11:33a. Composed of dermal accumulations of dilated, jagged vascular channels lined and surrounded by plump spindle cells. Scattered between the vascular channels are extravasated erythrocytes, hemosiderin-laden macrophages, and other mononuclear inflammatory cells. Eventually, lesions become nodular and more distinctly neoplastic. These lesions are composed of sheets of plump, proliferating spindle cells, mostly in the dermis or subcutaneous tissues. Fig. 11:33b, containing small vessels and slit-like spaces with red cells. Mark hemorrhage, hemosiderin pigment, and mononuclear inflammation are present. Mitotic figures are common, as are round, pink, cytoplasmic globules representing degenerating erythrocytes within phagocytomes. The nodular stage often heralds lymph node and visceral involvement. Clinical features. The course of KS varies widely and is significantly influenced by the clinical setting. Most primary HHV infections are asymptomatic. Classic KSs, at least initially, largely restricted to the skin, and surgical resection is usually adequate for an excellent prognosis. Radiation can be used for multiple lesions in a restricted area, and chemotherapy yields satisfactory results for more disseminated disease. Chapter 11. Blood vessels. Figure 11.33. Kaposi sarcoma. A gross photograph illustrating coalescent red-purple macules and plaques of the skin. The histologic appearance of the nodular stage of Kaposi sarcoma, demonstrating sheets of plump, proliferating spindle cells. B. Courtesy Christopher D. M. Fletcher, M.D., Brigham and Women's Hospital, Boston, Mass., including nodal involvement in immunosuppression, radiologic imaging, and polyvinyl chloride. One of the associated KS withdrawal of immunosuppression, perhaps best known examples of human chemical carcinogenesis, with adjuvant chemotherapy or radiotherapy is often effective. All of these agents have long latencies between initial for AIDS-associated KS, HIV, antiretroviral therapy is exposure and eventual tumor development, generally beneficial, with or without additional therapy. Angiosarcomas are locally invasive and can readily interfere in gamma and angiogenesis inhibitors also have proved metastasize, with 5-year survival rates of approximately variably effective, while newer strategies aimed at specific 30% kinases downstream of VEGF receptors show promise. Hemangioendothelioma. Hemangioendothelioma is comprised of a spectrum of borderline vascular neoplasms with clinical behaviors intermediate between benign, well-differentiated hemangiomas and frankly anaplastic angiosarcomas. Epithelioid hemangioendothelioma is a tumor of adults occurring around medium and large-sized veins. Well-defined vascular channels are inconspicuous, and neoplastic cells are plump and often cuboid or resembling epithelial cells. The clinical behavior is extremely variable. Most are cured by excision, but up to 40% recur, 20% to 30% eventually metastasize, and 15% of patients will die of their tumor. Malignant tumors. Angiosarcoma. Angiosarcomas are malignant endothelial neoplasms Fig. 11:34 with histology varying from highly differentiated tumors that resemble hemangiomas to profoundly anaplastic lesions. Older adults, males and females, are more commonly affected. Angiosarcomas occur at any site, but most often involve skin, soft tissue, breast, and liver. Angiosarcomas can also arise in the setting of lymphedema, classically in the ipsilateral upper extremity several years after radical mastectomy for breast cancer, i.e., after lymph node resection and slash or radiation. In such cases, the tumor presumably arises from lymphatic vessels. Lymphangiosarcoma. Angiosarcomas have also been induced by radiation and are rarely associated with prolonged insertion of foreign material, for example, prosthetic devices. Hepatic angiosarcomas are associated with a variety of carcinogenic exposures, including arsenic, for example, and pesticides, thorotrast, a radioactive contrast agent formerly used for morphology. Cutaneous angiosarcomas can begin as multiple, deceptively small and asymptomatic red papules or nodules. More advanced lesions are large, fleshy masses of red, tan to gray white tissue with margins blurring imperceptibly into surrounding structures. Fig. 11:34a. Necrosis and hemorrhage are common. Microscopically, all degrees of differentiation can be seen, from plump, atypical ECs forming vascular channels. Fig. 11:34b. Wildly undifferentiated tumors with no discernible blood vessels. The endothelial origin of these tumors can be demonstrated by immunohistochemical staining for CD31 or von Willebrand factor. Fig. 11:34c. Key concepts: vascular tumors. Vascular ectasias are not neoplasms, but rather dilations of existing vessels. Vessel neoplasms can derive from either blood vessels or lymphatics and can be composed of ECs, hemangioma, lymph, angioma, angiosarcoma, or other components of vascular wall. Cells. Glomus tumor. Most vascular tumors are benign, for example, hemangiomas. Some have an intermediate, locally aggressive behavior, for example, Kaposi sarcoma, and others are highly malignant, for example, angiosarcoma. Benign tumors typically form obvious vascular channels lined by normal appearing ECs. Malignant tumors are more often solid and cellular, exhibit cytologic atypia, and lack well-defined vessels. 522. Pathology of vascular intervention. 523. Figure 11.34. Angiosarcoma. An angiosarcoma involving the right ventricle. B. Moderately differentiated angiosarcoma with dense clumps of atypical cells lining distinct vascular lumens. C. Immunohistochemical staining for the endothelial cell marker CD31 demonstrating the endothelial nature of the tumor cells. Pathology of vascular intervention. The morphologic changes that occur in vessels following therapeutic intervention, for example, stenting or bypass surgery, largely recapitulate the changes that occur in the setting of any vascular insult. Local trauma or thrombosis, for example, due to a stent or abnormal mechanical forces, for example, A saphenous vein inserted into the arterial circulation as a coronary artery bypass graft all induce the same stereotypical healing responses. Fibromuscular intimal hyperplastic lesions composed of SMCs and ECM. Thus, just as with several risk factors for atherosclerosis, interventions that injure the endothelium also tend to induce intimal thickening by recruiting SMCs and promoting ECM deposition. Endovascular stenting. Arterial stenosis, especially those in coronary arteries, can be dilated by transiently inflating a balloon catheter to pressure sufficient to rupture the occluding plaque balloon angioplasty. Although most patients improve symptomatically following angioplasty alone, abrupt reclosure frequently occurs due to luminal compression caused by angioplasty-induced vascular dissection, by vessel wall spasm, or by thrombosis. Thus, more than 95% of endovascular coronary procedures now involve both angioplasty and concurrent coronary stent placement. Coronary stents are expandable tubes of metallic mesh. They provide a larger and more regular lumen, tack down the intimal flaps and dissections that occur during angioplasty, and mechanically limit vascular spasm. Nevertheless, due to endothelial injury, thrombosis is an important immediate post-stenting complication, and patients must receive potent antithrombotic agents, primarily platelet antagonists, to prevent acute catastrophic thrombotic occlusions. The long-term success of angioplasty is limited by the development of proliferative in-stent restenosis. This intimal thickening is due to SMC ingrowth, proliferation, and ECM synthesis, all driven by the initial vascular wall injury. It can cause clinically significant luminal occlusion in up to a third of patients within 6 to 12 months of stenting. Fig. 11.35. The newest generation of drug-eluting stents is designed to avoid this complication by leaching antiproliferative drugs, for example, paclitaxel or sirolimus, into the adjacent vessel wall to block SMC activation. Although the duration of drug elution is short, on the order of days to weeks, these drug-eluting stents nevertheless reduce the incidence of restenosis at 1 year by 50% to 80%. However, because of the antiproliferative effect of the drug-eluting stents, the time to re-endothelialization is prolonged, and patients require extended courses of anticoagulation to prevent stent thrombosis. Vascular replacement. Synthetic or autologous vascular grafts can be used to replace damaged vessels or bypass diseased arteries. Large-bore 12 to 18 mm synthetic conduits function well in high-flow locations, such as the aorta. Unfortunately, small-diameter artificial grafts 8 mm in diameter generally fail as a result of early thrombosis or late intimal hyperplasia, the latter at the junction of the graft with the native vasculature. Fig. 11.36. Consequently, when small-bore vessel replacement is required, for example, in the 400,000 coronary bypass surgeries performed annually, the grafts are fashioned from saphenous. Chapter 11. Blood vessels. B. Asterisk figure 11.35. A gross view demonstrating residual yellow atherosclerotic plaque arrows in a new, tan white, concentric intimal lesion inside of that plaque. B. Histologic view shows a thickened neointimus separating and overlying the stent wires, black diamond indicated by the arrow, which encroaches on the lumen indicated by the asterisk, movement stain with matrix staining gray green. B. Reproduced from Scone F.J. Abrams W.D. Pathology of cardiovascular interventions, including endovascular therapies, revascularization, vascular replacement, cardiac assist/replacement, arrhythmia control and repair, congenital heart disease, and Silver M.D. Gottlieb I. Scone F.J. Editors, Cardiovascular Pathology, Ed 3, Philadelphia, 2001. Churchill Livingstone. Restenosis after angioplasty and stenting. Veins taken from the patient's own leg or left internal mammary arteries. The long-term patency of saphenous vein grafts averages only 50% at 10 years. Grafts occlude due to thrombosis typically early, intimal thickening months to years postoperatively, and vein graft atherosclerosis. Sometimes with superimposed plaque rupture, thrombosis, or aneurysms. By contrast, more than 90% of internal mammary artery grafts, which can be used only to bypass the left anterior descending artery, are patent at 10 years. Asterisk B. Figure 11.36. Femoral popliteal graft. An angiogram demonstrating constriction arrow. B. Photomicrograph demonstrating Gore-Tex graft arrow with prominent intimal proliferation and very small residual lumen. Asterisk A. Courtesy Anthony D. Whittemore, M.D. Brigham and Women's Hospital, Boston, Mass. 524. Intimal hyperplasia at the distal anastomosis of a synthetic. Suggested readings: vascular structure and function, Axnick J. Lambert E. Vascular lumen formation, Kerr Oppen Hematol 1919-12, 2012. Overview of physiologic and developmental blood vessel formation and remodeling. Like valve A, the situation is more complex than anticipated. In a brief history of blood and lymphatic vessels. Chan, Switzerland, 2017. Springer. Nice review of the cellular and molecular underpinnings of vascular development, including tumor vasculogenesis. Monahan Early R. Dvorak A.M. Air W.C. Evolutionary origins of the blood vascular system and endothelium. J. Throm Hemost 11 Supple 146, 2013. Interesting discussion of the evolutionary basis for vascular development, including cogent explanations for endothelial heterogeneity. Vascular wall response to injury. Gimbron M.A. Jr., Garcia Cardin G. Endothelial cell dysfunction and the pathobiology of atherosclerosis. Circ Res 116020, 2016. Well-written review of endothelial responses to mechanical forces and other injury from one of the leading groups in the field. Hober J.S., Minute W., Bradley Jr., Mechanisms of Endothelial Dysfunction, Injury, and Death, and Reverend Pathar 471, 2009. Well-written scholarly review of the etiology and outcomes of endothelial injury. Hypertensive vascular disease. Kaufman T.M., Under Pressure. The Search for the Essential Mechanisms of Hypertension. Nat Med 1714-12, 2011. Although not immediately current, this is a well-written review of the potential mechanisms underlying hypertension, the models that help elucidate pathways, and some translational advances. Singh M., Mensa G.A., Akers G., Pathogenesis and Clinical Physiology of Hypertension, CardioClin 2854, 2010. Excellent overview of normal blood pressure regulation and the interaction of genetics and environment in the pathophysiology of hypertension. Atherosclerosis. Fuster J.J., Walsh K. Somatic mutations and clonal hematopoiesis. Unexpected potential new drivers of age-related cardiovascular disease. Circ Res 52-3, 2018. Excellent paper elucidating the mechanistic links between aging, clonal hematopoiesis, and atherosclerosis. Hansen G.K., Libby P., Tabazai, Inflammation and Plaque Vulnerability. J. Intermed 27848-3, 2015. Nice review of the current concepts linking inflammation and plaque vulnerability. Janauchi H. Q.O.L. Sakamoto et al. Diversity of macrophage phenotypes and responses in atherosclerosis. Cellmall Life Sci 2019. Pabaheda Print. Solid review of the different macrophage activities in the atherosclerotic plaque. Jaswell S. et al. Clonal hematopoiesis and risk of atherosclerotic cardiovascular disease. In Engel J. Med 37711, 2017. Remarkable new data showing the risk of atherosclerosis with increasing age may be related to clonal expansion of certain hematopoietic lineages. Readings 525. Veins and lymphatics. Goldhaber SC. Venous thromboembolism. Epidemiology and magnitude of the problem. Best Prac Res Clin Hematol 2523, 2012. Thorough clinically oriented overview of deep venous thrombosis and pulmonary embolism, including epidemiology, mechanism of disease, and therapy. Vascular tumors. Butani M., Polizado Amin, Aldrich T.S. et al. Kaposi sarcoma-associated herpes virus-associated malignancies, epidemiology, pathogenesis, and advances in treatment. Semin Oncall 4224-7, 2015. Solid and thorough review. Gashja, Green A.K. Congenital vascular tumors, Arolaringal Clin North and 5189, 2018. Good overview of vascular tumors and malformations. Pathology of vascular intervention. Gallo G., Pirelli G., Forte M. et al. Role of oxidative stress in the process of vascular remodeling following coronary revascularization. In J. Cardio 26827, 33, 2018. A well-written review highlighting the important role of reactive oxygen species pathways in vascular remodeling. In RT et al. Vascular inflammation and repair, implications for reendothelialization, restenosis, and stent thrombosis. Jack Cardiovascular 4 1057, 2011. Excellent overview of the inflammatory pathways that influence the outcomes of percutaneous vessel interventions. Kim F. et al. Saphenous vein graft disease. Review of pathophysiology, prevention, and treatment. Cardio Reverend 2110 2013. Good overview of the pathogenesis and clinical issues relating to venous bypass grafting, germane to all graft stenosis. Karasawa T. Takahashi M. Role of NLRP3 inflammasomes in atherosclerosis. J. Atherosclerosis 2444-3, 2017. Nice review describing the interaction of cholesterol microcrystals, phagocyte activation, inflammasome activation, cytokine production, and atherogenesis. Redker P. From C-reactive protein to interleukin-6 to interleukin-1, moving upstream to identify novel targets for atheroprotection. Circ Res 11-8-14-5, 2016. Well-written opinion piece regarding how C-reactive protein links to other inflammatory mediators and potentially identifies therapeutic targets. Aneurysms and dissection. Gillies E. Van Laer L. Lois B. L. Genetics of thoracic aortic aneurysm. At the crossroad of transforming growth factor beta signaling and vascular smooth muscle cell contractility. Circ Res 11-332-7, 2013. Good overview of the molecular and cellular basis for thoracic aneurysms. Mitchell J.B., John O.G., Milewicz D.M., From Genetics to Response to Injury, Vascular Smooth Muscle Cells and Aneurysms and Dissections of the Ascending Aorta, Cardiovasc Res 1157-8, 2018. Good discussion of the molecular pathways underlying human abdominal aortic aneurysm formation. Vasculitis. Jeanette J. Falk R. Nosology of Primary Vasculitis, Kerr Oppen Rheumatal 1910, 2007. Classification of vasculitis based on pathogenic mechanism and the vessels involved provides a good organization to a complex and potentially confusing aspect of vascular pathology. Jeanette J.C. Falk R.J. Pathogenesis of antineutrophil cytoplasmic autoantibody-mediated disease. Nat Reverend Rheumatal 1046-3, 2014. Well-written and well-organized overview of the big picture in antineutrophil cytoplasmic autoantibody vasculitis. Disorders of blood vessel hyperactivity. Mac Alpin RN. Some observations on and controversies about coronary arterial spasm in J. Cardio 8938-9, 2015. The clinical overview of coronary spasm and its sequelae. Suggested. See targeted therapy available at www.studentconsult.com. CHAPTE, or the Horther. 12. Andrew J. Call If of 127. Online, Richard N. Mitchell. Chapter contents. Cardiac structure and specializations. 528 myocardium, 528 valves, 528 conduction system, 528 blood supply, 528 cardiac regeneration, 529 effects of aging on the heart, 529 overview of cardiac pathophysiology, 529 heart failure, 530 cardiac hypertrophy, pathophysiology and progression to heart failure, 530 left-sided heart failure, 532 right-sided heart failure, 533 cardiac development, 534 congenital heart disease, 534 left to right shunts, 536 atrial defect, 536 patent foramen ovale, 537 ventricular septal defect, 537 patent ductus arteriosus, 538 right to left shunts, 538 tetralogy of Fallot, 538 transposition of the great arteries, 539 tricuspid atresia, 540 obstructive lesions, 540 cortation of the aorta, 540 pulmonary stenosis and atresia, 541 aortic stenosis and atresia, 541 ischemic heart disease, 542 angina pectoris, 543 myocardial infarction, 543 chronic ischemic heart disease, 553 arrhythmias, 554 sudden cardiac death, 555 hypertensive heart disease, 555 systemic left-sided hypertensive heart disease, 555 pulmonary right-sided hypertensive heart disease, cor pulmonale, 556 valvular heart disease, 557 calcific valvular degeneration, 557 calcific aortic stenosis, 557 calcific stenosis of congenitally bicuspid aortic valve, 559 Mitral annular calcification 559 mitral valve prolapse myxomatous degeneration of the mitral valve 559 rheumatic fever and rheumatic heart disease 560 infective endocarditis i.e. 563 non-affected vegetations 564 non-bacterial thrombotic endocarditis MBT 564 endocarditis of systemic lupus erythematosus Liebman-Sachs disease 565 carcinoid heart disease 565 complications of prosthetic valves 565 cardiomyopathies 567 dilated cardiomyopathy DCM 568 arrhythmogenic cardiomyopathy 572 hypertrophic cardiomyopathy 572 restrictive cardiomyopathy 574 amyloidosis 574 myocarditis 575 other causes of myocardial disease 577 cardiotoxic drugs 577 radiation 577 pericardial disease 577 pericardial effusion and hemopericardium 577 pericarditis 577 acute pericarditis 577 chronic or healed pericarditis 578 tumors of the heart 579 primary cardiac tumors 579 metastatic neoplasms 580 cardiac transplantation 580 cardiac devices 580 ventricular assist devices 581 human heart is a remarkably efficient, durable, and reliable pump, propelling more than 7,500 L of blood through the body each day and beating more than 40 million times a year, the wellspring for tissue oxygenation, nutrition, and waste removal. In utero, the heart and vasculature are the first fully functional organ system at roughly 8 weeks of gestation. Without a vascular supply and a beating heart, further development cannot occur and fetal demise is inevitable. When the heart fails postnatally, the results are equally catastrophic. Cardiovascular disease including coronary artery disease CAD, stroke, and peripheral vascular disease is the #1 cause of worldwide mortality. In the United States alone, cardiovascular disease accounts for roughly 1 in 4 of all deaths, totaling about 610,000 individuals each year, greater than the number of deaths caused by all forms of cancer combined. This chapter begins with a brief review of the normal heart because most cardiac diseases manifest as structural and/or functional changes in one or more cardiac components. General principles underlying cardiac hypertrophy and failure, common endpoints of several of the different forms of heart disease, are also discussed before exploring the major categories of cardiac disease: congenital heart abnormalities, ischemic heart disease IHD, hypertensive heart disease, diseases of the cardiac valves, and primary myocardial disorders. The chapter concludes with a few comments about pericardial diseases and cardiac neoplasms, as well as cardiac transplantation and devices. 825 Repoc 21 AT Tree H. Cardiac structure and specializations. Heart weight varies with body habitus, averaging approximately 0.4% to 0.5% of body weight 250 to 320 g in the average adult female and 300 to 360 g in the average adult male. Increased heart weight or ventricular thickness indicates hypertrophy, and an enlarged chamber size implies dilation. Both reflect compensatory changes in response to volume and/or pressure overload. See later. Increased cardiac weight or size or both, resulting from hypertrophy and/or dilation, is called cardiomegaly. Myocardium. The pumping function of the heart occurs through coordinated contraction during systole and relaxation during diastole of cardiac myocytes. The myocardium. Left ventricular myocytes are arranged in a spiral circumferential orientation to generate vigorous coordinated waves of contraction spreading from the cardiac apex to the base of the heart. In contrast, right ventricular myocytes have a less structured organization, generating overall less robust contractile forces. Contraction is achieved by shortening of serial contractile element sarcomeres within parallel myofibrils. Although the heart is primarily a pump, it is worth remembering that it also has other functions, for example, endocrine. For example, atrial cardiomyocytes have cytoplasmic storage granules that contain atrial natriuretic peptide, and ventricular myocytes contain B-type natriuretic peptide. Both of these are protein hormones that are released in response to increased stretch. They both promote arterial vasodilation and stimulate renal salt and water elimination, natriuresis and diuresis. Valves. The 4 cardiac valves, tricuspid, pulmonary, mitral, and aortic, maintain unidirectional blood flow. Valve function depends on the mobility, pliability, and structural integrity of the leaflets of the atrioventricular valves, tricuspid and mitral or cusps of the semilunar valves, aortic and pulmonary. The function of the semilunar valves depends on the integrity and coordinated movements of the cuspal attachments. Thus, dilation of the aortic root can result in valvular regurgitation. In contrast, the competence of the atrioventricular valves depends on the proper function not only of the leaflets but also the tendinous cords and the attached papillary muscles of the ventricular wall. Left ventricular dilation, a ruptured cord, or papillary muscle dysfunction can all interfere with mitral valve closure, causing valvular insufficiency. Cardiac valves are lined by endothelium and share a similar tri-layer architecture. Fibrosal layer, a dense collagenous layer at the outflow surface, connected to the valvular supporting structures and providing mechanical integrity. Spongiosal layer, a central core of loose connective tissue. Ventricularis or atrialis layer depending on which chamber it faces. A layer rich in elastin on the inflow surface, providing leaflet recall. Because they are thin enough to be nourished by diffusion from the blood, normal leaflets and cusps have only scant blood vessels limited to the proximal portion of the valve. Valve endothelium also does not express ABO or histocompatibility antigens, so cryopressor valvular tissues can be transplanted with relative impunity. Conduction system. Coordinated contraction of the cardiac muscle depends on the initiation and rapid propagation of electrical impulses, accomplished through specialized myocytes in the conduction system. The frequency of electrical impulses is sensitive to neural inputs, for example, vagal stimulation, extrinsic adrenergic agents, for example, circulating adrenaline, hypoxia, and potassium concentration, i.e., hyperkalemia, can block signal transmission altogether. The components of the conduction system include the following. Sinoatrial SA no pacemaker, at the junction of the right atrial appendage and superior vena cava. Atrioventricular AV node, located in the right atrium along the interatrial septum. Bundle of his AV bundle, connecting the right atrium to the ventricular septum. Right and left bundle branch divisions that stimulate their respective ventricles via further arborization into the Purkinje network. The cells of the cardiac conduction system depolarize spontaneously, potentially enabling all of them to function as cardiac pacemakers. Because the normal rate of spontaneous depolarization in the SA node 60 to 100 beats/minute is faster than the other components, it normally sets the pace. However, if nodal tissues become dysfunctional, other cells in the conduction system can take over, generating, for example, a junctional escape rhythm, usually at a much slower rhythm. The AV node has a gatekeeper function. By delaying the transmission of signals from the atria to the ventricles, it ensures that atrial contraction precedes ventricular systole. Blood supply. Cardiac myocytes rely almost exclusively on oxidative phosphorylation for their energy needs. Besides a high density of mitochondria, 20% to 30% of myocyte volume, myocardial energy generation also requires a constant supply of oxygenated blood, rendering myocardium extremely vulnerable to ischemia. Nutrients and oxygen are delivered via the coronary arteries, with ostia immediately distal to the aortic valve. These initially course along the external surface of the heart epicardial coronary arteries and then penetrate the myocardium intramural arteries, subsequently branching into arterioles and forming a rich arborizing vascular network so that each myocyte contacts roughly 3 capillaries. The right and left coronary arteries function as end arteries, although anatomically most hearts have numerous intercoronary anastomosis connections called collateral circulation. Blood flow to the myocardium occurs during ventricular diastole, after closure of the aortic valve. Wyverf table 4 arcade oak igaloids potap 925, when the microcirculation is not compressed by cardiac contraction. At rest, diastole comprises approximately 2/3 of the cardiac cycle. With tachycardia, increased heart rate, the relative duration of diastole also shortens, thus potentially compromising cardiac perfusion. Cardiac regeneration. There is considerable interest in exploring the possibility of replacing damaged myocardium by inducing cardiac regeneration in vivo or implanting stem cell-derived cardiac cells. Although cardiac regeneration in metazoans such as newts and zebrafish is well described, the myocardium of mammals has a very low replicative potential after fetal and neonatal life, averaging less than 1% cardiomyocyte turnover per year in adult humans. Increasing evidence, however, indicates that cardiomyocyte proliferation can be augmented in mice. The potential for stimulating cardiac regeneration in vivo in humans is tantalizing because it could facilitate recovery of myocardial function after a host of injurious stimuli. Another area of vigorous investigation is ex vivo expansion and subsequent administration of stem cell-derived myocardial cells into areas of myocardial injury. Unfortunately, results thus far have been less than exciting. Implanted cells may show some cardiomyocyte differentiation, but the durability of this benefit has been limited, and they do not contribute significantly to the restoration of contractile force. Moreover, failure to successfully integrate these cells into the conduction pathways of the host heart carries the very real risk of autonomous or arrhythmic foci. Effects of aging on the heart. Most forms of heart disease become more prevalent with each advancing decade. Consequently, as the average populations in high-income countries get progressively older, aging-associated changes in the cardiovascular system become ever more significant. Table 12.1. The size of the left ventricular cavity, particularly in the base to apex dimension, is reduced in later life. This volume change is exacerbated by systemic hypertension as the basal ventricular septum protrudes into the left ventricular outflow tract, so-called sigmoid septum. Compared with younger myocardium, the elderly heart typically has fewer myocytes due to degenerative attrition and increased connective tissue. Octogenarians and older also frequently have deposition of extracellular amyloid, most often poorly catabolized transthyretin. Chapter 6 that stiffens the heart and reduces diastolic filling. Valvular aging changes are major contributors to significant valvular disease. See later. And progressive atherosclerosis, with a strong aging component. Chapter 11 is the major cause of IHD. Overview of cardiac pathophysiology. Although a host of diseases can affect the cardiovascular system, the pathophysiologic pathways that result in a broken heart distill down to 6 principal mechanisms. 12.1 In the aging heart chambers: increased left atrial cavity size, decreased left ventricular cavity size, sigmoid-shaped ventricular septum. Valves: aortic valve calcific deposits, mitral valve annular calcific deposits, fibrous thickening of leaflets, buckling of mitral leaflets toward the left atrium, lamellal excrescences. Epicardial coronary arteries: tortuosity, diminished compliance, calcific deposits, atherosclerotic plaque. Myocardium: decreased mass, increased subepicardial fat, brown atrophy, lipofuscin deposition, basophilic degeneration, amyloid deposits. Aorta: dilated ascending aorta with rightward shift, elongated tortuous thoracic aorta, tubular junction, calcific deposits, elastic fragmentation and collagen accumulation, atherosclerotic plaque changes. Failure of the pump: in the most common situation, the cardiac muscle contracts weakly and the chambers cannot empty properly, so-called systolic dysfunction. In some cases, the myocardium cannot relax sufficiently to permit ventricular filling, resulting in diastolic dysfunction. Obstruction to flow: lesions that prevent valve opening, for example, calcific aortic valve stenosis, or cause increased ventricular chamber pressures, for example, systemic hypertension or aortic coarctation, can overwork the myocardium, which has to pump against the obstruction. Regurgitant flow: valve pathology that allows backward flow of blood results in increased volume workload and may overwhelm the pumping capacity of the affected chambers. Stunted flow: defects, congenital or acquired, that divert blood inappropriately from one chamber to another, or from one vessel to another, lead to pressure and volume overloads. Disorders of cardiac conduction: uncoordinated cardiac impulses or blocked conduction pathways can cause arrhythmias that slow contractions or prevent effective pumping altogether. Rupture of the heart or major vessel: loss of circulatory continuity, for example, a gunshot wound through the thoracic aorta may lead to massive blood loss, hypotensive shock, and death. Most cardiovascular disease results from a complex interplay of genetics and environmental factors. These can disrupt signaling pathways that control morphogenesis. 530 Chapter 12 The heart: affect myocyte survival after injury, or affect contractility or electrical conduction in the face of biomechanical stressors. Indeed, the pathogenesis of many congenital heart defects involves an underlying genetic abnormality whose expression is modified by environmental factors. See later. Moreover, genes that control the development of the heart may also regulate the response to various forms of injury, including aging. Subtle polymorphisms can significantly affect the risk of many forms of heart disease, and, as discussed later, a number of adult-onset heart disorders have a fundamentally genetic basis. Thus, cardiovascular genetics provides an important window on the pathogenesis of heart disease, and molecular diagnoses are increasingly a critical part of its classification. Heart failure. Heart failure, often called congestive heart failure (CHF), is a common, usually progressive condition with a poor prognosis. Each year in the United States, CHF affects more than 5 million individuals, approximately 2% of the population, necessitating more than 1 million hospitalizations and contributing to the death of nearly 300,000 people. Roughly 1/2 of patients die within 5 years of receiving a diagnosis of CHF, and 1 in 9 deaths in the United States include heart failure as a contributory cause. Heart failure is defined as the condition in which a heart cannot pump blood to adequately meet the metabolic demands of peripheral tissues, or can do so only at elevated filling pressures. It is the common end stage of many forms of chronic heart disease, often emerging insidiously from the cumulative effects of chronic work overload, for example, in valve disease or hypertension, or IHD, for example, after myocardial infarction (MI) with heart damage. However, acute hemodynamic stresses, such as fluid overload, abrupt valvular dysfunction, or myocardial infarction, can all precipitate sudden CHF. When cardiac workload increases or cardiac function is compromised, several physiologic mechanisms swing into action and can at least initially maintain arterial pressure and organ perfusion. Frank Starling mechanism: increased filling volumes dilate the heart, thereby increasing actin-myosin cross-bridge formation and enhancing contractility and stroke volume. Activation of neurohumeral systems: these augment heart function and or regulate filling volumes and pressures, and many of the therapies for CHF affect these systems when they become maladaptive. Release of norepinephrine by adrenergic nerves of the autonomic nervous system, elevating heart rate, augmenting myocardial contractility, and increasing vascular resistance. Activation of the renin-angiotensin-aldosterone system, promoting water and salt retention, augmenting circulatory volume, and increasing vascular tone. Release of atrial natriuretic peptide, counterbalancing the renin-angiotensin-aldosterone system through diuresis and vascular smooth muscle relaxation. Myocardial adaptations: in many pathologic states, heart failure is preceded by cardiac hypertrophy, a compensatory response to increased mechanical work. Ventricular remodeling is the general term applied to the collective molecular, cellular, and structural changes that occur in response to injury or altered ventricular loading. Although such adaptive mechanisms can potentially maintain adequate cardiac output in the face of acute perturbations, their capacity to do so may ultimately be overwhelmed. Heart failure can result from progressive deterioration of myocardial contractile function, systolic dysfunction, reflected as a decrease in ejection fraction (EF), the percentage of blood volume ejected from the ventricle during systole. Normal is approximately 45% to 65%. Reduction in EF can occur with ischemic injury, inadequate adaptation to pressure or volume overload due to hypertension or valvular disease, or ventricular dilation. Increasingly, heart failure is recognized as resulting from an inability of the heart chamber to expand and fill sufficiently during diastolic dysfunction, for example, due to left ventricular hypertrophy, myocardial fibrosis, constrictive pericarditis, or amyloid deposition. Cardiac hypertrophy: pathophysiology and progression to heart failure. Sustained increase in mechanical work of either ventricle due to pressure overload, volume overload, or trophic signals, for example, those mediated through the activation of beta-adrenergic receptors, causes myocytes to increase in size. Cellular hypertrophy: cumulatively, this increases the size and weight of the heart fig. 12.1. Hypertrophy requires increased protein synthesis to form additional sarcomeres, as well as increasing the numbers of mitochondria. Hypertrophic myocytes also have multiple or enlarged nuclei, attributable to increased DNA ploidy resulting from DNA replication in the absence of cell division. The pattern of hypertrophy reflects the nature of the stimulus. In pressure overload hypertrophy, for example, due to hypertension or aortic stenosis, new sarcomeres are predominantly assembled in parallel to the long axis of cells, expanding the cross-sectional area of myocytes and ventricles and causing a concentric increase in wall thickness. In contrast, volume overload hypertrophy, for example, due to valvular regurgitation, is characterized by new sarcomeres being assembled in series within existing sarcomeres, leading primarily to ventricular dilation. As a result, in dilation due to volume overload, or dilation that accompanies failure of a previously pressure overloaded heart, the wall thickness may be increased, normal, or less than normal. Consequently, heart weight, rather than wall thickness, is the best measure of hypertrophy in dilated hearts. Heart disease can lead to dramatic levels of cardiac hypertrophy. Patients with systemic hypertension, aortic stenosis, mitral regurgitation, or dilated cardiomyopathy frequently have heart rates double or triple the average. And aortic regurgitation or hypertrophic cardiomyopathy can produce heart rates threefold to fourfold greater than normal. Important changes at the tissue and cell level occur with cardiac hypertrophy. Significantly, myocyte hypertrophy. Failure 531, a B. CD figure 12.1 left ventricular hypertrophy. Pressure hypertrophy due to left ventricular outflow obstruction. The left ventricle is on the lower right in this apical four-chamber view of the heart. The left ventricular hypertrophy with and without dilation, viewed in transverse heart sections. Compared with the normal heart center, the pressure hypertrophy heart's left and then have increased mass in a thick left ventricular wall, and the hypertrophy dilated heart right has increased mass and an apparently normal wall thickness. See normal myocardium. The hypertrophied myocardium C and D are photomicrographs at the same magnification. Note the increases in both cell size and nucleus size in the hypertrophied myocytes, and the interstitial cells remain small. And B. Reproduce with permission from Edwards W.D. Cardiac Anatomy and Examination of Cardiac Specimens. In Emanuelized G.C. et al. Editors, Moss and Adams. Heart disease in infants, children, and adolescents, including the fetus and young adults. At 5. Philadelphia, 1995. Williams and Wilkins, p. 86. Heart is not accompanied by a proportional increase in capillary numbers. As a result, the supply of oxygen and nutrients to the hypertrophied heart, particularly one undergoing pressure overload hypertrophy, is more tenuous than in the normal heart. At the same time, cardiac hypertrophy is associated with heightened metabolic demands due to increases in mass, heart rate, and contractility in atropic state, or force of contraction, all of which increase cardiac oxygen consumption. As a result of these changes, the hypertrophied heart is vulnerable to ischemia-related decompensation, which can evolve to cardiac failure. Adding insult to injury, hypertrophy is also typically accompanied by a deposition of fibrous tissue interstitial fibrosis, causing increased resistance to diastolic filling. Molecular changes in hypertrophied cardiomyocytes include the expression of immediate early genes, for example, FOS, GIN, MYC, and e.g. Roan chapter 2 putatively driving cellular growth and altered protein expression. With prolonged hemodynamic overload, myocytes can even express genes usually only seen during fetal cardiac development, including fetal forms of myosin, natriuretic peptides, and collagen. The proposed sequence of initially adaptive and later harmful events in response to increased cardiac work is summarized in Fig. 12.2. As illustrated, heart failure eventually supervenes. The degree of anatomic abnormality does not always reflect the severity of dysfunction. Indeed, the gross appearance of the failing heart does not adequately convey the underlying structural, biochemical, and molecular basis for myocardial contractile failure. The hearts of patients with CHF are generally heavy and dilated, but can be relatively thin-walled, and histologically they exhibit variable degrees of myocyte hypertrophy. Loss of myocardial mass in the setting of infarction leads to work-related hypertrophy of the surrounding viable myocardium. In valvular heart disease, the increased pressure or volume overloads the myocardium globally. Increased heart mass owing to disease. 532 Chapter 12 The Heart. Hypertension. Pressure overload. Valvular disease. Pressure and or volume overload. Cardiac work. Wall stress. Cell stretch. Hypertrophy and or dilation. Characterized by heart size and mass. Protein synthesis. Induction of immediate early genes. Induction of fetal gene program. Abnormal proteins. Fibrosis. Inadequate vasculature. Cardiac dysfunction. Characterized by heart failure systolic/diastolic. Arrhythmias. Neurohumoral stimulation. Figure 12.2 Schematic representation of the causes and consequences of cardiac hypertrophy is correlated with excess cardiac mortality and morbidity. Indeed, cardiomegaly is an independent risk factor for sudden death. In contrast to the pathologic hypertrophy associated with persistent mechanical stressors, regular exercise can promote potentially beneficial physiologic hypertrophy. Aerobic exercise, for example, Long-distance running tends to be associated with volume load hypertrophy accompanied by increases in capillary density. Unlike other forms of hypertrophy, regular aerobic activity also decreases the resting heart rate and blood pressure, effects that are all beneficial. In comparison, purely static exercise, for example, weightlifting induces mild pressure hypertrophy, for example, secondary to recurring Valsalva maneuvers and less beneficial remodeling. Whatever its basis, CHF is characterized by variable degrees of decreased cardiac output and tissue perfusion forward failure, as well as pooling of blood in the venous capacitance system backward failure. The latter may cause pulmonary edema, peripheral edema, or both. As a result, many of the significant clinical features and morphologic changes noted in CHF are actually secondary to disorders induced by hypoxia and congestion in non-cardiac peripheral tissues. The cardiovascular system is a closed circuit. Thus, although left-sided and right-sided failure can occur independently, failure of one side, particularly the left, often produces excessive strain on the other, terminating in global heart failure. Despite this interdependence, it is easiest to understand the pathology of heart failure by considering right and left-sided heart failure separately. Myocardial infarction, regional dysfunction with volume overload, left-sided heart failure. Left-sided heart failure is most often caused by the following: hypertension, aortic and mitral valvular diseases, primary myocardial diseases. The clinical and morphologic effects of left-sided CHF are a consequence of passive congestion, blood backing up in the pulmonary circulation, stasis of blood in the left-sided chambers, and inadequate perfusion of downstream tissues leading to organ dysfunction. Morphology: heart. The findings depend on the disease process, ranging from myocardial infarcts to stenotic or regurgitant valves to intrinsic myocardial pathology. Except for failure caused by mitral valve stenosis or unusual restrictive cardiomyopathies described later, the left ventricle is usually hypertrophied and often dilated, sometimes massively. Left ventricular diastolic dysfunction or dilation with mitral valve incompetence causes secondary dilation of the left atrium, increasing the risk of atrial fibrillation. This in turn results in stasis of blood, particularly in the atrial appendage, which is a common site of thrombus formation. The microscopic changes in the failing heart are nonspecific, variable degrees of myocyte hypertrophy and interstitial fibrosis. Lungs. Pulmonary congestion and edema produce heavy, wet lungs, as described elsewhere, chapters 4 and 15. Pulmonary changes, from mildest to most severe, include 1. Perivascular and interstitial edema, particularly in the interlobular septum. 2. Progressive edematous widening of alveolar septum. And 3. Accumulation of edema fluid in the alveolar spaces. Extravasated red cells and plasma proteins in the alveoli are phagocytosed and digested by macrophages. The accumulated iron is stored as hemosiderin. These hemosiderin-laden macrophages, also known as heart failure cells, are telltale signs of previous episodes of pulmonary edema. Pleural effusions, typically serous, arise from elevated pleural capillary and lymphatic pressure and the resultant transudation of fluid into the pleural cavities. Early left-sided heart failure symptoms are related to pulmonary congestion and edema. Initially, cough and dyspnea, breathlessness may occur only with exertion. As CHF progresses, worsening pulmonary edema may cause orthopnea, dyspnea when supine, relieved by sitting or standing, or paroxysmal nocturnal dyspnea, dyspnea usually occurring at night that is so severe that it induces a feeling of suffocation. Dyspnea at rest may follow. The respiratory symptoms are characteristically associated with fine rales at the lung bases, caused when edematous pulmonary alveoli snap open during inspiration. Other manifestations of left ventricular failure include an enlarged heart cardiomegaly, apparent on imaging, tachycardia, a third heart sound due to volume overload S3, or a fourth heart sound S4 due to increased myocardial stiffness. If heart failure is associated with progressive ventricular dilation, the papillary muscles are displaced outward, causing mitral regurgitation. Subsequent chronic dilation of the left atrium can cause atrial failure. 533. Fibrillation and such uncoordinated, chaotic atrial contractions reduce the atrial contribution to ventricular filling, thus reducing the ventricular stroke volume. In moderate CHF, a reduced ejection fraction leads to diminished renal perfusion, causing activation of the renin-angiotensin-aldosterone system as a compensatory mechanism to correct the perceived hypotension. This leads to salt and water retention, with expansion of the interstitial and intravascular fluid volumes chapters 4 and 11 exacerbating the ongoing pulmonary edema. If the hypoperfusion of the kidney becomes sufficiently severe, impaired excretion of nitrogenous products may cause azotemia called prerenal azotemia, chapter 20. And for advanced CHF, cerebral hypoperfusion can give rise to hypoxic encephalopathy, chapter 28, with irritability, loss of attention span, and restlessness that can progress to stupor and coma with ischemic cerebral injury. Left-sided heart failure can be divided into systolic and diastolic failure. Systolic failure is defined by insufficient ejection fraction pump failure and can be caused by any of the many disorders that damage or derange the contractile function of the left ventricle. In diastolic failure, the left ventricle is abnormally stiff and cannot relax during diastole. Thus, although cardiac function is relatively preserved at rest, the heart is unable to increase its output in response to increases in the metabolic demands of peripheral tissues, for example, during exercise. Moreover, because the left ventricle cannot expand normally, any increase in filling pressure is immediately transferred back into the pulmonary circulation, producing pulmonary edema. Hypertension is the most common underlying etiology. Diabetes mellitus, obesity, and bilateral renal artery stenosis can also be causal. Reduced left ventricular relaxation may stem from myocardial fibrosis, for example, and cardiomyopathies and IHD or infiltrative disorders associated with restrictive cardiomyopathies, for example, cardiac amyloidosis. Diastolic failure may appear in older patients without any known predisposing factors, possibly as an exaggeration of the normal stiffening of the heart with age. Constrictive pericarditis, discussed later, can also limit myocardial relaxation and therefore mimics primary diastolic dysfunction. Right-sided heart failure. Right-sided heart failure is most commonly caused by left-sided heart failure, as any increase in pressure in the pulmonary circulation from left-sided failure inevitably burdens the right side of the heart. Consequently, the causes of right-sided heart failure include all the etiologies for left-sided heart failure. Isolated right-sided heart failure is infrequent and typically occurs in patients with one of a variety of disorders affecting the lungs. Hence, it is often referred to as cor pulmonale. Besides parenchymal lung diseases, cor pulmonale can also arise secondary to disorders that affect the pulmonary vasculature, for example, primary pulmonary hypertension, chapter 15, recurrent pulmonary thromboembolism, chapter 4, or conditions that cause pulmonary vasoconstriction, obstructive sleep apnea, altitude sickness. The common feature of these disorders is pulmonary hypertension, discussed later, which results in hypertrophy and dilation of the right side of the heart. In extreme cases, leftward bulging of the interventricular septum can even cause left ventricular dysfunction. The major morphologic and clinical effects of primary right-sided heart failure differ from those of left-sided heart failure in that pulmonary congestion is minimal while engorgement of the systemic and portal venous systems is pronounced. Morphology: heart. As in left heart failure, the cardiac morphology varies with cause. Rarely, structural defects such as tricuspid or pulmonary valvular abnormalities or endocardial fibrosis, as in carcinoid heart disease, may be present. However, because isolated right heart failure is most often caused by lung disease, most cases exhibit only hypertrophy and dilation of the right atrium and ventricle. Liver and portal system. Congestion of the hepatic and portal vessels may produce pathologic changes in the liver, the spleen, and the gastrointestinal tract. The liver is usually increased in size and weight. Congestive hepatomegaly caused by passive congestion, greatest around the central veins, chapter 4. Grossly, this is reflected as congested red-brown pericentral zones with relatively normal color tan periportal regions, producing the characteristic nutmeg liver appearance, chapter 4. In some instances, especially when left-sided heart failure with hypoperfusion is also present, severe centrilobular hypoxia produces centrilobular necrosis. With long-standing severe right-sided heart failure, the central areas can become fibrotic, eventually culminating in cardiac cirrhosis, chapter 18. Portal venous. Hypertension also causes enlargement of the spleen with platelet sequestration, congestive splenomegaly, and can also contribute to chronic congestion and edema of the bowel wall. The latter may be sufficiently severe as to interfere with nutrient and or drug absorption. Pleural, pericardial, and peritoneal spaces. Systemic venous. Congestion can lead to fluid accumulation, effusions in the pleural, pericardial, or peritoneal spaces of peritoneal effusions, also called ascites. Large pleural effusions can impact lung inflation, causing atelectasis, and substantial ascites can also limit diaphragmatic excursion, causing dyspnea on a purely mechanical basis. Subcutaneous tissues, edema of the peripheral and dependent portions of the body, especially foot/ankle pedal and pertibial. Edema is a hallmark of right-sided heart failure. In chronically bedridden patients, prosacral edema may predominate. Generalized, massive edema anosarca can also occur. The kidney and the brain are also prominently affected in right-sided heart failure. Renal congestion is more marked with right-sided than with left-sided heart failure, leading to greater fluid retention and peripheral edema and more pronounced azotemia. Venous congestion and hypoxia of the central nervous system can also produce deficits of mental function akin to those seen in left-sided heart failure with poor systemic perfusion. Although we have discussed right and left heart failure separately, it is again worth emphasizing that in many cases of chronic cardiac decompensation, patients with biventricular CHF have symptoms reflecting both right-sided and left-sided heart failure. Besides a careful history and physical heart, 534 Chapter 12 The Heart Examination. Serum levels of B-type or brain natriuretic factor BNP have become a popular tool to quantitatively assess the extent of CHF. Recall that BNP is released by ventricular cardiomyocytes during increased wall stress. A low value has a high negative predictive value for CHF. Echocardiography is also an extremely valuable tool in following patients with CHF, providing a measure of ejection fraction, wall motion, valvular function, and possible mural thrombosis. Treatment for CHF is initially focused on correcting any underlying cause, for example, a valvular defect or inadequate cardiac perfusion. Beyond that, the clinical approach includes salt restriction or pharmacologic agents that variously reduce volume overload, for example, diuretics, increase myocardial contractility, so-called positive inotropes, or reduce afterload via adrenergic blockade or inhibitors of angiotensin-converting enzymes AC. Although many of these medications provide benefit through effects on neurohumoral pathways, AC inhibitors also limit myocyte hypertrophy and cardiac remodeling. Although cardiac resynchronization therapy, exogenous pacing of both the right and left ventricles, and mechanical ventricular assist devices VADs, discussed later, have also been added to the cardiologist's armamentarium, CHF remains a serious cause of human morbidity and mortality. Key concepts: heart failure. Heart failure occurs when the heart is unable to provide adequate perfusion to meet the metabolic requirements of peripheral tissues. Inadequate cardiac output is usually accompanied by increased congestion of the venous circulation. Left-sided heart failure is most commonly due to IHD, systemic hypertension, mitral or aortic valve disease, and primary diseases of the myocardium. Symptoms are mainly a consequence of pulmonary congestion and edema, although systemic hypoperfusion can cause secondary renal and cerebral dysfunction. Right-sided heart failure is most often due to left heart failure, and less commonly to primary pulmonary disorders. Symptoms are chiefly related to peripheral edema and visceral congestion. Cardiac development. The heart is a mechanical organ that generates pulsatile blood within just 3 weeks after fertilization. It is therefore likely that hemodynamic forces play an important role in cardiac development, just as they influence adaptations in the adult heart such as hypertrophy and dilation. The diverse malformations seen in congenital heart disease (CHD) are caused by errors that occur during the complex migration and folding that constitutes cardiac morphogenesis. Derived from cells in the lateral mesoderm, the earliest cardiac precursors move to the midline in 2 migratory waves called the first and second heart fields within the first 15 days of fetal development. Although these are multipotent progenitor cells that can produce all of the major cell types of the heart: endocardium, myocardium, and smooth muscle cells, they rapidly assume distinct fates. Cells in the first wave largely populate the developing left ventricle, whereas those in the second wave become the outflow tract, right ventricle, and most of the atria. Thus, defects in one or the other anlage can explain some of the CHDs involving discrete structures. By day 20 of development, the nascent heart has become a beating tube, which begins to form the basic heart chambers roughly 8 days later. At about the same time, one neurocrest, derived cells migrate into the outflow tract, where they participate in the septation of the aortic and pulmonic outflow tracts and the formation of the aortic arch, and 2. Interstitial connective tissue expands to become definitive endocardial cushions that will become the future atrioventricular canals and outflow tracts. By day 50, further septation of the ventricles, atria, and atrioventricular valves produces a 4-chambered heart. Proper orchestration of these remarkable transformations depends on a network of transcription factors that are regulated by a number of signaling pathways, particularly the W&T, HEGI, vascular endothelial growth factor VAGF, bone morphogenetic protein, transforming growth factor beta TGF-beta, fibroblast growth factor, and Notch pathways chapter 1. It is not too surprising then that many of the inherited defects that affect heart development involve genes that encode transcription factors. These typically cause partial loss of function and are autosomal dominant, discussed later. In addition, specific microRNAs play critical roles in cardiac development by coordinating patterns and levels of transcription factor expression. Congenital heart disease. CHE refers to abnormalities of the heart or great vessels that are present at birth. Most CHE arises from faulty embryogenesis during gestational weeks 3 to 8, when major cardiovascular structures form and begin to function. Most severe anomalies preclude intrauterine survival, and significant heart malformations are common among stillborn infants. On the other hand, circumscribed defects affecting discrete regions of the heart or individual chambers can be compatible with live birth. In this latter category are the following: septal defects, or holes in the heart, including atrioseptal defects as or ventricular septal defects VSDs. Stenotic lesions, either at the level of valves or the entire cardiac chamber, as in hypoplastic left heart syndrome. Outflow tract anomalies, including inappropriate routing of the great vessels from the ventricles or anomalous coronary arteries. Such tolerated forms of CHE usually produce clinically important manifestations only after birth. Uncovered by the transition from fetal to perinatal circulation, roughly 1/2 will be diagnosed in the first year of life, although some milder forms may not be discovered until adulthood. For example, the incidence of CHE depends on what is counted as a defect. Thus, if echocardiography is performed routinely on neonates, small muscular VSDs or ASDs are detected in over 5% of live births. However, these typically close. Congenital heart disease 535. Elba T 2.21 Seiknuker F Folatino C Cadris C Asnor Tamrafla. Incidence per malformation million live births. Ventricular septal defect 448242. Atrioseptal defect 104310. Pulmonary stenosis 836-8. Patent ductus arteriosus 781-7. Tetralogy of Fallot 577-5. Cortation of the aorta 492-5. Atrioventricular septal defect 396-4. Aortic stenosis 388-4. Transposition of the great arteries 388-4. Truncus arteriosus 136-1. Total anomalous pulmonary 121. Venous connection. Tricuspid atresia 118-1. Total 9,757. Are presented as upper quartile of 44 published studies. Percentages do not add up to 100% because of rounding. Does not include bicuspid aortic valves. Data from Hoffman J.I., Kaplan S. The incidence of congenital heart disease, J.M. Cardio 3912, 1890, 1900, 2002. Syndrome. Indeed, the most common known genetic cause of CHE is trisomy 21 Down syndrome. Roughly 40% of patients with Down syndrome have one or more heart defects, most often affecting structures derived from the second migratory wave of cells, for example, the atrioventricular septi. The mechanisms by which aneuploidy causes CHE likely involve the dysregulated expression of multiple genes. A notable example of a small chromosomal lesion causing CHE is deletion of chromosome 22q11, occurring in patients with Di-George syndrome. In this syndrome, the fourth branchial arch and the derivatives of the third and fourth pharyngeal pouches, which contribute to the formation of the thymus, parathyroid glands, and heart, develop abnormally. Of the 30 or so genes present on this chromosome segment, deletion of the TB zone transcription factor gene is probably the culprit lesion. TB zone regulates neural crest migration, as well as the expansion of cardiac progenitors in the second migratory wave. Interestingly, deletions in this region are also associated with mental illness, including schizophrenia. In the case of single gene mutations, The affected genes encode proteins belonging to several different functional classes. Table 12.3. As mentioned earlier, many of these involve transcription factors. Because affected patients are heterozygous for such mutations, it follows that a 50% reduction in the activity of these factors or even less may spontaneously in the first year of life, and they probably should not be tallied with the burden of CHD. Similarly, bicuspid aortic valve, with an incidence of 1% to 2%, clearly persists beyond infancy, but often has modest manifestations and may not become evident until late adulthood. If their counting is restricted to more serious defects, the worldwide incidence of congenital cardiovascular malformations is slightly less than 1%, still ranking CHD among the most prevalent birth defects. 12 disorders account for about 85% of cases. Their frequencies are listed in Table 12.2. The number of individuals who survive into adulthood with CHD is increasing rapidly and is estimated at nearly 1.5 million people in the United States alone. Many have benefited from surgical advances that increasingly permit early postnatal repair of structural defects. In some cases, however, surgical intervention fails to restore complete normalcy. Patients may have already sustained pulmonary or myocardial changes that are no longer reversible, or conversely, may suffer from arrhythmias due to surgical scarring. Other factors that impact the long-term outcome include complications associated with the use of prosthetic materials and devices, for example, substitute valves or myocardial patches, and the cardiovascular stressors associated with childbearing that may tip a repair heart into failure. LBT 3.21 Detzel S submax E4 NGSTCFD Detekasa HGIW Latino C3 HECCD. Gene product. Disorder gene S function. Non-syndromic. ASD or conduction defects 2.5. Transcription factor. ASD or VSD GATFR transcription factor. Tetralogy of Fallot CFP mTOL or transcription factors. 2.5. Syndromic. Alago syndrome. JAGON or signaling proteins or pulmonary artery stenosis not atrial receptors or tetralogy of Fallot. Charge syndrome. PDA TFA P12B transcription factor. Charge syndrome as CHD7 helicase binding VSD, PDA, or hypoplastic protein right side of the heart. DiGeorge syndrome as TB's own transcription factor VSD, or outflow tract obstruction. Whole arm syndrome as TBX5 transcription factor VSD, or conduction defect. Noonan syndrome, PTP11, signaling proteins pulmonary valve stenosis, CROS, VSD, or hypertrophic Sosome cardiomyopathy, as atrial septal defect, charge, posterior collarboma, heart defect, choanal atresia, retardation, genital and ear anomalies, PDA, patent ductus arteriosus, VSD, ventricular septal defect. Different mutations can cause the same phenotype, and mutations in some genes can cause multiple phenotypes, for example, 2.5. Many of these congenital lesions also can occur sporadically, without specific genetic mutation. Only the cardiac manifestations of the syndrome are listed. The other skeletal, facial, neurologic, and visceral changes are not. Etiology and pathogenesis, environmental exposures, for example, congenital rubella infection, teratogens, including some therapeutic drugs, and gestational diabetes and genetic factors are the best characterized causes but still account for a minority of CHD cases. Nutritional factors can also influence risk. Folate supplementation during early pregnancy reduces CHD incidence. Genetic factors include specific loci implicated in familial forms of CHD and certain chromosomal abnormalities, for example, trisomies 13, 15, 18, and 21, and monosomy X/Turner. 536 Chapter 12 The heart is sufficient to derange cardiac development. Even relatively minor decrements in activity of particular genes can result in significant defects. Thus, transient environmental stresses during the first trimester of pregnancy that alter the synthesis or activity of these same genes can conceivably lead to acquired defects that mimic those produced by heritable mutations. In addition, many of the transcription factors interact in large protein complexes, providing a rationale for why mutations in any one of several genes can produce similar defects. Thus, JTFR, TBX5, and NKX5, three transcription factors that are mutated in some patients with atrial and ventricular septal defects, all bind to one another and co-regulate the expression of target genes required for proper cardiac development. Other single gene mutations can alter structural proteins or affect signaling pathway molecules. Thus, mutations in genes encoding various components of the Notch pathway Chapter 1 are associated with a variety of congenital heart defects, including bicuspid aortic valve knock-home, discussed later in Tetralogy of Fallot-Jaegon and Knock-H12. As described in Chapter 5 and 11, fibrillin mutations underlie Marfan syndrome, associated with valvular defects and aortic aneurysms. Although fibrillin is an important structural protein in the extracellular matrix ECM, it is also an important negative regulator of TGF-beta signaling, and hyperactive TGF-beta signaling contributes to the cardiovascular abnormalities in Marfan syndrome and the related Loeys-Dietz syndrome. Despite these advances, our understanding of the mechanisms underlying CHE remains rudimentary. The precise cause is unknown in almost 90% of cases. Most affected patients have no identifiable genetic risk, and even in those that do, the nature and severity of the defect are highly variable. It is likely that most forms of CHE arise by interactions of environmental factors with multiple genes. Guidelines for genetic testing are complex and evolving but suggest that genetic testing may be useful in patients with a broader non-cardiac syndrome or a family history of CHE. Clinical features. Most of the various structural anomalies in CHE can be organized into three major categories according to the major functional abnormalities they cause. Left to right shunt, right to left shunt, obstruction. A shunt is an abnormal communication between chambers or blood vessels. Abnormal channels permit blood flow down pressure gradients from the left systemic side to the right pulmonary side of the circulation or vice versa. When blood from the right side of the circulation flows directly into the left side right to left shunt, hypoxemia and cyanosis of dusky blueness of the skin and mucous membranes result because the pulmonary circulation is bypassed and poorly oxygenated venous blood shunts directly into the systemic arterial supply. In addition, right to left shunts can allow emboli from the peripheral veins to bypass the lungs and directly enter the systemic circulation. Paradoxical embolism. Severe, long-standing hypoxia/cyanosis also causes increased numbers of circulating red blood cells polycythemia, as well as a peculiar distal blunting and enlargement clubbing of the tips of the fingers and toes that can include bony changes called hypertrophic osteoarthropathy. The most important causes of right to left shunts are tetralogy of Fallot-TOF, transposition of the great arteries TGA, persistent truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous connection. In contrast, left to right shunts, for example, as VSD and patent ductus arteriosus PDA, increase pulmonary blood flow but are not initially associated with cyanosis. However, left to right shunts chronically elevate both volume and pressure in the normally low pressure, low resistance pulmonary circulation. To maintain relatively normal distal pulmonary capillary and venous pressures, the muscular pulmonary arteries 1 mm in diameter initially respond by undergoing medial hypertrophy and vasoconstriction. However, prolonged pulmonary arterial vasoconstriction stimulates the development of irreversible obstructive intimal lesions analogous to the arteriolar changes seen in systemic hypertension. Pulmonary arteries can even develop frank atherosclerotic lesions. Chapter 11. The right ventricle also responds to the pulmonary vascular changes by undergoing progressive hypertrophy. Eventually, pulmonary vascular resistance approaches systemic levels, and the original left to right shunt becomes a right to left shunt that introduces poorly oxygenated blood into the systemic circulation as Menger syndrome. Once irreversible pulmonary hypertension develops, the structural defects of CHE are considered irreparable. Subsequent right heart failure can lead to the patient's death unless combined heart-lung transplantation can be performed. This provides the rationale for early intervention to close significant left to right shunts. Obstructive CHD occurs when there is abnormal narrowing of chambers, valves, or blood vessels. These include coarctation of the aorta, aortic valvular stenosis, and pulmonary valvular stenosis. Complete obstruction is called an atresia. In some disorders, for example, TOF, an obstruction pulmonary stenosis and a shunt right to left through a VSD are both present. The altered hemodynamics of CHE usually cause cardiac dilation or hypertrophy or both. However, some defects induce a decrease in the volume and muscle mass of the cardiac chamber. This is called hypoplasia if it occurs before birth and atrophy if it develops postnatally. Left to right shunts. Left to right shunts are the most common CHD. These include ASD, VSD, and PDA Fig. 12.3. ASDs typically increase only right ventricular and pulmonary outflow volumes, and VSDs and PDA cause both increased pulmonary blood flow and pressure. Depending on their size and location, manifestations of these shunts range in severity from no symptoms at all to fulminant heart failure. Atrial septal defect ASDs are abnormal, fixed openings in the atrial septum caused by incomplete tissue formation that allows communication of blood between the left and right atria. ASDs are usually asymptomatic until adulthood. See Table 12.2 and Fig. 12.3a. ASD should not be confused with patent foramen ovale PFO. See later, which represents the postnatal heart disease 537, ROD, LARV, LPT, LA, LV, atria. The valve opens only when the pressure is greater in the right atrium. In fetal life, the lungs are non-functional, and the pressure in the pulmonary circulation is greater than that of the systemic circulation. Thus, the right atrium is under higher pressures than the left atrium, and the valve of the foramen ovale is normally open. At birth, with lung expansion, the pulmonary vascular pressures drop, and the right atrial pressures fall below those in the left atrium. As a result, the valve of the foramen ovale closes, and is usually permanently sealed before adulthood. See later. B-ROD, RV, LPT. VSD, a Figure 12.3 common congenital left to right shunts arrows indicate the direction of blood flow. Atrial septal defect ASD. B ventricular septal defect VSD. With VSD, the shunt is left to right, and the pressures are the same in both ventricles. Pressure hypertrophy of the right ventricle and volume hypertrophy of the left ventricle are generally present. See Panductus arteriosus PDA. Al, aorta, LA, left atrium, LV, left ventricle, PT, pulmonary trunk, right atrium, or V, right ventricle. Failure to close a foramen channel that is part of normal development. A brief summary of the developmental stages of the atrial septum follows. The septum primum is a crescent-shaped membranous ingrowth that sits posteriorly between the right and left atria and partially separates them. The remaining transient anterior opening, called the ostium primum, allows movement of blood from the right to left atrium during early fetal development. Before the growing septum primum completely obliterates the ostium primum, it develops a second posterior opening called the ostium secundum. The septum secundum is a subsequent membranous ingrowth located to the right and anterior of the septum primum. The septum secundum grows to cover the ostium secundum, leaving only a small channel called the foramen ovale that is continuous with the ostium secundum. The foramen ovale/ostium secundum permits continued right to left shunting of blood during intrauterine development. This flap of septum secundum tissue opens and closes in response to pressure gradients between the left and right. LA, LV as C, RA, RV, PT, PDA. LA, LV morphology ASDs are classified according to their location. Secundum ASD 90% of all ASD result from a deficient septum secundum formation near the center of the atrial septum. These are usually not associated with other anomalies, may be of any size, and can be multiple or fenestrated. Primum anomalies 5% of ASD occur adjacent to the AV valves and are often associated with AV valve abnormalities and /or VSD. Sinus venosus defects 5% are located near the entrance of the superior vena cava and can be associated with anomalous pulmonary venous return to the right atrium. Clinical features ASDs are usually asymptomatic until adulthood. Although VSDs are more common, most close spontaneously. Consequently, AS, which are less likely to close spontaneously, are the most common defects to be diagnosed in adults. ASDs result in a left to right shunt, largely because pulmonary vascular resistance is considerably less than systemic vascular resistance and because the compliance distensibility of the right ventricle is much greater than that of the left. The resulting pulmonary flow volumes may be 2 to 8 times normal. A murmur is often present as a result of excessive flow through the pulmonary valve and / or through the ASD. Despite the right-sided volume overload, ASDs are generally well tolerated and usually do not become symptomatic before 30 years of age. Irreversible pulmonary hypertension is unusual. Surgical or intravascular ASD closure is performed to preempt the development of heart failure, paradoxical embolization, and irreversible pulmonary vascular disease. Mortality is low, and postoperative survival is comparable to that for an unaffected population. Patent foramen ovale. The foramen ovale closes permanently in approximately 80% of people by 2 years of age. However, in the remaining 20%, the unsealed flap can open if right-sided pressures become elevated. Thus, sustained pulmonary hypertension or even transient increases in right-sided pressures, for example, during a bowel movement, coughing, or sneezing can produce brief periods of right-to-left shunting with the possibility of paradoxical embolism. Ventricular septal defect VSDs are incomplete closures of the ventricular septum, allowing free communication of blood between the left to right ventricles. They are the most common form of CHEC Table 12.2 and Fig. 12.3b, congenital. 538 Chapter 12 The Heart. Figure 12.4 A membranous type ventricular septal defect arrow just proximal to the aortic valve. Courtesy William D. Ambers, MD. Mayo Clinic, Rochester, Men. Morphology VSDs are classified according to their location and magnitude. About 90% occur in the region of the membranous interventricular septum membranous VSD. Fig. 12.4, and the majority are 2 to 3 cm in diameter. The remaining 10% occur below the pulmonary valve infundibular VSD or within the muscular septum. Although most VSDs are single, those in the muscular septum may be multiple. The pulmonary artery to the aorta, thereby bypassing the unoxygenated lungs. In healthy-term infants, the ductus constricts and is functionally closed within 1 to 2 days of birth. This occurs in response to increased arterial oxygenation, decreased pulmonary vascular resistance, and declining local levels of prostaglandin EPO. Complete structural obliteration occurs within the first few months of extrauterine life, leaving behind the ligamentum arterius. Ductal closure is often delayed or even absent in infants with hypoxia due to respiratory distress or heart disease, or when other congenital defects are present, particularly VSDs that increase pulmonary vascular pressures. PDAs account for about 7% of cases of CHEC Table 12.2 and Fig. 12.3c, and 90% of these are isolated defects. PDA produces a characteristic, continuous, harsh machinery-like murmur. The clinical impact of a PDA depends on its diameter and the cardiovascular status of the individual. PDA is usually asymptomatic at birth, and a narrow PDA may have no effect on the child's growth and development. Because the shunt is initially left to right, there is no cyanosis. However, with large shunts, the additional volume and pressure overloads eventually produce obstructive changes in small pulmonary arteries, leading to reversal of flow and its associated consequences. In general, isolated PDA should be closed as early in life as is feasible. Therapy includes prostaglandin synthesis inhibitors and possibly percutaneous or surgical interventions. Conversely, preservation of ductal patency by administering prostaglandin EM may be life-saving for infants with various congenital malformations that obstruct the pulmonary or systemic outflow tracts. In CHE with aortic valve or pulmonary valve atresia, for example, a PDA may provide the entire systemic blood flow or pulmonary blood flow, respectively. Clinical features: right to left shunts. Most VSDs that clinically manifest in the pediatric age group are associated with other congenital cardiac anomalies, such that diseases in this group cause cyanosis early and postnatal as TOF. Only 20% to 30% are isolated. Conversely, if a VSD life cyanotic CHD, TOF, the most common in this group, is first detected only in an adult, it is usually an isolated and TGA are illustrated schematically in Fig. 12.5. The other's defect. The functional consequences of a VSD depend on include persistent truncus arteriosus, tricuspid atresia, and the size of the defect and whether there are associated total anomalous pulmonary venous connection. Note that right-sided malformations. Thus, large VSDs cause difficulties. The names of all of these conditions start with a T, virtually from birth. Smaller lesions are generally well tolerated for years and may not be recognized until much later. Tetralogy of fallout in life. Moreover, approximately 50% of small muscular. The four cardinal features of TOF are 1 VSD, 2 obstruction VSDs close spontaneously. Large defects are usually MEM of the right ventricular outflow tract, subpulmonic stenosis, branous or infundibular, and they generally cause significant 3 in aorta that overrides the VSD, and 4 right ventricular left to right shunting, leading to early right ventricular hypertrophy. See Fig. 12.5a. The first 3 features result hypertrophy and pulmonary hypertension. Over time, large embryologically from anterior superior displacement of the unclosed VSDs almost universally lead to irreversible infundibular septum and the right ventricular hypertrophy, pulmonary vascular disease, ultimately resulting in shunt as a secondary consequence of the pressure overload. Reversal in cyanosis. Surgical or catheter-based closure of asymptomatic VSD is generally delayed beyond infancy in hope of spontaneous closure. Early correction, however, morphology must be performed for large defects to prevent the development. The heart is typically enlarged and is classically boot-shaped meant of irreversible obstructive pulmonary vascular disease. Due to marked right ventricular hypertrophy, the VSD is usually patent ductus arteriasis large with the aortic valve at the superior border. Thereby over the ductus arteriasis arises from the pulmonary artery inriting the defect in both ventricular chambers. The obstruction joins the aorta just distal to the origin of the left subclavian to right ventricular outflow is most often due to narrowing of artery. During intrauterine life, it permits blood flow from the infundibulum subpulmonic stenosis but can be accompanied. Heart disease 539, RA, RV out, PT, RA, RV out, PT. The classic tetralogy of fallout, LA, RA, LV, with VSD without VSD. B complete transposition. Figure 12.5 Common congenital right to left shunt cyanotic congenital heart disease. Tetralogy of fallout. The direction of shunting across the ventricular septal defect VSD depends on the degree of the subpulmonic stenosis. Once severe, a right to left shunt results arrow. B dextra transposition of the great arteries with and without VSD. Out. Aorta. LA. Left atrium. LV. Left ventricle. PT. Pulmonary trunk. RA. Right atrium. RV, right ventricle, LA, LV out RV, PT, LA, LV, and thinner walled and the larger is the overriding aorta. As the child grows and the heart increases in size, the pulmonic orifice does not expand proportionally, making the obstruction progressively worse. The subpulmonic stenosis, however, protects the pulmonary vasculature from pressure overload, and right ventricular failure is rare because the right ventricle is decompressed by the shunting of blood into the left ventricle and aorta. Complete surgical repair is possible but becomes complicated for individuals with pulmonary atresia and dilated bronchial arteries. Transposition of the great arteries TGA produces ventricular arterial discordance, the ventricle outflow going to the wrong outflow vessel. In the more common variant dextro-TGA or DTGA, the aorta rises from the right ventricle, and the pulmonary artery emanates from the left ventricle ventricular arterial discordance. Fig. 12, 5b and Fig. 12.6. The atrium to ventricle connections are normal concordant, with the right atrium joining the right ventricle and the left atrium emptying into the left ventricle. The embryologic defect in complete TGA stems from abnormal formation of the spiraling truncal and aortopulmonary septi. The result is separation of the systemic and pulmonary circulations, a condition incompatible with postnatal life unless a shunt exists for adequate mixing of blood. The outlook for infants with DTGA depends on the degree of blood mixing, the magnitude of tissue hypoxia, and the ability of the right ventricle to maintain the systemic circulation. Patients with DTGA and a VSD, approximately 35%, often have a stable shunt. However, dependence on a patent foramen ovale or ductus arteriasis for blood mixing, approximately 65%, is problematic. These systemic top pulmonary connections tend to close early and thus require intervention to create a new shunt within the first few days of life, for example, balloon atrial septostomy. With time, right, by pulmonary valvular stenosis. Sometimes there is complete atresia of the pulmonary valve in variable portions of the pulmonary arteries, such that blood flow through a PDA, dilated bronchial arteries, or both, is necessary for survival. Aortic valve insufficiency or an ASD may also be present. A right aortic arch is present in about 25% of cases. Clinical features depending on the severity of the subpulmonic stenosis. Untreated TOF can be tolerated into adulthood. 10% of unoperated individuals are alive at 20 years of age, and 3% survive for 40 years. If the subpulmonic stenosis is mild, the abnormality resembles an isolated VSD, and the shunt may be left or right, without cyanosis, so-called pink tetralogy. With more severe right ventricular outflow obstruction, right-sided pressures approach or exceed left-sided pressures, and right-to-left shunting develops, producing cyanosis, classic TOF. Most infants with TOF are cyanotic at birth or soon thereafter. The more severe the subpulmonic stenosis, the more hypoplastic are the pulmonary arteries, i.e., smaller figure 12.6 dextrotransposition of the great arteries. Courtesy William D. Edwards, MD, Mayo Clinic, Rochester, Men, Congenital. Chapter 12, the Heart. Obstructive lesions. Raw, aorta, pulmonary, trunk, LV, LA. RV, congenital obstruction to blood flow can occur at the level of the heart valves or within a great vessel. Common examples include aortic or pulmonary valve stenosis or atresia, and coarctation of the aorta. Obstruction can also occur within a chamber, as with subpulmonic stenosis and TOF. Coarctation of the aorta, coarctation narrowing. Constriction of the aorta ranks high in frequency among the common structural anomalies. It is twice as common in males as in females. Interestingly, females with Turner syndrome are also frequently affected. Chapter 5. There are two classic forms, one an infantile form, often symptomatic in early childhood, with tubular hypoplasia of the aortic arch proximal to a PDA, and two an adult form with a discrete ridge-like enfolding of the aorta just opposite the closed ductus arteriosus ligamentum arteriosum distal to the arch vessels. Fig. 12.8. Encroachment. Figure 12.7 schematic for congenitally corrected leave or transposition of the great arteries. The right atrium RA flows to the morphologic left ventricle LV, which connects to the pulmonary arteries. The left atrium LA connects to the morphologic right ventricle RV, which empties into the aorta, which is anomalously anterior and to the left. This congenital malformation may be well tolerated, presenting only relatively late in adulthood with decompensation of the morphologic right ventricle. RA, LPT, LA, RA, LPT, LA. Ventricular hypertrophy becomes prominent because this chamber is functioning as the systemic ventricle. Concurrently, the left ventricle becomes thin-walled atrophic as it supports the low-resistance pulmonary circulation. Without surgery, most patients die within months. However, improved early surgical intervention, typically with an arterial switch operation, allows many patients with DTGA to survive into adulthood. In the less common level TGA, LTGA, also commonly referred to as congenitally corrected TGA, the right atrium connects to a ventricle with the internal morphology of a left ventricle atrioventricular discordance, which in turn empties into the pulmonary arteries ventricular arterial discordance. At the same time, the left atrium connects to a morphologic right ventricle, which empties into the aorta. Fig. 12.7. LTGA does not lead to cyanosis and indeed can be entirely asymptomatic, being diagnosed in adulthood only during a workup for other cardiac issues. Nevertheless, LTGA will result in hypertrophy of the morphologic right ventricle and eventually can cause heart failure. It is also often associated with other CHEs such as VSD, as and panforamen ovale. Tricuspid atresia. Tricuspid atresia represents complete occlusion of the tricuspid valve orifice. It results embryologically from unequal division of the AV canal. Thus, the mitral valve is larger than normal, and there is right ventricular underdevelopment hypoplasia. The circulation can be maintained by right or left shunting through an interatrial communication ASD or panforamen ovale, in addition to a VSD that connects the left ventricle and the pulmonary artery arising from the hypoplastic right ventricle. Cyanosis is present virtually from birth, and there is a high early mortality. AB, RVLV, with PDA without PDA. Coarctation of aorta, RVLV. Figure 12.8, a schematic of aortic coarctation with and without patent ductus arteriosus PDA. Decoarctation of the aorta, postductal type. The coarctation is a segmental narrowing of the aorta arrow. Such lesions typically manifest later in life than preductal coarctations. The dilated ascending aorta and major branch vessels are to the left of the coarctation. The lower extremities are perfused predominantly by way of dilated, tortuous collateral channels. Aorta, LA, left atrium, LV, left ventricle, PT, pulmonary trunk, right atrium, RV, right ventricle, PDA, patent ductus arteriosus. A. Courtesy William D. Edwards, MD, Mayo Clinic, Rochester, Men. B. Courtesy Sid Murphy, MD, Department of Pathology, University of Texas Southwestern Medical School, Dallas, Tex. 540. Congenital heart disease 541. The aortic lumen is variable, sometimes leaving only a small channel and at other times producing only minimal narrowing. Although coarctation of the aorta may occur as a solitary defect, in 50% of cases it is accompanied by a bicuspid aortic valve and may also be associated with congenital aortic stenosis, as VSD, mitral regurgitation, or berry aneurysms of the circle of Willis. Morphology. Preductal cortation is characterized by circumferential narrowing of the aortic segment between the left subclavian artery and the ductus arteriosus. The ductus typically is patent and is the main source of unoxygenated blood delivered to the distal aorta. The pulmonary trunk is dilated to accommodate the increased blood flow, because the right side of the heart now perfuses the body distal to the narrowed segment court. The right ventricle typically is hypertrophied. In the more common adult postductal cortation, the aorta is sharply constricted by a tissue ridge adjacent to the non-patent ligamentum arteriosum, see Fig. 12, 8b. The constricted segment is made up of smooth muscle and elastic fibers derived from the aortic median. Proximal to the cortation, the aortic arch and its branch vessels are dilated and the left ventricle is hypertrophied. Clinical features. Clinical manifestations depend on the severity of the narrowing and the patency of the ductus arteriosus. Cortation of the aorta with a PDA usually manifests early in life. Indeed, it may cause signs and symptoms immediately after birth. In such cases, the delivery of unsaturated blood through the PDA produces cyanosis localized to the lower half of the body. Many such infants do not survive the neonatal period without surgical or catheter-based intervention to occlude the PDA. The outlook is different with cortation of the aorta without a PDA. Unless the aortic constriction is severe, most children are asymptomatic, and the disease may go unrecognized until well into adult life. Typically, there is hypertension in the upper extremities with weak pulses and hypotension in the lower extremities, associated with manifestations of arterial insufficiency, i.e., claudication and coldness. Particularly characteristic is the development of collateral circulation between the precortation and postcortation arteries through enlarged intercostal and internal mammary arteries, often producing radiographically visible erosions notching of the undersurfaces of the ribs. With significant cortations, murmurs are present throughout systole. Sometimes a vibratory thrill is also present. The long-standing pressure overload leads to concentric left ventricular hypertrophy. With uncomplicated cortation of the aorta, surgical resection and end-to-end anastomosis or replacement of the affected aortic segment by a prosthetic graft yields excellent results. Pulmonary stenosis and atresia. Pulmonary stenosis or atresia is a relatively frequent malformation leading to obstruction at the level of the pulmonary valve. This can be mild to severe. The lesion can also be isolated or part of a more complex anomaly, either TOF or TGA. Right ventricular hypertrophy typically develops, and there is sometimes poststenotic dilation of the pulmonary artery due to injury of the wall by high-pressure jets through the stenotic valve. With coexistent subpulmonic stenosis as in TOF, the pulmonary trunk is not dilated and may in fact be hypoplastic. When the valve is entirely atretic, there is no communication between the right ventricle and lungs. In such cases, the anomaly is associated with a hypoplastic right ventricle and an ASD. Blood reaches the lungs through a PDA. Mild stenosis may be asymptomatic and compatible with long life, whereas symptomatic cases require surgical correction. When the RV is severely hypoplastic, blood can be surgically routed directly from the vena cava to the pulmonary artery, bypassing the right side of the heart. Aortic stenosis and atresia. Congenital narrowing and obstruction of the aortic valve can occur at three locations: valvular, subvalvular, and supravalvular. Congenital aortic valve stenosis is an isolated lesion in 80% of cases. With valvular aortic stenosis, the cusps may be hypoplastic, small, dysplastic, thickened, nodular, or abnormal in number, usually with one or no commatius. In severe congenital aortic stenosis or atresia, obstruction of the left ventricular outflow tract leads to hypoplasia of the left ventricle and ascending aorta, sometimes accompanied by dense, porcelain-like left ventricular endocardial fibroelastosis. The ductus arteriosus must be patent to allow blood flow to the aorta and coronary arteries. The constellation of findings is called hypoplastic left heart syndrome, and unless PDA patency is preserved, duct closure in the first week of life is generally lethal. Affected patients require surgeries that allow the right ventricle to become the pump for the systemic circulation, with the lungs perfused from either a parallel right ventricular conduit or passively from the vena cava. Subaortic stenosis is caused by a thickened ring or collar of dense endocardial fibrous tissue below the level of the cusps. Supravalvular aortic stenosis is a congenital aortic dysplasia with thickening and constriction of the ascending aortic wall. Elastin gene mutations can cause supravalvular stenosis by disrupting elastin, smooth muscle cell interactions during aortic morphogenesis. Subaortic stenosis is usually associated with a prominent systolic murmur and sometimes a thrill. Pressure hypertrophy of the left ventricle develops as a consequence of the obstruction to blood flow. Unless very severe, the stenosis is generally well tolerated, although left ventricular hypertrophy still carries a risk of sudden cardiac death. Key concepts: congenital heart disease. CHE represents defects of cardiac chambers or the great vessels. These typically either result in shunting of blood between the right and left circulation or cause outflow obstruction. Lesions range from relatively asymptomatic to rapidly fatal. Environmental and genetic causes both contribute, and the manifestations depend on the timing of the environmental insult and which step in cardiac development is affected. Chapter 12: The heart. Left or right shunts are most common and are typically associated with ASD, VSD, or PDA. These lesions result in chronic right-sided pressure and volume overloads that eventually cause pulmonary hypertension with reversal of flow, and right-to-left shunts with cyanosis-Eisenmenger syndrome. Right-to-left shunts are most commonly caused by TOF or TGA. These are cyanotic lesions from the outset and are associated with polycythemia, peripheral cyanosis effects, and paradoxical emboli. Obstructive lesions include valve stenosis and aortic coarctation. The clinical severity of the lesion depends on the degree of stenosis and the patency of the ductus arteriosus. 542. Ischemic heart disease. IHE represents a group of related entities resulting from myocardial ischemia, an imbalance between myocardial supply perfusion and cardiac demand for oxygenated blood. Ischemia not only limits tissue oxygenation and thus ATP generation, but also reduces the availability of nutrients and the removal of metabolic waste. Chapter 2. Thus, cardiac ischemia is generally less well tolerated than hypoxemia per se, such as may occur with severe anemia, cyanotic heart disease, or advanced lung disease. In more than 90% of cases, myocardial ischemia results from reduced blood flow due to obstructive atherosclerotic lesions in the epicardial coronary arteries. Consequently, IHE is frequently referred to as coronary artery disease (CAD). In most cases, there is a long period up to decades of silent, slow progression of coronary lesions before the sudden onset of symptoms. Thus, IHE is often the late manifestation of coronary atherosclerosis that began during childhood or adolescence. Chapter 11. IHE can declare itself through one or more of the following clinical presentations: myocardial infarction (MI), in which ischemia causes frank cardiac necrosis; angina pectoris, literally chest pain, in which ischemia is not severe enough to cause infarction, but the symptoms nevertheless portend infarction risk; chronic IHD with heart failure, sudden cardiac death (SCD). In addition to coronary atherosclerosis, myocardial ischemia can be caused by coronary emboli, myocardial vessel inflammation, or vascular spasm. Moreover, otherwise modest coronary artery occlusions may become consequential in the setting of increased cardiac energy demand, for example, myocardial hypertrophy or increased heart rate, hypoxemia, or systemic hypotension, for example, shock. Some conditions can have multiple deleterious effects. Thus, tachycardia increases oxygen demand because of more contractions per unit time while decreasing functional supply by decreasing the relative time spent in diastole. When cardiac perfusion occurs, epidemiology, IHE is the single largest cause of mortality worldwide, accounting for over 12% of global deaths. In the industrialized nations, this amounts to over 7.5 million casualties each year. Even in low-income countries, advances in the treatment and prevention of infectious diseases and the increasing adoption of westernized diets is accelerating IHD incidence. It is predicted soon to become the leading cause of mortality there as well. At the same time, there is cause for optimism. Since peaking in the mid-1960 seconds, the overall death rate from IHD has fallen in the United States by over 50%. This remarkable improvement can be attributed to the following: prevention, achieved by modifying important risk factors, such as smoking, level of blood cholesterol, and hypertension. Additional risk reduction can occur through weight loss, exercise, and maintaining good glycemic control in diabetic patients. Diagnostic and therapeutic advances, allowing earlier and more effective treatments. The latter include cholesterol and inflammation-lowering drugs such as statins, thrombolysis for acute coronary occlusions, better medical management after MI, coronary angioplasty and stenting, coronary artery bypass graft cath surgery, and improved therapies for heart failure and arrhythmias using left VADs, implantable defibrillators, and cardiac resynchronization approaches. Even a simple daily prophylactic aspirin can have therapeutic benefit. Continuing this encouraging trend will be challenging, particularly in view of the increased longevity of baby boomers, which will lead to a doubling of individuals older than 65 years of age by 2050, and the obesity epidemic. New therapeutic advances will depend on understanding the genetic determinants of coronary atherosclerosis and IHD. Thus, the observation that MIs occur in only a fraction of individuals with coronary disease suggests that simple control of atherosclerotic risk factors is only part of the story. Pathogenesis: the dominant cause of IHD syndromes is insufficient coronary perfusion relative to myocardial demand. In the vast majority of cases, this is due to either of the following: chronic, progressive atherosclerotic narrowing of the epicardial coronary arteries, variable degrees of superimposed acute plaque change, thrombosis, and vasospasm. The individual elements and their interactions are discussed next. Chronic vascular occlusion: more than 90% of patients with IHD have atherosclerosis involving one or more of the epicardial coronary arteries, Chapter 11. Fixed lesion obstructing greater than 70% of vascular cross-sectional area, so-called critical stenosis, is typically cited as the threshold for symptomatic ischemia precipitated by exercise, characteristically manifesting as exertional angina. With this degree of obstruction, compensatory coronary arterial vasodilation is no longer sufficient to meet even moderate increases in myocardial demand. Obstruction of 90% of the cross-sectional area of the lumen generally leads to inadequate coronary blood flow, even at rest. Slowly developing obstructions induce the formation, heart disease 543, of collateral circulation that can mitigate the effects of even high-grade stenosis by allowing alternate channels to perfuse at-risk myocardium. Consequently, rather than just assessing the extent of local vascular stenosis, measurements of coronary flow across the stenosis flow reserves provide a better assessment of the consequences of fixed coronary artery occlusions, particularly when multifocal. Although only a single major coronary epicardial vessel may be affected, two or all three, the left anterior descending LAD, left circumflex LCX, and right coronary artery RCA, are often involved simultaneously by obstructive atherosclerosis. Clinically significant plaques can be located anywhere along the course of the vessels, although they tend to predominate within the first several centimeters of the LAD and LCX. Sometimes the major epicardial branches are also involved, i.e., LAD diagonal branches, LCX obtuse marginal branches, or posterior descending branch of the RCA. But atherosclerosis of the intramyocardial penetrating branches is rare. Thus, most atherosclerotic stenosis can be accessed by coronary catheterization. Acute plaque change: the risk of an individual developing clinically important IHD depends in part on the number, distribution, structure, and degree of obstruction by atheromatous plaques. However, the very clinical manifestations of IHD cannot be explained by the anatomic disease burden and fixed stenosis alone. This is particularly true for the so-called acute coronary syndromes, namely when unstable angina, acute MI, and sudden death are caused abruptly by acute plaque changes. These acute coronary syndromes are typically initiated by an unpredictable and sudden conversion of a stable atherosclerotic plaque to an unstable and potentially life-threatening atherothrombotic lesion through rupture, superficial erosion, ulceration, fissuring, or deep hemorrhage, collectively called acute plaque change, Chapter 11. In most instances, acute plaque changes, typically associated with intralesional inflammation, precipitate the formation of a superimposed thrombus that partially or completely occludes the artery. It remains to be seen whether aggressive anti-inflammatory regimens are means to reduce such acute coronary events. Consequences of myocardial ischemia: stable angina results from increases in myocardial oxygen demand that outstrip the ability of coronary arteries with fixed stenosis to increase oxygen delivery. It is usually not associated with plaque disruption. Unstable angina is caused by acute plaque change that results in thrombosis and/or vasoconstriction and leads to incomplete or transient reductions in coronary blood flow. In some cases, microinfarcts can occur distal to disrupted plaques due to thromboemboli. MI is often the result of acute plaque change that induces an abrupt thrombotic occlusion, resulting in myocardial necrosis. Sudden cardiac death may be caused by regional myocardial ischemia that induces a fatal ventricular arrhythmia. This can result from a fixed stenosis or acute plaque change. Each of these important syndromes is discussed in detail next, followed by an examination of the important myocardial consequences. Ischemic. Angina pectoris is characterized by paroxysmal and usually recurrent attacks of substernal or precordial chest discomfort caused by transient 15 seconds to 15 minutes myocardial ischemia that is insufficient to induce myocyte necrosis. The anginal pain is a consequence of the ischemia-induced release of adenosine, bradykinin, and other molecules that stimulate sympathetic and vagal afferent nerves. 3 overlapping patterns of angina pectoris are recognized, caused by varying combinations of decreased perfusion, increased demand, and coronary arterial pathology. Importantly, not all ischemic events are perceived by patients. Silent ischemia is particularly common in the geriatric population and in the setting of diabetic neuropathy. Stable typical angina is the most common form of angina. It is caused by an imbalance in coronary perfusion due to chronic stenosis and coronary atherosclerosis relative to myocardial demand. Stable angina does not occur at rest, but in a given patient can be reliably induced by activities that increase the energy requirements of the heart, including physical activity, emotional excitement, or psychological stress. Angina pectoris is classically described as a crushing or squeezing substernal sensation that can radiate down the left arm or to the left jaw, referred pain. The pain is usually relieved by rest, decreasing demand, or by administering vasodilators, such as nitroglycerin and calcium channel blockers, thereby increasing perfusion. Transmetal variant angina is an uncommon form of episodic myocardial ischemia caused by coronary artery spasm. Although individuals with transmetal variant angina can also have significant coronary atherosclerosis, the anginal attacks are unrelated to physical activity, heart rate, or blood pressure, and can occur at rest. Transmetal angina generally responds promptly to vasodilators. Unstable or crescendo angina refers to a pattern of increasingly frequent, prolonged 20-minute, or severe angina, precipitated by progressively lower levels of physical activity or even occurring at rest. Unstable angina is associated with plaque disruption and superimposed thrombosis, distal embolization of the thrombus, and / or vasospasm. It is an important harbinger of MI, potentially portending complete vascular occlusion. Myocardial infarction, MI, also commonly referred to as heart attack, is the death of cardiac muscle due to prolonged ischemia. Roughly 1.5 million individuals in the United States suffer an MI each year, causing approximately 610,000 deaths annually. The major underlying cause of IHD is atherosclerosis. Although MIs can occur at virtually any age, 10% of MIs occur in people younger than 40 years of age, and 45% occur in people younger than 65 years of age. Nevertheless, the frequency rises progressively with increasing age and with increasing atherosclerotic risk factors. Chapter 11. Through middle age, male gender increases the relative risk of MI. Indeed, women are generally protected against MI during their reproductive years. However, postmenopausal decline in estrogen production is usually associated with accelerated CAD, and IHD is the most common cause of death in older. Chapter 12. The heart. Women. Unfortunately, postmenopausal hormonal replacement therapy has not been shown to be protective, and in fact, in some cases, may be detrimental. Pathogenesis: coronary arterial occlusion. The following sequence of events likely underlies most MIs. See Chapter 11 for additional details. An atheromatous plaque is eroded or suddenly disrupted by endothelial injury, intraplaque hemorrhage, or mechanical forces, exposing subendothelial collagen and necrotic plaque contents to the blood. Platelets adhere, aggregate, and are activated, releasing thromboxane ADPO, adenosine diphosphate ADP, and serotonin, causing further platelet aggregation and vasospasm. Chapter 4. Activation of coagulation by tissue factor and other mechanisms adds to the growing thrombus. Within minutes, the thrombus can evolve to completely occlude the coronary artery lumen. The evidence for this scenario derives from autopsy studies of patients dying of acute MI, as well as imaging studies demonstrating a high frequency of thrombotic occlusion early after MI. Interestingly, comparison to prior angiograms shows that these thrombi are usually at a site that did not previously have a critical 70% fixed stenosis. Typically, when angiography is performed within 4 hours of the onset of MI, it demonstrates coronary thrombosis in almost 90% of cases. However, when angiography is performed 12 to 24 hours after onset of symptoms, evidence of thrombosis is seen in only 60% of patients, even without intervention. Thus, At least some occlusions clear spontaneously through lysis of the thrombus or relaxation of spasm. This sequence of events in a typical MI also has therapeutic implications. Early thrombolysis and or angioplasty can be highly successful in limiting the extent of myocardial necrosis. In approximately 10% of cases, MI occurs in the absence of the typical coronary atherothrombosis. In such situations, other mechanisms may be responsible for the reduced coronary blood flow. Vasospasm with or without coronary atherosclerosis, perhaps in association with platelet aggregation or due to drug ingestion, for example, cocaine or ephedrine. Emboli from the left atrium in association with atrial fibrillation, a left-sided mural thrombus. Vegetations of infective endocarditis, i.e., intracardiac prosthetic material, or paradoxical emboli from the right side of the heart or the peripheral veins traversing a patent foramen ovale and into the coronary arteries. And common causes of MI without atherothrombosis include disorders of small intramural coronary vessels, for example, vasculitis, hematologic abnormalities, for example, sickle cell disease, amyloid deposition in vascular walls, vascular dissection, marked hypertrophy, for example, due to aortic stenosis, lowered systemic blood pressure, for example, shock, or inadequate myocardial protection during cardiac surgery. Myocardial response. Coronary arterial obstruction diminishes blood flow to a region of myocardium, causing ischemia, rapid myocardial dysfunction, and eventually, with prolonged vascular compromise, myocyte death. The anatomic region supplied by that artery is referred to as the area at risk. The outcome depends predominantly on the severity and duration of flow deprivation. Fig. 12.9. The early biochemical consequence of myocardial ischemia is the cessation of aerobic metabolism within seconds, leading to inadequate production of high-energy phosphates, for example, creatine phosphate and adenosine triphosphate, and accumulation of potentially noxious metabolites, for example, lactic acid. See Fig. 12.9a. Because of the exquisite dependence of myocardial function on oxygen and nutrients, myocardial contractility ceases within a minute or so of the onset of severe ischemia. Such loss of function contributes to decreased systolic function long before myocyte death occurs, as detailed in Chapter 2. Ultrastructural changes including myofibrillar relaxation, glycogen depletion, cell and mitochondrial swelling also develop within a few minutes. Units arbitrary, lactate and ad. 6 onset of irreversible injury. 5 lactate. 4 3 2 at 1 0 0 5 10 15 20 30 40 50 minutes. Myocardium fraction at risk of 180 60 40 20 123,456 12 18. A B time hours. Figure 12.9 temporal sequence of early biochemical findings and progression of cardiomyocyte necrosis after onset of severe myocardial ischemia. Early changes include loss of adenosine triphosphate ATP and accumulation of lactate. B for approximately 30 minutes after the onset of even the most severe ischemia, myocardial injury is potentially reversible. Thereafter, progressive loss of viability occurs that becomes complete by 6 to 12 hours. The benefits of reperfusion are greatest when it is achieved early and are progressively lost when reperfusion is delayed. Originally modified with permission from Antman E. Acute myocardial infarction. And Bronwald E. et al. Editors, Heart Disease, A Textbook of Cardiovascular Medicine, ed. 6, Philadelphia, 2001, W.B. Saunders, pp. 1114, 1231, 544. 0. Phase reversible, phase irreversible. Ischemic myocardium potentially salvageable by timely intervention. Cumulative dead myocardium. Ischemic heart disease 545. Of the onset of ischemia. Nevertheless, these early manifestations of ischemic injury are potentially reversible. Indeed, experimental and clinical evidence shows that only severe ischemia blood flow 10% or less of normal lasting 20 to 30 minutes or longer leads to irreversible damage necrosis of cardiac myocytes. This delay in the onset of permanent myocardial injury provides the rationale for rapid diagnosis in acute MI, to permit early coronary intervention to establish reperfusion and salvage as much at-risk myocardium as possible. The earliest detectable feature of myocyte necrosis is disruption of the integrity of the sarcomal membrane, allowing intracellular macromolecules to leak out of necrotic cells into the cardiac interstitium and ultimately into the microvasculature and lymphatics. This escape of intracellular myocardial proteins into the circulation forms the basis for blood tests that can sensitively detect irreversible myocyte damage and are important for managing the MIC later. With prolonged severe ischemia, injury to the microvasculature follows injury to the cardiac myocytes. The temporal progression of these events is summarized in Table 12.4. Table 12.4 Approximate time of onset of key events in ischemic cardiac myocytes. Feature: onset of ATP depletion, loss of contractility, ATP reduced to 50% of normal to 10% of normal, irreversible cell injury, microvascular injury, adenosine triphosphate, time seconds, 2 minutes, 10 minutes, 40 minutes, 20-40 minutes, hour. The progression of ischemic necrosis in the myocardium is summarized in Fig. 12.10. Irreversible injury of ischemic myocytes first occurs in the subendocardial zone. This region is especially susceptible to ischemia because it is the last area to receive blood delivered by the epicardial vessels, and also because it is exposed to relatively high intramural, right coronary artery, aorta, pulmonary artery, left circumflex coronary artery, left anterior descending coronary artery, acute coronary arterial occlusion, cross section of myocardium, obstructed coronary artery, endocardium, zone of perfusion, area at risk, zone of perfusion, area at risk, zone of necrosis, completed infarct involving nearly the entire area at risk, 0 HR 2 HR 24 HR. Figure 12.10 Progression of myocardial necrosis after coronary artery occlusion. Necrosis begins in a small zone of the myocardium beneath the endocardial surface in the center of the ischemic zone. The area that depends on the occluded vessel for perfusion is the at-risk myocardium shaded. Note that a very narrow zone of myocardium immediately beneath the endocardium is spared from necrosis because oxygen and nutrition can be provided by diffusion from the ventricle. 546 Chapter 12 The heart pressures, which act to impede the inflow of blood. With more prolonged ischemia, a wave of cell death moves through other regions of the myocardium, driven by progressive tissue edema and myocardial-derived reactive oxygen species and inflammatory mediators. The location, size, and specific morphologic features of an acute MI depend on the following: the location, severity, and rate of development of coronary obstructions due to atherosclerosis and thrombosis, the size of the vascular bed perfused by the obstructed vessels, the duration of the occlusion, the metabolic and oxygen needs of the myocardium at risk, the extent of vascular collateralization, the presence, site, and severity of coronary arterial spasm. Other factors, such as heart rate, cardiac rhythm, and blood oxygenation. An infarct usually achieves its full extent within 3 to 6 hours. In the absence of intervention, an infarct caused by occlusion of an epicardial vessel can involve the entire wall thickness transmural infarct. Clinical intervention within this critical window of time can lessen the size of the infarct within the territory at risk. Patterns of infarction. The distribution of myocardial necrosis correlates with the location and cause of the decreased perfusion. Fig. 12.11. Knowledge of the areas of myocardium perfused by the major coronary arteries allows correlation of specific vascular obstructions with their corresponding areas of MI. Typically, the LAD branch of the left coronary artery supplies most of the apex of the heart, the anterior wall of the left ventricle, and the anterior 2/3 of the ventricular septum. By convention, the coronary artery, either RCA or LCX, that perfuses the posterior third of the septum is called dominant, even though the LAD and LCX collectively perfuse the majority of the left ventricular myocardium. In a right dominant circulation present in approximately 80% of individuals, the RCA supplies the entire right ventricular free wall, the posterobasal wall of the left ventricle, and the posterior third of the ventricular septum, and the LCX generally perfuses only the lateral wall of the left ventricle. Thus, RCA occlusions can potentially lead to left ventricular damage. Although most hearts have numerous intercoronary anastomosis collateral circulation, relatively little blood normally courses through these. However, when a coronary artery is progressively narrowed over time, blood flows via the collaterals from the high to the low pressure circulation, causing the channels to enlarge. Through such progressive dilation and growth of collaterals, stimulated by ischemia, blood flow is provided to areas of myocardium that would otherwise be deprived of adequate perfusion. Indeed, in the setting of extensive collateralization, The normal epicardial perfusion territories may be so expanded that subsequent occlusion leads to infarction and paradoxical distributions. Transmural infarctions occur when there is occlusion of an epicardial vessel in the absence of any therapeutic intervention. The necrosis involves virtually the full thickness of the ventricular wall and the distribution of the affected coronary. This pattern of infarction is usually associated with a combination of chronic coronary atherosclerosis, acute transmural infarcts, non-transmural infarcts, restoration of flow-ward perfusion, permanent occlusion of left anterior descending branch, transient/partial obstruction, regional subendocardial infarct, posterior, permanent occlusion of left circumflex branch, permanent occlusion of right coronary artery or its posterior descending branch, RVLV, anterior, global hypotension circumferential subendocardial infarct, small intramural vessel occlusions microinfarcts. Figure 12.11 distribution of myocardial ischemic necrosis correlates with the location and nature of decreased perfusion. F. The positions of transmural acute infarcts resulting from occlusions of the major coronary arteries, top to bottom, left anterior descending, left circumflex, and right coronary arteries. Right. The types of infarcts that result from a partial or transient occlusion, global hypotension, or intramural small vessel occlusions. Ischemic heart disease 547. Plaque change and superimposed thrombosis discussed earlier. Subendocardial non-transmural infarctions can occur as a result of a plaque disruption followed by a coronary thrombus that becomes lyased therapeutically or spontaneously before myocardial necrosis extends across the full thickness of the wall. Subendocardial infarcts can also result from prolonged, severe reduction in systemic blood pressure, as in shock superimposed on chronic, otherwise non-critical, coronary stenosis. In the subendocardial infarcts that occur as a result of global hypotension, myocardial damage is often circumferential, rather than being limited to the distribution of a single major coronary artery. Multifocal microinfarction refers to a pattern that is seen when there is pathology involving only smaller intramural vessels. It can occur in the setting of microembolization, vasculitis, or vascular spasm, for example, due to endogenous catecholamines, epinephrine, or drugs cocaine or ephedrine. Elevated levels of catecholamines also increase heart rate and myocardial contractility, exacerbating ischemia caused by the vasospasm. The outcome of such vasospasm can be sudden cardiac death, usually caused by a fatal arrhythmia or an ischemic dilated cardiomyopathy discussed later. Morphology. The temporal evolution of the morphologic changes in acute MI and subsequent healing are summarized in Table 12.5. Nearly all transmural infarcts involve at least a portion of the left ventricle comprising the free wall and ventricular septum. They encompass nearly the entire perfusion zone of the occluded coronary artery, save for a narrow rim approximately 0.1 mm of viable subendocardial myocardium that is preserved by diffusion of oxygen and nutrients from the ventricular lumen. The frequencies of involvement of each of the three main arterial trunks and the corresponding sites of myocardial lesions resulting in infarction in the typical right dominant heart are as follows. Left side of Fig. 12.11. Left anterior descending coronary artery 40% to 50%. Infarcts involving the anterior wall of left ventricle near the apex, the anterior portion of ventricular septum, and the apex circumferentially. Right coronary artery 30% to 40%. Infarcts involving the inferior/posterior wall of the left ventricle, posterior portion of ventricular septum, and the inferior/posterior right ventricular free wall in some cases. Left circumflex coronary artery 15% to 20%. Infarcts involving the lateral wall of the left ventricle except at the apex. Other locations of critical coronary arterial lesions causing infarcts are sometimes encountered, such as the left main coronary artery, the secondary diagonal branches of the left anterior descending coronary artery, or the marginal branches of the left circumflex coronary artery. MI is caused by right coronary obstruction. 15% to 30% extend from the posterior free wall of the septal portion of the left ventricle into the adjacent right ventricular wall. Isolated infarction of the right ventricle is unusual, only 1% to 3% of cases, as is infarction of the atria. The gross and microscopic appearance of an infarct depends on the interval of time between the MI and death. Damaged myocardium undergoes a progressive sequence of morphologic changes involving typical ischemic coagulative necrosis, the predominant mechanism of cell death in MI, although apoptosis. Table 12.5 of morphologic changes in myocardial infarction time gross features like microscope reversible injury 0, 1 2 hour none irreversible injury 1 4 hours 2 none usually none variable waviness of fibers at border early coagulative necrosis edema hemorrhage ongoing coagulative necrosis pycnosis of nuclei myocyte hypereosinophilia marginal contraction band necrosis early neutrophilic infiltrate, coagulative necrosis, with loss of nuclei and striations, brisk interstitial infiltrate of neutrophils, beginning disintegration of dead myofibers with dying neutrophils, early phagocytosis of dead cells by macrophages at infarct border, well-developed phagocytosis of dead cells, granulation tissue at margins, well-established granulation tissue with no blood vessels and collagen deposition, increased collagen deposition with decreased cellularity, collagen scar evolution. 4. 12 hours 12. 24 hours. Dark modeling occasional. Dark modeling. 1. 3 days modeling with yellow tan infarct. Center 3. 7 days hyperemic border. Central. Yellow tan softening. 7. 10 days maximally yellow tan and soft. With depressed red tan margins. Red-gray depressed infarct borders. 10. 14 days. 2. 8 weeks gray-white scar. Progressive from border toward core of infarct. Scarring complete. 2 months. Electron microscope. Relaxation of myofibrils. Glycogen loss. Mitochondrial swelling. Sarcomal disruption. Mitochondrial amorphous densities. 548 Chapter 12 The heart can also occur. This is followed by stereotypical inflammation and repair that parallels responses to injury in other tissues. Chapter 2. Early morphologic recognition of acute MI can be difficult, particularly when death occurs within only a few hours of symptom onset. MIs less than 12 hours old are usually not apparent on gross examination alone. However, if the infarct preceded death by at least 2 to 3 hours, it is possible to highlight the area of necrosis by immersion of tissue slices in a solution of triphenyl tetrazolium chloride. This gross histochemical stain imparts a brick red color to intact, non-infarcted myocardium with preserved lactate dehydrogenase activity. Because dehydrogenases leak out through the damaged membranes of dead cells, an infarct appears as an unstained pale zone Fig. 12.12. By 12 to 24 hours after infarction, an MI can usually be identified grossly as a reddish-blue area of discoloration caused by congestion and extravasated blood. By 3 to 7 days, it is rimmed by a hyperemic zone of highly vascularized early wound healing granulation tissue. Thereafter, the infarct becomes progressively more sharply defined, yellow tan, and soft. Over the succeeding weeks, the injured region evolves to a fibrous scar. The histopathologic changes also proceed in a fairly predictable sequence. Fig. 12.13. The typical changes of coagulative necrosis become detectable in the first 6 to 12 hours. Wavy fibers may. Figure 12.12 acute myocardial infarct, predominantly of the posterolateral left ventricle, demonstrated histochemically by a lack of staining by triphenyl tetrazolium chloride in areas of necrosis arrow. The staining defect is due to the lactate dehydrogenase leakage that follows cell death. Note the myocardial hemorrhage at one edge of the infarct that was associated with cardiac rupture, and the anterior scar arrowhead, indicative of an old infarct. The specimen is oriented with the posterior wall at the top. A BCDE, figure 12.13 microscopic features of myocardial infarction and its repair. A one-day-old infarct showing coagulative necrosis and wavy fibers elongated and narrow, as compared with adjacent normal fibers at right. Widened spaces between the dead fibers contain edema fluid and scattered neutrophils. B-des polymorphonically leukocytic infiltrate in an acute myocardial infarction that is 3 to 4 days old. The removal of necrotic myocytes by phagocytosis approximately 7 to 10 days. Degranulation tissue characterized by loose collagen and abundant capillaries. Healed myocardial infarct in which the necrotic tissue has been replaced by a dense collagenous scar. The residual cardiac muscle cells show evidence of compensatory hypertrophy. E and E are stained with mastose trichome, rendering collagenous connective tissue a deep blue color. Note the accumulation of extracellular matrix density of blue stain between the early granulation tissue and the subsequent dense scar. Ischemic heart disease 549, be present at the periphery of the infarct, resulting from the contractions of viable myocardium that cause the stretching and buckling of adjacent non-contractile dead fibers. An additional suboptimal ischemic change may be seen in the margins of infarcts. The so-called myocyte vacuolization reflects intracellular accumulations of salt and water within the sarcoplasmic reticulum and marks myocytes that are viable but poorly contractile. Necrotic myocardium elicits acute inflammation typically most prominent 1 to 3 days after MI, followed by a wave of macrophages that remove necrotic myocytes and neutrophil fragments most pronounced 3 to 7 days after MI. The infarcted zone is progressively replaced by granulation tissue most prominent 7 to 10 days after MI, which in turn forms the provisional scaffolding on which dense collagenous scar forms. Because cardiac myocytes are terminally differentiated cells, no cardiomyocyte proliferation is seen. In most instances, scarring is well advanced by the end of the 6th week, but the efficiency of repair depends on the size of the original lesion and the ability of the host tissues to heal. Healing requires the migration of inflammatory cells and ingrowth of new vessels from the infarct margins. Thus, an MI heals from its borders toward the center, and a large infarct may not heal as fast or as completely as a small one. Moreover, malnutrition, poor vasculature, or exogenous anti-inflammatory steroids can impede effective infarct scarring. Chapter 3. Once an MI is completely healed, it is impossible to distinguish its age, whether present for 8 weeks or 10 years. Fibrous scars look the same. The following discussion considers the changes that result from interventions that can limit infarct size by salvaging myocardium that is not yet necrotic. Infarct modification by reperfusion. The therapeutic goal in acute MI is to salvage the maximal amount of ischemic myocardium. This is accomplished by restoration of tissue perfusion as quickly as possible, hence the average time is myocardium. Such reperfusion is achieved by thrombolysis, dissolution of thrombus by a tissue plasminogen activator, angioplasty, or coronary arterial bypass graft. Unfortunately, although preservation of viable but at-risk heart can improve both short and long-term outcomes, reperfusion is not an unalloyed blessing. Indeed, late restoration of blood flow into ischemic tissues can be associated with arrhythmias and can incite greater local damage than might otherwise have occurred. So-called reperfusion injury. The effects of reperfusion on myocardial viability and function are summarized in Fig. 12.14. Although the clinical significance of myocardial reperfusion injury is debated, it has been estimated that up to 50% or more of the ultimate infarct size can be attributed to its effects. To date, clinical trials to prevent reperfusion injury have not been fruitful, but this remains an active area of investigation. Factors that contribute to reperfusion injury include the following. Mitochondrial dysfunction. Ischemia alters the mitochondrial membrane permeability, which allows proteins to move into the mitochondria. This leads to swelling and rupture of the outer membrane, releasing mitochondrial contents that promote apoptosis.